nerve head and its relationship with the sacral canal, the lamina cabrosa, the blood vessels, the orientation of the optic nerve head, and any congenital anomalies. So all these things have to be kept in mind, and the anatomy should be kind of well understood. There are many reasons. There are many ways of looking at optic disc evaluation there for glaucoma, but my approach is simple. Look at what is the most important structure in the eye. So, and we know from vision point of view and from glaucoma point of view is the neural tissue, which is the most important. And neural tissue is formed by the neural rim and the nerve fiber layer. So pay attention to neural rim and the nerve fiber layer and look at very carefully. So when you are looking at the optic nerve head, mentally dissect the neural tissue and then see whether it's normal or does it have any abnormality. Now, glaucomatous optic nerve damage has certain characteristic patterns, and as you start looking for them, the patterns, they become more familiar and you start recognizing them more and more. This is just to remind you that we human beings as a species are very good in recognizing patterns. We see a lot of people every day, we see a lot of new faces, and we recognize them almost immediately. So this same thing happens to some extent with glaucoma diagnosis also. Those people who are looking at glaucomatous discs on a, almost on a daily basis, it becomes easy for them to recognize these patterns. So practice is the key here. Another early is that be aware of the common errors and their impact on the diagnosis of glaucoma. Now, failure to consider disc size, for example, while assessing the neuroretinal rim could lead to error in the diagnosis. The larger discs, they will have a tendency for overestimation, whereas smaller discs, they will have a tendency for underdiagnosis. It has been seen that missing neuroretinal rim notch, nerve fiber defect, or a disc hemorrhage is often associated with underdiagnosis. So pay attention to these signs, specifically when you are looking for a glaucoma evaluation for glaucoma. Also, peripapilar atrophy is sometimes associated, is often associated with glaucoma, but all PPA is not glaucoma. So sometimes there could be a bias towards overdiagnosis if you're depending more on PPA. The next pearl is that be aware of the frequently missed glaucomatous phenotypes. Now, some of the glaucoma subtypes are more prone to underdiagnosis, and on top of the list I have put is angle closure glaucoma, because this is very common in our country. And angle closure disease in the early phase, when the pressure is not gone up, chronically it's not elevated, you may have a normal pressure when the patient visits you, but these patients have high IOP fluctuations, and next time patient can come with a significant optic nerve damage. Similarly, normal tension glaucoma, pseudoaxial glossa, and pigmentous persistent trauma, and some other phenotypes, they can be easily missed if you're not careful. So you have to do a good anterior segment examination as well as posterior segment examination, disc evaluation to get these patients. And lastly, the last tip is to use technology to your advantage. I would say to the patient's advantage, actually. This might be required to confirm the diagnosis, a good documentation of your findings, and subsequently monitoring and follow-up. At least you will need a visual field charting if you have nothing else, but if you have an OCT, that will add to your diagnostic accuracy and confidence. And many more things are actually happening in this field. So, keep your eye open and whatever is available to you and how best that can be used for your patients. But the minimum would be that do a very good clinical examination, follow a good practice, clinical practice, and have visual fields done at least. And with these things, you would be able to treat, to pick up most of these patients and reduce the likelihood of missing glaucoma. So to summarize, glaucoma is largely undiagnosed disease in our country to the tune of 90%. In the clinic also, it's often to miss glaucoma unless you're careful. So pay attention to the individuals who are at high risk, adopt good clinical practices. Optic nerve evaluation is the key skill, and it must be learned and must be taught. And this takes time and patience to develop this skill, and be aware of the pitfalls in the diagnosis. So once we keep all these things in mind, we can reduce our chances of missing glaucoma in our clinical practice. Thank you very much once again for this opportunity to talk to you. Thank you.
Thank you so much, Dr. Pandav and Dr. Jayant, for your wonderful presentations. We'll now be starting with our panel discussion, and I invite my expert panelists, Dr. Devan Tully, Dr. Suresh Kumar, Dr. Vineet Ratra, Dr. Sirisha Senthil, and Dr. Vinita Pathak Ray. So I'll be starting with my first question. Let me just do the screen share. So sorry. Yes, my first question is to Dr. Devan Tuli. So can, sir, we start glaucoma treatment only on the basis of increased intraocular pressure? Dr. Devan, please. Dr. Devan?
Is he mute?
They're not able to hear you. Just
No, I think I'm audible, sir.
Yes, ma'am, you are audible.
Yeah, I'm audible.
Dr. Deven, I'm not able to see him. You can pose that question to somebody else for the time being.
Okay. Yeah, Dr. Suresh Kumar, then can you answer the question?
Yes, Dr. Shikha. Thank you for the invitation, and I'm really feeling good to be in company of such great glaucoma specialist. The question is, can glaucoma treatment be initiated only on the basis of increased IOP? So we do see patients in our clinic who have been started on anti-glaucoma medication on the basis of just one reading of eye intraocular pressure. So I will like to split this question into two situations. First situation is when this high intraocular pressure recording is by any tonometer. So like so many times, everybody doesn't have Goldman applanation tonometer in our private practice. So sometimes just on the basis of non-contact tonometer reading, so reading of 25 or more than 20, and the anti-glaucoma therapy has been started. So we have to give a clear message to the audience that the first thing is to know the accuracy of recording of intraocular pressure. So the gold standard for that is Goldman applanation tonometer. So if this recording of eye intraocular pressure is just on non-contact tonometer or any other tonometer, shots is still being used by some people in the periphery. So that higher reading doesn't carry any value. So first thing is pressure has to be checked by accurate tonometer, and gold standard for this in glaucoma diagnosis and management is your Goldman applanation tonometer. So now second situation is if IOP is high on Goldman applanation tonometer. So that is true high intraocular pressure. In that situation also, just one reading of eye pressure, sometimes we have to confirm it with another tonometer, and if it is consistently high intraocular pressure on Goldman applanation tonometer, and rest of the things are normal, fields are normal, your OCT is normal, disc evaluation shows normal disc, so then probably you are dealing with a patient of ocular hypertension. Then as per the ocular hypertension treatment study, we can plan treatment of that patient, but otherwise just on the basis of high reading of intraocular pressure, maybe one or more, we should not be subjecting patient to anti-glaucoma medication, because all these medications have sequelae, have side effects, the cost is involved.
Thank you so much. That was wonderfully elaborated. Now the second question. Nikhil, please.
Yeah, this I would like to ask Dr. Sirisha that in her practice, which is the tonometer of choice for her, and keeping in mind, like Dr. Suresh said, Goldman applanation tonometer is the gold standard, but even it has several sources of error, like somebody has tight lids, somebody has deep set eye. Then even Goldman can have error, and one should be careful about taking a correct reading. And it is a good idea that you confirm it from another instrument, like Dr. Suresh Kumar said. So I'd like to ask Dr. Sirisha, which tonometer does she prefer?
Thanks, Nikhil. So I think by and large, Goldman applanation tonometer is what we use as a gold standard. Having said that, we do realize that a Goldman applanation tonometer in certain clinical conditions does not give you accurate readings. And also in children, it is not possible to use. So in adults, I would say, what are the conditions where you are unlikely to get accurate readings with Goldman applanation tonometer? Let's say it's a post LASIK eye or a post PK or a DSEK eye where you have irregular corneas and things like that. So an alternate tonometer can be used. It could be a tonopen. It could be a eye care tonometer. We should remember that these conditions with ocular surface abnormalities or those with corneal problems, definitely there will be some error in the recording. Of course, the treatment will depend not just on the IOP, but also on the other factors of disc evaluation and things like that. But having said that, when there is a discrepancy, the other tonometers, especially the tonopen, the eye care, is something that we use routinely. In one condition where we cannot do any of these estimations, for example, in patients, let's say with keratoprosthesis, it's not uncommon for us to see patients with type 1 keratoprosthesis today, and most of them keep a follow-up with specialists across the country. So in situations like that, even a finger tension tonometry, where we know it's not ideal, but can be used, and sometimes Shiots could be something that is very much better off compared to other tonometers on the sclera, because the cornea is not normal and it is a prosthetic cornea in these patients. So the answer is not simple. If there was one ideal tonometer, then I think we will not have so many tonometers. The fact that you have so many, it tells you that there is some fallacy in one, and one has an advantage over the other.
Nice, nice. So if I gather that you mean to say that for our all routine clinical care, you mean to stick to Goldman applanation tonometer, and other situation that you said there you prefer other tonometers. Very well explained. But I put the eye care there for some purpose, because the question is, I know that you are doing some studies on eye care, and the question is, knowing the limitations of GAT in the routine clinical practice, say your cornea is clear. Do you think that eye care is a futuristic instrument?
Yeah, so eye care, I think the one that we have now, IC200, is a combination of the typical eye care, the IC100 that we had earlier, and the eye care Pro. So the one that we have now, IC200, is quite a good tonometer. In fact, we have recently published the agreement between the eye care and the Goldman applanation tonometer. And on average, the mean difference between the two tonometers was less than about 1.5 millimeters of mercury, and limits of agreement were less than 3 on either sides, which means it is agreeable. Of course, especially in children, I think it is very, very useful. I would say that the number of EUAs that I used to do for kids earlier, maybe 3 years ago versus now, has come down by almost 75%. Most of the time we can actually check the intraocular pressures in children in the clinic itself. So that is very, very helpful. And another study that we did as to how it compares with Perkins as well as with the Goldman applanation tonometer in children, we found that if the intraocular pressure with eye care is 19 millimeters of mercury or less, it agrees very well with Goldman applanation tonometer. Almost there is no difference. If the intraocular pressure recorded by eye care is on the higher side, then we definitely need to reconfirm it either with Perkins or Goldman applanation tonometer. So eye care has a role to play both in the children as well as in adults. We also did the study in adults as well. But in children, why I'm mentioning this is because the adults, most of the time, we are comfortable using Goldman applanation tonometer, but kids, we have to treat them intraocular pressure should become a part of their evaluation. And I think one of the difficulties that we used to have earlier was it is difficult to do the current conventional tonometry on them. So that way, eye care, I think, is very, very useful.
Very nice, Dr. Sirisha. I just want to reiterate that we do not have any financial interest in eye care. It is interested in the technology. So with this, we can move ahead.
Sorry, can I make a point here? NCT is coming up.
Yes.
Basically, yeah. There is a pandemic of NCT, and that is what the message has to go out that, NCT is not the be all and the cure all for glaucoma. Anyway, go ahead, please. Sorry.
Fine. Vanita, just to answer, we are aware that NCT is used very frequently. So my question to Dr. Vineet is, can we use NCT in the diagnosis and management of glaucoma? Dr. Vineet?
Yeah, thanks. Thanks, Dr. Mathur, Shikha, and Nikhil for having me over. Well, no. In one word, no. NCT can't be used in the diagnosis and management of glaucoma. I think we've just gone through what all the speakers, Dr. Jain, Dr. Pandav, Suresh, and even Nikhil said, and Dr. Shrisha, that probably applanation is still the gold standard. NCT is more a screening when you want to do it, but on a routine basis, it should probably be the applanation. So NCT, no.
Fine. Thank you, Vineet, for a very definite no to take NCT as the initial measurement and diagnosis and management in glaucoma. Going to the next question, Dr. Nikhil.
This I would like to ask Dr. Vanita. Now, once we are clear with which instrument we are using to do IOP, how do you use this concept of target IOP? Do you set a number? Do you set a range? And how do you work on the concept?
Yeah, thanks, Nikhil. Well, target IOP can be as complex as you want to make it, or as simple as you want to make it in your own clinical practice. So based on its definition that it is an IOP at which we presume that no further retinal ganglion cell loss is taking place, it is that IOP which sort of more or less parallels the age-related loss, looks like the age-related loss rather than an accelerated loss due to not going into the complexities of how it evolved. I would say there is a fairly good guideline from the American Academy saying that when you have advanced glaucoma, you reduce it at least by 40%. And such tight control is not required if you have ocular hypertension, so on and so forth. These are all available as, on the net quite freely. So I don't think I need to reiterate that. But what I do is that even if I set a target IOP, it can never be a IOP. It has to be a range. It has to be, early to mid-teens, mid to high teens, and high teens to 20. That is the kind of scenario in the real world. You will never get one IOP value throughout the day. So you have to have a range. And the best way, I feel, to set a target IOP is actually only in retrospect. When you followed up the patient for a while and have done their visual fields on a regular basis, and if it has not progressed, then whatever your target IOP, that was obviously accurate enough. If the patient has progressed, then obviously your target IOP was off. So you have to consider other interventions, adding medication, whatever, that based on the clinical scenario. So yes, I would say it's at best a guesstimate in the real world scenario, and it needs to be periodically assessed. You cannot just put a target IOP for a particular patient and stick by it in a fastidious fashion. The other thing I would like to mention is I never put down the target IOP in the folder. Never. It's a medical legal problem. Patients can get hold of your folder and that can lead to problems. So the best thing is, in advanced glaucoma, obviously you want it in low to mid-teens. In not, early glaucoma, ocular hypertension, you can tolerate higher pressures. And that is what I keep in mind.
So when you say periodic, that's very appropriate. I would like to bring you to one dilemma where what happens is a patient presents with a quite high pressure. So you start your treatment, you're titrating your treatment, your IOP has reduced by a certain percentage. That percentage reduction may be more than 30%, but you have still not reached your so-called target IOP range. So how would you address that dilemma? On one hand, you have
There,
reached it by a significant percentage, but on the other hand, you are still not reached.
True. See, when we are in a real world scenario, very rarely do we come across pressures which are 40s and 50s. Yes, you can get that in angle closure, you can get that in secondary glaucomas, but where open angle is concerned, and definitely in NTG, you will not get such high pressures. That is where you use this kind of percentage reduction, so to speak. But yes, you have to come to a number as well, or a range of numbers where you would like your patient to be.
Is Dr. Devan there?
Very much there, very much there.
All right, Dr. Devan. So my question to you, what is the importance we give to the systemic comorbidities before we initiate our glaucoma management?
Oh, I think it's a must to record all such comorbidities in the first visit, because I think a common scenario that I see in my practice in Delhi is that a lot of the general ophthalmologists are keeping the patients on timolol with known respiratory and asthma. So they don't even bother. The patient is kept on timolol. He's using further steroids because of timolol for the breathing condition. So that's an important one which is missed often. With hypertension, I think it's important to know that if you could give a beta blocker topical, then it's important to know if the patient is not taking a systemic beta blocker. So that is something which we should keep in mind. There are other issues with, say, diabetes, where again, timolol is a relative contraindication, where, it sometimes can mask the hypoglycemia part of a diabetic. So these are the three common scenarios. With timolol also, as I'll also present in my small set of slides today, we need to also understand whether the patient is on hyperlipidemias, because beta blockers are used very often in my part of practice, and they are used at times without even knowing it. Then hyperlipidemias may be worsened with beta blockers. Similarly, with depression is so common in our scenario, where it can also be worsened, depression, hallucinations with beta blockers. So those were the things I had in mind. The other ones, maybe the others can add to this. I think beta blocker is excellent drug. I have nothing against it, but we need to keep the comorbidities in mind.
Absolutely. And I was thinking in diabetics, it's more important for the newly diagnosed diabetics that we are careful starting with the topical beta blockers rather than the well-established diabetics, but we still need to keep that in mind.
Yes.
Thank you. Thank you.
I would like to again go back to Dr. Sirisha, because LVP is maybe the center or one of the center where 24-hour diurnal IOP is done. So which are the situations where you do diurnal IOP daytime versus 24 hours, and what interval between the IOP checks?
Thanks, Nikhil. So I think even for the diurnal, ideally speaking, it should be done in everybody, but I think that's not something that is practical. Even in our institute, we don't do it routinely for all glaucoma patients. So what we do is, let's say it's an NTG patient. We've repeatedly checked the intraocular pressures, 2-3 readings that we have taken. We normally do it at the first instance, and then after dilatation, and maybe the patient comes back another day. So at every reading, you have the intraocular pressures which are in the normal range. There is definite disc damage, usually bilateral, and the corneal thickness is, let's say, even if it is on the thinner side or if it is normal, that means that you are kind of not really underestimating it too much. And apart from this, we also have to make sure that the oral beta blockers are not being taken by the patient. So that means you're not having a systemic condition or treatment that is bringing down the intraocular pressure. The reason why I'm bringing all these points into account is we need to do all of this before we say we need a 24-hour diurnal. So 24-hour diurnal helps you with 2 reasons. One is to understand what is the peak intraocular pressure and what is the fluctuations. So if the fluctuations in intraocular pressure are more than 3 millimeters of mercury at different time points that we check. We check once every 3 to 4 hours when we do a 24-hour diurnal. Then I think that's a significant fluctuation. Sometimes we do it even on treatment. Some patients are progressing. Then we definitely need to do a gonioscopy to make sure we're not missing out on angle closure, which typically happens in POAGs or NTGs, especially NTGs. And despite that, that means you have cross-checked and your gonioscopy is open and there is no pseudo-exfoliation that is developed in the time period, as we follow up a patient. Despite all that, if the patient is progressing, we have ruled out certain other conditions like sleep apnea and things like that. So then we definitely need to know, are we missing something? So patient compliance, of course, is very important for medications. But are we missing the fluctuation? So these are the two conditions. So before treatment in NTG patients, definitely. And on treatment, if somebody is progressing, then we need to know, after ruling out all the other causes, including steroids and things like that. I don't want to go into the details, but these are the two conditions. The other time that I would like to do an office diurnal is typically in a patient with ocular hypertension. I don't want to admit and really do a differential IOPs or facing or whatever you call it. In, let's say, a patient with ocular hypertension and we have repeated intraocular, let's say on 2 different visits, different days, you still have IOP which is on the higher side. The reason why I would like to do a diurnal is to make sure that is it just that one-off intraocular pressure, or is it that there is a consistent rise in intraocular pressure, and especially if somebody has a risk family history being there. I want to do it in ocular hypertensive patients just to make sure that is the peak too high? Is it that borderline of 22, 23 that can I ignore, or can I just follow them up, or should I start treatment? So these are the two conditions, OHT, NTG, before treatment and after treatment in those with progression.
Nice, very well described.
And just for the interval between the IOP check, what would you prefer, Sirisha?
3 to 4 hours. If it is office diurnal, usually what we do is we tell the patient to come in the earliest in the morning when we start the clinic. Let's say 8 o'clock, 8 a.m. we do. And then we give the timings. So 8 a.m. and then it is 10 a.m. or 10:30 a.m. And then usually it is just after lunch. And then one intraocular pressure reading in the evening. We tell them the timing so that the day can be taken care of. They go and come back or they stay back, whatever is convenient to them. But at least 4 readings is what we do in day diurnal. But when we do 24-hour diurnal, we admit them. We admit them at, let's say, 10 o'clock this morning. Until next morning, 8 o'clock, we take intraocular pressure readings every 3 to 4 hours. And during that time, we also check the blood pressure.
Thank you.
So, Shika, actually, in some areas here, what we do is we do the diurnal over 3 to 4 days. And call in the office diurnal over 3 to 4 days means call in the patient at different times on different days, so that their office work is also not affected.
Perfect. Thank you, Dr. Devan. Vinny,
Jayant here. Can I just check with Sirisha and Dr. Devan as well? Good to meet you all. I think I met Sirisha in a few panels as well. So I'm just wondering, this with regards to 24 hours, of course, we do not do it at all in Singapore with the costs, and we don't do it definitely not in the US as well. My question is two-pronged. Are you doing only GAT measurements, and does your poor fellow end up doing it, or your MOs or whatever? And that's the first one, practical aspect. Second aspect is, does it honestly change management significantly for the subset that you described? Because, for example, many of us do end up seeing patients in office hours anyway over a period of time. And we do have a rough idea, a good idea of the GAT measurements over, if I see them in the morning clinic once, in the midday or in the evening. Do I need to subject it to 3 days or 1 day? And does it really significantly alter management for a lot of patients? Or, I'm just curious, how much does it add value in real life? And perhaps should we all consider doing it internationally? Are we missing out something that the Indians are doing? And even the Chinese, I know, are doing this, by the way, in Tongren.
So we do it very selectively. In fact, I'm in private practice. We don't have a facility to admit. So we do it very selectively. And for me, the main indication is unexplained progression. And that's why I said we do it over 3 to 4 days so that it doesn't affect the daily routine of the patient also. And so NTG and unexplained progression would be my bet.
So Dr. Devan, in that case, what can you give any, maybe a couple of cases that you have, therefore, because of doing that, you have picked up something that you did not otherwise pick up? But that's basically the crux of my question.
Yes, and also to titrate the medication timing at times. Most of my practice, the patients are on prostaglandins. so that good, day and nighttime control of IOP is taken care of with the prostaglandins. But sometimes, if you want to titrate the other medicines, the adjunct second drugs or the third drugs, then it helps. So I have had situations where, we just change the timings, and that has prevented a future trabeculoplasty or a trabeculectomy. Dr. Sirisha would like to add her experience with the 24 hours.
So I can just add, thanks, Jayant. So this is like, if you ask me the typical percentage of patients who would have benefited, I can't give you a percentage, but I can definitely tell you that maybe I would say once every, so that means if we do a diurnal, let's say we do that now typically the numbers, like leave alone COVID, pre-COVID I'm talking about. So we used to do every Saturday, we admit every Saturday and discharge them every Sunday. Okay, so weekly once there is one fellow who's posted who does the night duty, that the same person also does the eye bank duty for us. So there are 2 or 3 people who are there, and there's the same doctor who actually checks the intraocular pressure at different time points. So logistical difficulties are there, but yes, we do take care, and it's been working since almost 25 years now. So how many patients have you changed treatment? I would say that significantly in a certain small amount of patients. So I can typically give you an example of one gentleman who used to live half the time, he's no more now, he used to live half the time in India and half the time in the US. Previous pseudophakic, previous trabeculectomy done, advanced glaucoma, very, very reliable with his medications, and absolutely no difficulties otherwise, systemically stable. So this gentleman was progressing, and we really didn't know, and progressing at the pressures of 13 and 14. And pseudophakic eye, so there's no angle closure that you can really think about. So when we advised for a 24-hour diurnal for this gentleman, middle of the night, the fellow called me and said, I'm recording a pressure of 38. Do you think I should continue the diurnal, or should I stop it and give the patient Diamox, and what do I need to do? So I'm giving you this example that 13 pressures, 14 pressures followed up over several months, and you still see that there is a progression. And that example is enough for me to say that if I'm able to pick up, and even if it means that one single patient, it helps me. It's not a single patient. We do have several such examples, but I'm giving you this because it does happen. So sometimes the fluctuations can be as high as 15 to 16 millimeters of mercury, but that is not very common. But what we typically get is the amount of fluctuation. So 8 to 10 millimeters fluctuation between different time points, like 5 a.m., you typically see a peak. So 5 to 8 millimeters to 10 millimeters is something that we routinely see.
What did you do for that patient with the 38 thing? So did he change management, video surgery?
Yeah.
Yeah, makes sense. Yeah.
Yeah, re-surgery had to be done for him, and until he passed away recently, but until he passed away, his only aim was to be independent and his vision should be retained, which we were able to.
I would just argue, for the sake of argument, not saying I agree absolutely with the ethos of what you're doing. And I think if that's available to people to check GAT 24 hours would add value for a definite subset of patients. But in the lack of availability in some centers, if you have ruled out other causes of progression, specifically neurological causes, and you find the pressure is there, then surgery has already been proven in many studies to help blunt the diurnal effect, because then you could assume it's probably a diurnal variation, which typically happens in the nighttime, as Dr. Srisha has explained, and therefore surgery does help in these regards. But yes, thanks for those excellent points.
Yeah, but just a point against it, I would say, I mean, I totally agree with you, Jen, but then for argument's sake, and also I typically have, I would say about 3 or 4 patients, and one patient that has taught me a big lesson, that same thing, progression happened, went ahead and did a combined surgery with mitomycin because we also had some amount of cataract, continued to progress despite that, and despite having pressures of 13 and 14, started on PG analog, continued to progress, and now there you're back to square one. So should I subject somebody to a surgery like a glaucoma surgery while I'm not sure that's the intraocular pressure that's causing a problem? So this patient ultimately, when we evaluated and he figured out that he had a sleep apnea syndrome with an AHI index of 48, and we had to treat him, disc hemorrhages disappeared, and he's on single medication, but we could stop his progression. So what I'm saying is it could be a small percentage of patients either ways. If you don't have a facility, I would agree with Tulin that call them on different time points on different days and do it, or the same day if you're able to do it, like let's say morning OPD, afternoon, or the evening once they finish work, they can just visit your clinic before they go home. whichever way. So you could do it at least a few readings to see, is it the IOP or is it a non-IOP related factor?
I absolutely agree. And we also aggressively screen our patients for OSA for those reasons. Excellent points. Thank you. Thank you for the clarification.
There's just one point I would like to make about doing nighttime intraocular pressure is that we are getting the patient from supine to sitting position. That itself can affect intraocular pressure. Please move on.
Yeah, so we always take, if we do the office, we always take supine and this thing, at least 2 random readings. That's a must.
That has to be taken into account as well.
We always do, and also record the blood pressure if possible alongside the IOP.
Yeah, I think if I can make a butt in a little bit, regarding diurnal variation in NTG especially, I think it gives you a little better perspective of how the IOP is in a given patient. So you get better baselines for that patient. Many times you might think that IOP is like 12, 13 in the clinic, but when you do diurnal variation, it might be like 18, 19, or 20. So I think that gives you a better idea about the IOP, and then you can tailor your treatment accordingly, and you can have a little more confidence that reducing pressure would be helpful or not helpful. Though it's not exact, but it does give you a little extra confidence if you know what the diurnal IOP is in NTG particularly.
Thank you, Dr. Pandav. Vinit, can you share your screen?
Yeah, can I start?
Yes, please.
Yeah, so thank you once again for having me over, Dr. Mathur, Shika, and Nikhil. So, well, the case that I'm going to present is of a 77-year-old gentleman. He's a known patient of glaucoma who was diagnosed in 2017. He had uncomplicated cataract extraction in his left eye. That was in 2018. Well, other than diabetes and hypertension, he was negative. He had a negative for all other histories. The other thing which, just to add to the previous, was we also asked these patients if they drink a lot amount of water. So you have it in India where they get up in the morning and Ayurveda says that you should drink 2 to 3 liters of water. So we do ask them that also, especially in patients who are progressing. So his best corrected visual acuity was 6.9 and 6 in the right eye and 6 by 7.5 and 6 in the left eye. There was no relative apparent pupillary defect. And this is the slit lamp photo of the right eye. So you can see the pseudo exfoliation here and also some pigmentation here. The other eye had an uncomplicated cataract surgery by a colleague of mine, and other than a little posterior capsular opacification, he was doing well. So his intraocular pressures were 14 and 13. His max intraocular pressures were in the mid-20s, and he was currently on Combigan in both eyes and Lumigan at night in the right eye. His PACI was 526, 530, fairly all right. His gonioscopy of the right eye showed angle open till the posterior trabecular meshwork with pigmentation of around 2+, which was regular. There was no pseudo exfoliation in the angle, and the left was more easily open again with 2+ trab meshwork pigmentation. His fundus showed a 0.9 disc with bipolar thinning in the right eye and a 0.7 disc with an inferior thinning in the left eye. And well, this was his visual fields. So the right eye showed a double arcuate going close to the fixation, which wasn't so close when you did it on the 10-2. And in the left eye, other than a little small superior nasal step, he was otherwise okay. So that brings us, how do we manage the right eye? What do we do next? Do we plan just cataract surgery alone? His vision was down, or do we plan a combined cataract and a glaucoma? So Shika, will you take over or should I continue?
Yeah, I'll whichever way. You can continue and we can ask questions. I think.
Okay, so then were different factors which one can consider. One is how old the patient is. This was around 74, 78. What is his compliance for treatment? How easy it is for him to follow up? How severe is the pseudo-exfoliation? And do you take into account pupillary dilatation when you decide a surgery to do just a phaco or a phaco trap? So in this patient, he had a aqueous depth of 2.64 in the right eye with a lens thickness of 5.27, and the pseudophakic eye, the aqueous depth was 4.34, and the lens thickness, well, that's the pseudophakic eye, so it doesn't matter. So you also need to see how the other eye behaved. In the other eye, he had had just a cataract surgery alone. And on Combigan, the pre-op, his post-op intraocular pressures were just 12 and 13 consistently. So in the right eye, we had a follow-up of 2+ years. The IOP, though at baseline was 26, on 3 drugs, it was 13 and 14. His discs were stable. We looked at his serial fields. This was the field when he first came in June 2017, and this was now. Didn't show much change, not at the 10-2. So, well, the management options, what would we do and how do we decide? What do we go about it? Yes, Shikha, you can take over.
Okay, so Sirisha can answer what other factors do we keep in mind how we decide it's a pseudo-exfoliation glaucoma, which we know is an aggressive form of glaucoma. So how would you manage? What factors you would consider, and pre-op what precautions, and just brief this thing if possible.
Yeah, thanks, Vineet. It's a very nice case. So I think I agree. We need to consider both, considering the age of the patient, the fact that the pressures were well controlled on medications and had occludability of the angle, which means that lens is also playing a role. And since the patient was well controlled, IOP intraocular pressure was well controlled, I think I agree that we'll go ahead with the cataract surgery. But the fact that the day this patient has an advanced glaucoma, on the day of surgery, IOP fluctuations are something that we should really be taking into consideration. So I would actually give them oral Diamox if they are not allergic to sulfur drugs, oral Diamox on the day of surgery, and start them on topical anti-glaucoma medications immediately, like what we did. We do stop PG analogs, but Combigan is something that I would continue. So the day of surgery, we have to worry about the fluctuations, because if you do a combined surgery, it's unlikely to fluctuate, but simple cataract, it would, because the outflow is not very good. And however well you do, a little bit of overfill or a little bit of visco would compromise and the pressures would spike. So that's IOP spike is something that we can prevent.
So we give mannitol. We do give mannitol pre-op and put on oral Diamox. These are for any glaucoma patients that we operate. And the other thing was avoid a prednisolone acetate and give something like a milder amount of milder steroid. Good point.
Just to summarize, Vineet, what did you eventually do?
Can I make a?
Yes, sir. Yes, sir.
I think I agree with Sirisha that there's a fluctuation and we have to take care, during the surgery. But I think this fluctuation, they can actually even happen otherwise also, because pseudo-exfoliation glaucoma, even if they apparently are well controlled, like this patient, 14, 15 pressure with 2 drugs, but sometimes, they have unexplained, fluctuation in between, which actually go undetected in pseudo-exfoliation disease. I think sometimes that may be the reason for progression, and you have to keep in mind. But this patient obviously has pseudo-exfoliation and also has a significant cataract, and the lens is thick. So there are many reasons in these patients to actually prefer cataract surgery. But IOP fluctuations certainly is an issue here during surgery and even before that. Thank you.
Thank you, Dr. Panda.
But so,
Nikhil,
Dr. Panda, would you do a combined or would you do a cataract alone?
I think in this case, I'll do the cataract alone because the reason is the number one, the lens is thick. There is some tendency for angle closure, which is going to go away after cataract surgery.
But PTM is visible.
And yeah, it's visible, but I think maybe I missed that. But it's just it's just visible. It's not, that doesn't mean that it's really wide open.
Well,
And
it was mentioned as, if I can add, it was mentioned as PTM on compression.
Compression, yes.
that's what I
assume that it is occludable.
Yeah, so that's what I got the impression that occlusion. And also in fluid exfoliation, cataract surgery has a like higher effect on this little higher IOP lowering effect of phacoemulsification in pseudo exfoliation patients. So that.
Yeah, but on the other hand, the fluctuation of IOP is also much higher in pseudoexfoliation. So a gentleman who has already had a very advanced damage, yes, it's not involving fixation just yet, but it is pretty close to fixation. Why do we even take the chance of it getting close to fixation? So I would actually defer. I would actually do a combined here. Of course, I would discuss both. The patient is on 3 drugs, please remember. Is requiring 3 drugs for control, and after surgery, if only cataract is done, we only have 1 more, and quite a few people have reservations about using prostaglandin analogs in pseudofix. I personally don't, but I'm just putting it out there. So my choice in the first, the left eye, definitely cataract surgery alone. In the right eye, the eye in question, I would do a combined.
Yeah, Vinita, that would improve doing a combined would improve the quality of life for a 77-year-old.
Absolutely.
So I think that's a major factor in going towards a phacotrap or a MICS.
Life improvement is more because of the cataract surgery rather than glaucoma surgery. The immediate quality of improvement. Okay, so the cataract surgery will take that, and also will take care of, to a larger extent, IOP. But of course, you need to this patient, and you can always go second time for glaucoma surgery if required. I generally prefer not combining surgeries, but that's kind of an individual thing, and I think it's perfectly okay to do combined as well. But this is my preference.
Jayant, yeah, I agree with Vanita actually in this one. I think I'm wondering another factor that could be thought about or talked about is are we trying to achieve medication independence or the burden of medication?
Yeah, that's what I meant by quality of life. I meant 3 doses.
I'm all for it. Achieve independence from medication.
From medication. So I think if that's an important factor, then phacotrap in a very advanced eye might be a good idea, of course, with its attendant risks. So I will discuss both options with the patient.
Yeah.
And secondly, the left eye, I know it looks like he's already had a phaco done. So there might be some lens component, and pressure 16 went down to 12 to 13. Why is he on Combigan, I wonder? Because maybe I would trial off and check that out. I'm not sure because it might have already stabilized. I don't know. I'm just putting that out there for the left eye. So I am all for medication independence. I try to take my patients off medicines as much as I can because they're going to be with this chemical for life. And especially Lumigan is one of the eyes. One of the eyes can cause obvious side effects. So I try to avoid that if I can. And Combigan, 20-30% of them have allergies. So of course, it's a discussion. I mean, there's no right answer, I believe. All the answers have points.
I mean, it's not just the quality of life. Also the fact that unfortunately Combigan, or any of these drugs can cause ocular surface disease, which, we are seeing more and more as less and less people are actually getting surgery and more are on medication. So, I would definitely go for a combined here.
Okay, I think we are just about to finish the time for this. So we'll take one last question. Nikhil, please.
This is Van Herrick grading, and I know that it's an important test. Dr. Panda also showed a photograph of Van Herrick test when he said how we not miss glaucoma. But the common question is when you are doing gonioscopy, what they need to do Van Herrick. So Dr. Vanitha, please.
Right. Well, I am really sad that we have run out of time because, I did have a really interesting case of angle closure. Nonetheless, yeah, Van Herrick. See, what is Van Herrick grading? It's looking at the peripheral, depth of the anterior chamber versus the central depth. Whether you're doing when you are doing a comprehensive examination, not in a glaucoma OPD, in a busy OPD, then not only do you need to document whether the central depth, but also the peripheral depth. Now, when we are doing only Van Herrick, we are actually not talking about the central depth. And I'll give you an example here. I had her patient -6 diopter sphere myope. So that's a high myope with a 24+ mm globe, who actually had angle closure and was missed in 4 different institutions, hospital practices, whatever, in the city. The reason being that I think the majority assumed that with a -6 diopter and a 24, well, I don't know, that the angle cannot be closed. So Van Herrick was shallow for this gentleman. So was the central. Obviously not to that extent. So whenever Van Herrick is equal to or less than 1/4 peripheral anterior chamber depth, we need to do a gonioscopy. But at the same time, we need to document the central AC, because there are several other conditions like plateau iris syndrome, like maybe even the differential depth in, say, angle recession or in lens subluxation. So traumatic situations. I think we need to document in all cases.
Vinita, because this broadcast is going to so many general ophthalmologists, please say gonioscopy is a must.
Yeah, absolutely a must.
Because
But
they will quote you and not do gonioscopy and do only Van Herrick. So
no. Gonioscopy is a must, and not just in all patients of glaucoma or high pressures or Van Herrick's equal to or less than 1/4 CT or trauma. These are the situations where you will be doing a gonioscopy, but also when you have done a laser peripheral iridotomy. After that also you will check, because patients can be post LPI occludable. And that was my case. Unfortunately, we've run out of time.
Thank you, Dr. Vanita. Thank you, Dr. Pandav. Thank you, Dr. Jayant. And thanks to all the faculty and as well as the delegates. We hand over to the next session coordinator, please. Thanks a lot. Thank you.
Thank you, sir. Thanks.
Thank you so much.
Thank you.
Thank you, everybody.
Thank you. Thank you.
Thank you.
Dr. Praveen sir, we can start the session.
All right, thank you very much. It's a pleasant surprise to finish the previous session on time. So that's really nice. And hello and good afternoon, Dr. Dan Reinstein. And thank you for being with us on a Sunday morning. And welcome to the rest of our panel as well. Vardhaman, Dr. Maz, Dr. Kumar, Doctor, and Dr. Gaurav Luthra, who are going to be joining us very shortly. So also on behalf of the Hyderabad Ophthalmology Association, we welcome all of you to this session on the basics of understanding refractive surgery from the perspective operating with slide. So to give you an overview, we're going to have the keynote lecture delivered by Dr. Dan Reinstein on the treatment of presbyopia in the absence of a cataract. And then we're going to follow that up with a very interesting panel discussion, which is going to focus on operating in the space of refractive surgery in older patients. And we're going to have a detailed discussion with our expert panel, so do stay with us. So before we waste any more time, I'd like to introduce Professor Dan Reinstein very quickly. Dan Reinstein is the head of the London Vision Clinic in London, UK. More than 25 years experience in the area of refractive surgery and more than 1,000 talks. I'm sure not a large percentage online, Dan. And also He is a pioneer in the area of smile, has published some seminal work in the area of smile, as well as in presbyopic LASIK, as well as refractive surgery. And Dan is probably also best known as the person who is the head and the heart behind the Artemis. The Artemis is a device that he probably might not talk about today, but is a fantastic tool that can image the anterior segment of the eye in very high resolution. So without any further ado, Dan, welcome to the Hyderabad Ophthalmology Association, and look forward to listening to you and learning from you.
Well, thank you for the introduction. And I do wish I was in Hyderabad with you, because I've never been there. But I was telling my kids that I'm going to Calcutta tomorrow. And they were like, what? So the amount of traveling I've done this year has been extraordinary by internet. So let me share with you, something which I think I'm sure a number of you have already heard me speak about, but the treatment of presbyopia, of course, is the final frontier in refractive surgery, because it affects every single human being, not just people who have a refractive error for distance. And our ability to treat presbyopia has been, has had a mixed reviews, I would say, over the years. Traditionally, the problem is that we're using a static solution to try and overcome the loss of a dynamic process. When the accommodation is dynamic, right, you can focus at different distances very accurately, very quickly, and literally instantaneously see at any part of the vergence field. So what we've done is we've tried to do multifocal surgery, either on the cornea or in the lens, or we've tried to do monovision. And we know that each of these has, a number of challenges to get patients to be happy, and a number of challenges in screening for the patients to determine if they are candidates for these multifocal or monovision options. And the development of what I originally called laser blended vision, but is now a Zeiss product, which I have no financial interest in, so that you know, called Presbeyond, was, in my
share
view,
your screen.
I'm sorry?
Please share your screen.
I wasn't sure.
No,
Sorry,
don't
I'm glad you pointed that out, because I was just going to race ahead here talking on my own. Okay, thank you for that. You didn't miss much, actually. You missed my financial disclosures, but as I say, I don't have a financial interest in Presbeyond. And I'm talking about multifocality, where there's more than one focus in the same eye. And this, of course, can be done on the cornea or in the lens. And I'm talking about monovision as these static solutions, which are supposed to replace the loss of the dynamic process of accommodation. And I really want to try and convince you in the next few minutes that these are not optimal because of the difficulties we have in qualifying patients, the difficulties that we have managing their discomfort and unhappiness afterwards. And how, in my practice, and now well over 7,000 patients ahead, we have been using Presbeyond, laser blended vision, for correcting plano presbyopia and non-cataract presbyopia. In other words, myopia, but no cataract, hyperopia, but no cataract. So, I want to talk about these two camps, which everyone is very familiar with, because the idea of having a multifocal eye, meaning two images or more, three images in the same eye, what are we requiring from the brain? We're requiring the brain to discern an intraocular rivalry. There's two images, and the brain has to sort of, within the same eye, decide which image to pay more attention to. And then in monovision, which we're very familiar with, we have two different images, but the brain is trying to decide between eyes. So that's, let's call that interocular rivalry. So intraocular and interocular. Now, it just turns out, you know, and many of you know this, that the brain is wired for interocular rivalry because it suppresses. It's a natural neurological function. The question is whether someone can suppress sufficiently to not be noticing that one eye is blurred, a sort of conscious suppression. And we know from monovision for 50 years that about 50–60% of people tolerate monovision. We know that. So we've got a procedure that's about 50–60% of people do great, and we got another procedure that about 50–60% of people do great with multifocality. Can we do better? And the answer is absolutely. What we're going to say here is that the eye already has a feature which we can enhance to improve monovision and make it into binocular vision. The eye has an optical defect called spherical aberration. And as we get into our presbyopic years, that spherical aberration is at a significant level. It's about 0.3, on average about 0.3 microns in a 6 millimeter zone. And so it's a naturally occurring aberration. And guess what? It increases the depth of field of the eye. In fact, if you think about it, it's spherical aberration kind of describes what it is. When the lens bunches up in accommodation, it becomes more spherical. And actually, spherical aberration goes up as we accommodate. So we are already used to having spherical aberration go up to give us better depth of field. So the most important thing, though, and I emphasize that when we talk about changing spherical aberration in the cornea, we are not talking about a multifocal cornea. We're not talking about multiple foci in the same eye. We're talking about a continuous spread of the point of focus. So let's think about that diagrammatically here. You have an aspheric system with a perfect focus and no depth of field, or very poor depth of field, or you have spherical aberration, which enables depth of field. Now, I can show you this in your own brains, in your own eyes, while you're watching this screen. So this top row is showing the chart defocusing. And if we look at the -150 defocus, which is the minimum real monovision for reading small print up close, you can't really see well at distance. So this is a situation where the brain is going to require suppression in one eye. And 40% of people won't be able to do it comfortably, so they're not candidates. But look what happens when we have the same defocus and we add spherical aberration. So down here, what you're looking at with your eyes, your brain, is a -150 plus spherical aberration defocus. And your brain is detecting the edges of those letters on this screen. I haven't done surgery on you, but it's happening as you look at this screen. That edge, the edge of a spherically aberrated, the edge of a letter that has spherical aberration has a particular kind of blur that the brain will filter. So let's say that we've got increased spherical aberration in a dominant plano eye and -150 in a non-dominant spherically aberrated eye as well. You'd say, well, does the brain is having to put these two images together, but they're not going to see clearly because there's spherical aberration. And that is what optical scientist Pablo Artad was saying this meant for many years, actually. But he's now changed his mind because he of course, he himself published papers on the fact that the brain filters spherical aberration. And in fact, you don't see spherical aberration because in your mind, there is a filter going on. So in fact, what the brain is really putting together is two images that are much more similar. and the brain is able to fuse images that are very similar, and you in fact can retain even stereo acuity with this blended vision treatment. And so this is easier for the brain to do than, of course, traditional monovision, which is fine if you can tolerate it, but not as many patients can do it. And what we find is that with this non-dominant eye at -150 and spherical aberration, we are also helped by the fact that at whatever age you're at, you always have meiosis. So even if you're 75 years old, when you look up close, your pupil gets smaller. So that meiosis is still in the mix. So that gives you even more depth of field. And like I said, the retinal image, which has spherical aberration on it, is processed in the brain, and actually the perceived image in the mind is much sharper. And I can tell you this myself, from personal experience, because my distance eye is 20/12 at distance, and I don't have any halo whatsoever that I can discern when I look at the moon at night. So somehow there is brain processing. Now, if we think about the multifocal attempts on the cornea, we saw a number of people trying to put a central island in the middle of the cornea, either by a Q slider or by literally making a little central steep zone with Vizix was doing this, Supercore was doing this, Schwind is doing this even now. And invariably, if that ad is anything significant, it will cause loss of contrast and loss of lines. And that's not acceptable, because it's a compromise that, especially if you put it in the cornea, then what happens when they get a cataract? Then they have this visual degradation, which persists even with a monofocal IOL after surgery. Now, Schwind have done a very good job in decreasing the amount of ad in the dominant eye, and so that binocularly now people don't lose two lines. But the non-dominant eye has lost contrast because it has a 1.5 diopter little nipple in the middle of the cornea. And it's not a procedure that many of the Schwind users are using on their patients for good reason. So halos, central islands, not a good thing. So yeah, the monovision challenges, we know, people actually perceive less distance vision when both eyes are open because of neural subtraction. So we lose summation, we lose intermediate vision, and the tolerance can be difficult. And adding spherical aberration to a small anisometropia, what it does is it overcomes all of these things, because the near vision of the distance eye is much better. The distance vision of the near eye is much better. And so actually 97% of people that we test, and we publish this test, 97% of people who you do a 5-minute on the chair test will pass the test. So it's an objective test that has a hard endpoint, and you can take someone through to surgery if they're plano. I mean, it's quite different from the palaver that you have to go through in interviewing the patient about what job they have, what distances there are, what do you prefer, intermediate or near, and then you can mix and match your multifocal lenses. This is much simpler. This is a 5-minute test. You're a candidate, step this way, 10-minute procedure, healed in 3 hours. It's called LASIK. And the next morning, you can see everything. Now, stereo acuity, I mentioned the binocularity. We tested stereo acuity, and we found that there is no loss of stereo acuity with presbyond, which is different from monovision. And part of the understanding of this comes from understanding just how much retinal correspondence there is between the eyes when we do this treatment. So we all know that the peripheral retina is about 2200 in vision. And let's just say that the center is 20/20, and we know that at 5 degrees, the vision is 20/60. So as we go eccentrically from the fovea, the visual acuity diminishes exponentially. down to 2200. So in a monovision situation, you've got 2200 in one eye, and you've got your normal eye, set for distance. And so for this to work, you have to have some neural suppression in order for the brain to tolerate, for the patient to not feel odd. In presbyon binocular vision modified by spherical aberration, the distance vision is actually 20/60 in the non-dominant eye. And what this means is that the retinal correspondence between the eyes is much higher. And so the brain is fusing because there is correspondence all the way down to the 5-degree field. So think about it, peripheral vision, 2200. And as you come towards the center, 2020, and traditional monovision, there's very little overlap. You're not even inside the macula when you're trying to wear monovision. Whereas in blended vision, the non-dominant eye is 20/60. And so even the macula, the greatest proportion of the macula is still the same between the two eyes. And it's only the central 5-millimeter field that is different between the two eyes. So you can understand why the brain is much more willing to fuse the two eyes and produce binocular vision. So we don't get suppression, we have summation. And that's why we see that the non-dominant eyes, 80% of them are 20/60, and the dominant eyes, 92% of them are 20/60, but with both eyes together, it becomes 96% of the eyes, so of the patient. So more distance vision when both eyes are together instead of just with one eye. And this is a sample of about 400 patients with more than 100 patients, myopia up to -8, hyperopia up to +6, and emmetropes. Of course, once I started describing this in 2004, 2005, a number of adaptive optics labs started experimenting with introducing spherical aberration non-surgically into the visual pathway, and they did show exactly what we were talking about. So here's a study from Carolina Rocha, where adding positive spherical aberration or negative spherical aberration, either way, will increase the depth of field. Now, what we had discovered, we came in from the repairing night vision disturbances with wavefront guided treatments and realizing that we could reduce the spherical aberration a little bit and still get great night vision. They're coming from adding spherical aberration and noticing the increased depth of field. And so our perception of how we came to this in 2004 was we had patients that were in the toxic range of spherical aberration, and we were doing a wavefront guided treatment to push them into what I call now the therapeutic range. Well, actually, my colleague Glenn Karp thought of this toxic and therapeutic drug analogy. So you see, spherical aberration can actually be a positive thing if it gives you depth of field. And so because we get about a diopter and a half of depth of field from the right amount of the therapeutic amount of spherical aberration, just a small, and that's without, because obviously there's no loss of contrast. Just a small anisometropia will provide vision at all distances from near to distant, including the intermediate, where in the intermediate range, both eyes are similar. How does that work? Well, the dominant eye is set to plano, but remember, there's a 1.5 diopter bracket around that plano, meaning that at near, the distance eye has about -0.75 equivalent vision. The non-dominant eye is set to -150, but it sees at distance as if it was only -0.75, but it sees at near as if it was -225. That's your 1.5 diopter bracket around the -150 of the non-dominant eye. And so this setup gives you incredible results because you are doing it with LASIK, and LASIK is incredible, right? It's the most accurate refractive surgical procedure we have. So as I said before, we've published these results, over 100 patients in all these groups with 1-year follow-up. And as you can see, myopia up to -8.5, 2020 J5 rates, 98%, for plus up to +6, 95%, and plano presbyopes, 97% seeing 2020 and J5. 2020 J2 is almost everybody, 95%. Okay, hyperopia up to +6 is a little bit less accurate, but emmetropes, 95% completely spectacle free at all times. 95%. The intermediate vision is taken care of because computer science font 12 is seen by everyone, both in myopia up to -12 here in these studies and hyperopia up to +6. There's no loss of 2 lines because it's LASIK, right? And we're keeping the spherical aberration in the therapeutic range. There's no loss of contrast even. In fact, the contrast post-op tends to be slightly higher because we're optimizing spherical aberration. It's not clinically significant, but it's a statistically significant increase. And the interesting thing is that finally we have many researchers around the world, including Sri Ganesh in Bangalore now, who who have demonstrated that they're getting the same results that we were. So it wasn't this thing about, oh, it's only Dan Reinstein. Anybody can do this as long as you stick to the protocol and the testing parameters. And you see, when I talk about presbyopia in the absence of cataract, I think I'm not going to dwell on this because I think you're all familiar. Obviously, you're in India and you do the most cataracts per capita per surgeon, I would say, in the universe. The complications of even an uncomplicated cataract surgery are significant, and CME and at least the few studies out there on clear lens exchange that report best spectacle corrected vision change, that's the safety, show that it's between 3 and 4% of eyes lose 2 lines. And it's because of capsular problems, capsular opacification, the YAG edges, which cause scatter, negative dysphotopsia from IOLs. The complications are avoided by staying outside of the eye and doing a 10-minute procedure that heals in 3 hours, and the patient is seen the next morning. Yes, there's an adaptation phase, but it's not as painful as the adaptation phase of a multifocal cornea or lens, because it's whatever discomfort there might be during the adaptation, that discomfort is instantly reversible by a pair of glasses. So you can diminish the anisometropia instantly by glasses and relieve any discomfort. And as the patient adapts, they use the spectacles less and less until they're not using them. And we have our emmetropic study where 97% of the patients that got to the 1-year mark were fully adapted. So I've given you a very short tour of what is in fact about a 6-hour course. And we run this course twice a year in June and in November. In fact, this afternoon, will be evening for you, we are running our presbyopia course, which of course includes all presbyopia correction, but it focuses on how to perform blended vision. We also include, of course, all of the SMILE stuff that we wrote in our textbook, our learning curve, our complications, how to avoid them, and the last part of the course is on nomogram, advanced refractive surgical concepts, nomogram development, all of the diagnostics, epithelial profiles, how to correct complications in corneas, therapeutics. So this course, we run it in June and November, and in between those 2 dates, the previous course goes online, so it can be actually taken anytime, through a subscription to the Royal College of Physicians in London's website, where we have our courses is sort of living permanently there. So I'm very obviously willing to take attacks and questions, but before that, I'll just leave you with a thought. The first time we taught this course about 5 years ago, a colleague of mine asked if they said he was convinced and said, you know what, would you do my eyes? I'm a plano presbyope. And that was Dr. De Wilde here from Belgium. And the next course, Rob Morris here in the UK, who's a -5, He's presented on his own case. And I mean, you can see and probably recognize a lot of your friends here and colleagues. Every time we teach the course, we have several surgeons saying, holy moly, you changed my mind. I'm going to stop doing multifocal surgery. I'm going to start doing this. And by the way, would you do my eyes? So, you know, it's not just me. I think there are a number of surgeons that are voting with their feet on a procedure that doesn't compromise distance vision. My own surgery is the same. I, you know, did my presbyope when I was 55. I'm now 58. I was essentially plain. I was a little bit myopic, and you know, I feel like I was when I was 20 years old. I'm plano in minus 175. I've got 20/10 distance vision, 20/50 in the non-dominant eye. My uncorrected vision is 20/10. My intermediate is J3. I have J1 at near. My contrast is perfect. I have 40 seconds of uncorrected stereo. I still operate perfectly. And I feel like I did when I was playing the saxophone at Club Med when I was 21 years old, although of course I don't quite look like I did back then, but you know, it's how I feel looking out at the world. So in summary, you know, we have a method now of using LASIK to correct plano presbyopia, but also a wide range of refractive error together with presbyopia. We're using a natural aberration that's already in the eye and enhancing it in therapeutic levels. We can simultaneously correct the cylinder, of course, because it's very easy to do with an excimer laser. It's done on the visual axis because we have eye trackers that put the ablation exactly where it's supposed to go. There's no compromise to the contrast sensitivity, and so the night vision remains excellent. Any difference between the eyes can be instantly reversed by a pair of glasses, so that's an option if there's any issue with binocular confusion at night. And 95% of the people that walk through the door are candidates for this procedure, and 97% of them are adapted at 1 year, and functional stereo acuity is maintained. And like I said, it's a 10-minute procedure that heals in 3 hours. The patient is at the restaurant that evening reading the menu to to your next patient, their husband or their wife, who is, you know, invariably coming in for surgery next. So I think I'll stop there, and if anybody wants to attack me, I'm ready for it.
Thanks a lot, Dr. Einstein. It's difficult to attack someone who's had surgery themselves.
Hey, Four Eyes, come over here.
So is getting a free surgery part of your course as well?
Yes, it's that professional courtesy. I consider my payment is the honor of being asked to operate on a fellow colleague, but also the honor of having my own scientific pathway validated by, you know, someone who knows as much as I do about eyes.
Yeah, thank you so much. And I would like to also introduce our panelists today so we can have an engaging discussion about what you just shared. So we have with us today Dr. Kumar Doctor from Dr. Eye Institute in Mumbai, Dr. Gaurav Luthra, the president of the III RSI and the head of the Wave LASIK Eye Institute in Dehradun. We have Vardhaman Kankaria, again a very prolific smile as well as refractive surgeon based in Pune, head of the Asian Eye Hospital. And then we have the Nawab of Hyderabad, Dr. Syed Maz. He runs a hospital called the Eye Care Vision Clinics in Hyderabad, several of them actually. And all 4 of the surgeons that you have on the panelists have access to Smile as well as regular LASIK as well. So I would invite comments or questions from any of you to start the discussion with Dr. Einstein.
Dan, fantastic presentation as usual. So I was just wondering, I know Sri Ganesh very well, and I every time ask him only 2 questions, which is of course answered, is whenever he gets a cataract, what is the preferred lens that he would prefer? And what happens to the calculations in Press Beyond when you get a cataract?
Right.
And next question is, I always thought that cornea remolded itself. I have a Schwind. So I do the blended, results are very good in hyperopia, but not very good in plano and not very good in myopia. So this is my findings on the Schwind examer, and I've talked to them in detail, and this is what my findings are. So I always thought that cornea remolded itself. Even if you create a little of depth of perception over time, that reduces. So what is the longest period you had a follow-up of a patient who can still perform the way he did on day one with the Press Beyond? And over time, how did it do? And thanks for the answers.
Well, I would, I'm sort of reaching here for my slide deck, because all of these questions, of course, we answer them in our course, and therefore I have slides to present. I'll just do it orally. Look, in terms of your first question, and we have a whole lecture on cataract and Presbeyond combinations. You're asking about cataract after Presbeyond.
Yes.
And I'm also going to mention Presbeyond after cataract. Okay, so, but both are answered by the same paragraph. Essentially, as I've said, we are putting spherical aberration, not a multifocal cornea like the Schwind, but a spherical aberration, which is basically a change in the asphericity of the cornea. We're putting that on the visual axis onto the eye. So it doesn't matter where the pupil is, the spherical aberration is on the visual axis. Okay, so that gives you 1.5 diopters of depth of field. So the preferred lens is a high quality 100% transmission monofocal IOL that has low PCO rate. That's the preferred lens, which means you can put in a 1995 SA60 for $40 and get the whole range back after the cataract surgery. And this is the most, see, the reason why this is not, you don't hear about this a lot, is that companies that make IOLs make more money when they sell you a newer lens, not when they sell you an old lens. And it just turns out that in this situation, the old lens is the best option. All of these modifications to the lenses, the multifocality, which obviously was terrible 20 years ago, and of course is much better now. The multifocals now are excellent, actually. But all of that upsell that they can do to you is gone. And so they're not going to promote the concept, even though it gives better vision to the patients. So let me flip that around the other way. When we have patients coming to us with cataract, we have, so you know, people call that premium cataract surgery with the multifocal lens, right? And we have something which I now call premium cataract surgery, comma, no really. Because premium cataract surgery, no really, is we will do your cataract surgery and then we will nail the refraction with a Presbeyond procedure on top. Now it's really premium because you're paying for 2 surgeries, very premium. But at the end, you have the highest chance of being fully corrected at distance, fully corrected at near and intermediate, and not having halos and night vision disturbances that you have to hope that in 6 months you will neuroadapt to. So that's what we call premium cataract surgery. So by the same token, all of the previous patients that had cataract surgery with their monofocal IOLs, they're also candidates for Presbeyond. So you can essentially write, I mean, I don't even want to ask how many hundreds of thousands of cataracts have been done by the 5 people on this screen in India. I mean, you guys, it puts us and the rest of the world to shame how efficient you are at cataract surgery. All of those patients are fresh patients for you if you are doing Presbeyond, because you can, unless they have a contraindication to LASIK. So I hope that kind of answers the question in full. You had longevity, yeah. So, okay, so we have 15 years follow-up now on this. And you're very right to point out that I haven't published that yet, but I'm trying to, I publish almost a paper a month, but that one still isn't on the, hasn't got to the top of the pile yet. And we do present in the course the longevity, and we found that the enhancement rate goes up as time goes on. So what our statistics show is that 1 in 5 patients will have needed an enhancement by 5 years. And about 40% will have needed an enhancement by 15 years. Okay, so it goes from 20% to 40% between 5 and 15 years. But here's the thing. There's a misconception and that permanent lens replacement is permanent vision, because it isn't. Because actually, the corneal astigmatism changes anyway from the age of 40 all the way to 80, right? And you look at the large studies that have been done on natural changes of astigmatism in the eye, every 5 years, 1/3 of eyes change by 1 diopter of astigmatism or more. So if you do permanent lens replacement on someone at the age of 51, because they're +2, and that's what you think is the right thing to do, then you've got your perfect multifocal setup, and 5 years later, that 1 diopter of SIL means the multifocality isn't working anymore. They're going to need a laser enhancement. So why not start with the laser enhancement in the first place? And who knows, 10, 15 years from now, we may have actual accommodating IOLs. And that's now not available to someone that you did clear lens exchange in now. There's just no advantage to taking a clear lens out when there is an option that gives you better quality of vision without a higher risk intraocular surgery that's less accurate. So, we're, in a scientific meeting here, but I mean, commercial things are important. You can't, anybody would immediately start doing presbyon now if they didn't have to pay for it, right? So the money is the issue, right? But the fact is that, because the eye continues to change, and we tell our patients, look, they say, oh, is this, so will I never need it again, doctor? We say, no, of course not. There's nothing in the body is permanent. So, 1 in 5 patients by about 5 years will need a little tweak. Oh, will I have to pay £5,000 again? Say, no, absolutely not. You're a patient of the clinics. So when you come back, it's a nominal fee. We cover costs. Right now it's £2,000. So what we do is we charge a fraction of the initial surgery because that patient is an ongoing patient. And so in a way, the business side of the clinic things are very high. My CEO is very happy because presbyon becomes a procedure with an annuity, which refractive surgery generally isn't. And you're upfront about it because it's the truth, right? I don't know if some of you may be old enough to remember an American actress called Mae West. And she was, very glamorous in her youth, and she was 70 years old, and they were interviewing her, and she said, "But Miss West, but you're 70 years old. You look fantastic. What's your secret?" And she said, "Well, everything in my body is exactly the same as it was 40 years ago, just a little bit lower." So, the body changes, okay? And so that's not something to apologize for to the patients. I think that the difficulty is that we have this misinformation out there that if you do a lens replacement now, you won't get a cataract and you get permanent vision correction. That's the misinformation, which makes it difficult to understand why you'll need an adjustment in 5 or 10 years' time.
Thank you, Dan. There's a follow-up question from one of the attendees who wants to know whether you can do presbyon in somebody who's undergone LASIK surgery in the past with a new kind of spherical aberration on the cornea, and what special precautions need to be taken in such a case.
No precautions at all. You just use the Presbyon software. You put the spherical aberration of the eye into the software. There's a data entry point, or you measure it with your Wasca aberometer and it imports it automatically, and you do the enhancement. I mean, it's just an enhancement. Yeah, there's no precautions whatsoever.
Gaurav, please go on. Gaurav.
Okay. Hi, Dan. So I wanted to ask you that how do you differentiate between patients who are, say, 45 and who are 55, and how do you plan your treatments differently? And what do you tell those patients whom you're treating at, say, 45, 46? And when you do enhancements, are you concerned about, things like epithelial ingrowth and other things? Because you said that you do a lot of enhancements. I mean, you might want to do because patients will come back. So these two questions. Yeah.
Yeah, great questions. Again, I would encourage you to perhaps take the full 4-hour course, because we go through all of those things and they're great questions. So the first question, what was the second question is about ingrowth and safety. And that is a barrier to Presbyon, is that many people are anxious about enhancements because of the extra work and possible problems that ingrowth can cause. And for that reason, we have a whole lecture in our course on all of the most modern concepts behind prevention of ingrowth and management of ingrowth, so that the Presbyon surgeon is equipped with all of these new concepts that have come from all over the world and have been put into one lecture, so that we don't have an issue with ingrowth. So we don't have an issue with ingrowth. And we also, with the VisuMax, you have such an accurate flap creator that we also have a lecture on what we call flaps for life. Flap planning, meaning that you can start with a thinner, smaller flap, lift that flap, manage the ingrowth, maybe get a little bit of melt in the edge. And then the next 5 years, you would come, instead of lifting that flap, you would make a new flap that's wider, deeper around it. We talk about the parameters you have to do to avoid crossing the previous flap, and you can lift that flap. All of the Corey Lesnar, he has a website called pristineflap.com. I would encourage everyone to look at that, pristineflap.com. You could just pop this into the audience there. He has videos showing that the way to manage ingrowth is quick. In other words, when you see the patient at the 1 year mark, 1 week mark, and you see a little ingrowth, you literally just take a 27 gauge cannula. He has a sandblasted tip from Ryan, but you could just take any 27 gauge cannula, a little bit assessed, and at the slit lamp in the office, you just, get into the wound and just push the epithelium out, and it doesn't come back. Or if it does, you just do it again. The percentage of eyes that I need to take back to the operating room for cleaning and suturing is 1%. Is that me?
That's from my forest.
Oh, you know what? That's the time that I normally wake up on a Sunday. So I hope, so okay, and the first part of your question was, ingrowth was the second part.
So the other question was the age, like what's the best age to do it? And if you did it at 45 and 55?
Yeah, and the patients asked that question too. So my presbyopia, I read on the internet that my presbyopia is going to get worse with time. So what I do today isn't going to work for me later. And the answer is no. See, the Presbyon treatment is, the patient that passes the plus 150 Reinstein tolerance test, they get plano and minus 150. The 69-year-old who passes the tolerance test gets plano minus 150. There is no difference in the treatment, no matter what age you are, because 97% of people pass, more than 95% of people pass the tolerance test. So once you pass the tolerance test, you just put that in, and you might not need all of that if you're 47, but you put it in. So there's no difference in what you do. What you're asking, you're coming from, you're obviously a very experienced monovision user, because in monovision, you would give less ad to a younger patient and more ad to an older patient. And so you have a 68-year-old, you have to give them -250. And 30% of people tolerate -250. So when you look at it at like a monovision way, it sounds like it's not going to work, but this is totally different, right? This is binocular vision. So all we're doing over time with these enhancements is returning the eyes to plano -150, not adding more ad. And when I say this, there are exceptions at the outskirts of our practice, where a younger patient who tolerates less, who doesn't tolerate the +150 test fully, will get slightly less ad and will be told that they're very lucky that they came in now, because I can put in half of the Presbyon, I can put a half of the blend in now, but because you're young, you'll be able to see tiny print. But in about 3 to 5 years' time, you will come back, because that won't be enough. I'll put the extra half in for you then, and you end up out of spectacles between now and continuously. If you had come in 5 years from now, it wouldn't have been good, because I would have only been able to give you half then, and it wouldn't have been enough for the small print at that time. So we cover all these eventualities.
Dan Vardhaman, would you like to ask a question?
Yeah, thank you, Dr. Praveen. Yeah, so Dr. Dan, enjoyed your presentation as always. So my question is basically, when we look at the presbyopic reversal procedures as such today, now we are looking at actually a continuum of laser vision correction on the cornea, and also it is now blending into the lens-based procedure. So I think let us say both these refractive lens-based procedures and the refractive corneal procedures are kind of continuum of each other. And I obviously, of course, understand that you do prefer presbyon as the first choice in all presbyopic patients. So what is is there an upper limit in terms of the age that you would actually choose for these patients? Like if a patient is 65, let us say, or 60-year-old. Right. And my second question is basically, are there any real indications for you to go for lens-based procedures for presbyopia? Is there indication that you would choose? Yeah.
Of course. But you guys are like pros here, asking the best questions. So the age limit is non-existent, because I don't divide presbyopic patients into, older and younger. Well, look, what you're saying is traditional, right? People say that, if someone's 48 and they're -2, they're not a great candidate for a multifocal, and they got vitruses attached and they're myopic. So you know what? Let's just do a little bit of monovision LASIK and we'll do the clear lens later. No. My criteria for lens or cornea, presbyon, is there a cataract? That's the criteria. Because, as I explained earlier, starting with presbyon is the best way to start your senescence in the eye. It's best to start with placing therapeutic spherical aberration in your cornea. Because if you get a cataract in the future, when I know in India, the whole Indian subcontinent, you get cataracts coming in much earlier than we do in Northern Europe. But when that time comes that the cataract develops, you now have the opportunity to do the cataract surgery with a monofocal, low PCO rate lens that's not expensive, and you maintain the best possible quality of vision. So for us, presbyon is the gateway into the rest of the eye's life, if you see what I mean. Now, so when would we say, well, you're not a candidate for presbyon? Well, when there is a cataract. So how do we determine that? Well, there's two kinds of lens problem that would alert us that it's best not to just do presbyon. The first is to use an ocular scatter measurement. So we use the HD analyzer because that gives you the OSI gives you the ocular scatter index, and that gives us a good indication of where this eye is, because looking at the slit lamp can be very misleading. But if someone has best corrected vision that's normal and their contrast is normal, we measure contrast sensitivity in every patient as well, and their OSI is in the green, well, then they don't get a lens surgery. If their OSI is in the yellow, even though it doesn't look like they have cataract and their vision's still 20/20 best corrected, that's where we say, you know, we might, well, it depends on where in the yellow they are. We might say, look, you know, you do have opacity starting in your cataract. And then we tell them there's two ways of doing a cataract. We can just do your cataract surgery normally with monovision, with monofocal intraocular lenses. We very, very rarely use a trifocal, excellent trifocal lens, very rarely. We just find that the disadvantages of having an unhappy patient that's not adapted with a trifocal far outweigh the inconvenience of having to do presbyond on someone where the monofocal monovision isn't working well. So to us, again, we go back to presbyond because it's a better option than splitting light inside the same eye, intraocular rivalry. And, you know, maybe the patients are more forgiving where you are, but our patients can be very, very, very demanding here with respect to visual quality. So there's no age limit. There is a transparency limit, if you like. That's the way we look at it. And it's not just transparency, because it's also the situation that the lens itself can be changing the refractive power of the eye. So someone can have no cataract, but they have lens hypermetropization, or lens, you know, by rounding of the lens as it grows, or by nuclear sclerosis, they can get lens myopization, right? And so determining stability in the eye before knowing which, you know, angle of attack to start is the second way. This has nothing to do with transparency, but it is to do with age. And let's be clear, about half of the patients that we have to do an enhancement on at the 5-year mark are because the lens shifted the refraction, not because the cornea changed. Yeah. And the patients understand that. And we explain it to them. We say, okay, we've analyzed everything here. We look at the K change and we look at the refraction change. And if the Ks are stable, well, it's the lens that shifted, right? Bob's your uncle. So we say, look, your lens is shifting. Well, does that mean I need lens surgery? No, it's completely transparent. You see 2016 on the chart with the correction. There's no need to take this lens out yet. It's shifting, so I'll just adjust it for you on the cornea. No problem. 10-minute procedure, healed overnight, and then we'll see how it goes. Do you see how I'm thinking?
Yeah. So can I just ask a follow-up question on the same? Because whenever we will have a lens-induced change, although it can be a small, let us say, roundation of the bipolar areas, or it can have nuclear sclerosis early, this is also going to induce a bit of spherical aberration, right? So basically, then when you plan for enhancement, then how do you counteract that?
So the software does it for you.
Okay.
So basically, we've designed the software so that it's one button. You put the spherical aberration of the eye into the software, you push the button, you do the LASIK. So whatever the spherical aberration is of that eye at that time, it calculates what it needs to do based on what you're about to do.
Got it. Thank you.
Thank you. Dr. Maz? Sorry.
You do a lot of smile. You have a MEL as well?
Yeah.
Wow. But you don't have presbyond.
Yeah. So basically, we had an evaluation period for presbyond. We used it for about 3 months, I guess. This was recent. And now we are actually, because of the COVID times, we have been waiting actually to take a call on whether to shift to presbyond yet or not. Yeah.
Right. I mean, you know, my advice has been, because we noticed over the years, and then that's why we started the course. we only started the course, who has time for this stuff? We only started the course because we realized that Presbyon trials were not working well. And that is probably because the application specialist is it is a criticism of Zeiss, but it's no criticism of Zeiss. It's a very medical, it's very medical and very clinical, the process of qualifying a patient and managing a patient. And so Presbyon is not, I would say, that Presbyon is not a software. Presbyon is a system. The software is in the middle of the system. So Presbyon is doing the +150 test and refraction in a specific way, then doing the surgery, then counseling the patient in an appropriate way, then doing the surgery, and then reinforcing the pre-op counseling during the adaptation phase. And then knowing what to do next if things aren't, the patient isn't happy. So it's the whole system that has to be understood. It's not just install the software and do LASIK. So I would, I hope that when you next fire up, you make sure that we've got the whole system, which involves your optometrists. That whole system needs to be installed into your clinical setting so that you can have the sort of results that we're getting.
Sure. Thank you.
Hi. Am I audible? Good afternoon.
Yeah.
Yes. So my first question is that in India, we tend to have a little lesser central corneal thicknesses. So do you advise PRK Presbyon? And is there any difference in outcome if you're doing Presbyon with PRK versus Presbyon with LASIK? That's my first question. And my second question is that since you're doing it in people who have already crossed 40, is your selection criteria a bit different, or I mean a bit lax than what you would have a selection criteria for, say, a 18 to 25-year-old patient going in for a simple LASIK as such? I'm telling you this because the chances of keratoconus at this kind of an age would be, much lower than what you would have, say, someone less than 25-ish as such. So
yeah,
would you decrease your central corneal thickness selection criteria, or kind of, have something different vis-a-vis someone who's going for a primary LASIK?
Yeah. I mean, basically no is the answer. Form first keratoconus is form first keratoconus. And I don't care, I think someone could be stable with form first at 45, and then you can destabilize them by removing tissue. So, and by the way, we all now know that just because SMILE leaves the cornea stronger doesn't mean you can do SMILE in someone with form first keratoconus. We learned that the hard way, right? There's 5 papers on this now published. So no, the criteria for LASIK are the same for young and old. Before I never got on the intralase bandwagon. I didn't think that the intralase I didn't think it was even as good as the Hansatome. I thought it was worse than the Hansatome, so I never switched to the intralase. But when the Visimax came in 2007, I did switch to that. And this is 5 years before we were doing SMILE, right? Because for me, as a flap cutter, it was so accurate. And I mean, I actually didn't, initially I said to Zeiss, I'm very happy with my Hansatome. I have a super low complication rate, 1 in 3,000. I don't want to invite a whole new set of problems at a great expense. And they said, well, could you please at least do a study with your Artemis? We need to know the precision of the cuts. And so we did the study, and I was so impressed with the accuracy of the flaps. Well, obviously they're accurate, otherwise they wouldn't be able to do SMILE, right? So that at that point I said, okay, you know what, let's talk turkey here, because I think I'm going to have to buy this thing. So what happened was that I went from doing about 10 to 12% PRK because of corneal thickness problems, because of the Hansatome, to 1% PRK once I had the Visimax. And the reason is that the Visimax can cut 80 micron flaps. And 80 micron flaps mean that you pretty much never have to do PRK again. Think, if you make an 80 micron flap, that's 30 microns of stroma, right? 50 microns of epithelium, 30 microns of stroma. Now you do have to learn some special ways of making sure there's no microfolds in an 80 micron flap. And I tell you that at the beginning, I wasn't successful, but we did learn special technique to make the 80 micron flap, no microfolds. Once you do that, you see in our book, if you have a cornea that you're doing PRK in because of corneal thickness issues, we do not leave the cornea less than 350 microns at the end. In other words, 300 microns of stroma. With LASIK, we leave 250. So if you're doing an 80 micron flap and you've left the cornea 350 total, you're leaving 280 or 270 of residual stroma. So there's no situation where, because of thickness, you can't do LASIK, as long as you can make an 80 micron flap. Now, one of the aspects to be aware of in 80 micron flaps is that you need to measure the epithelial thickness profile of every patient before you make an 80 micron flap, because if someone has 65 micron thick epithelium, they're an outlier. That 80 micron flap is way too little stroma. And so we have been using epithelial screening for keratoconus for many years. That's one of the great discoveries of applications of epithelial thickness mapping. And I would say, especially in India, where the incidence of keratoconus is so much higher than it is here in Europe, distinguishing equivocal topographies as being keratoconic or not is the very best way of doing it, is by looking at an epithelial thickness map, because that will give you the red light or the green light. There's no orange light in the middle. If you have the epithelium, it's red or green. So you have your epithelial screening, you got your myope with a finished cornea, you make your RST calculations with an 80 micron flap. You can say, I can do this with an 80 micron flap. And then you got the epithelium is 60 microns in the middle. And you go, wait a second. This epithelium is 7 microns thicker than average. So I'm going to program an 87 micron flap so that I don't cross into the epithelium if the flap happens to be thinner, et cetera, et cetera. And you're now cutting the same amount into the stroma that you would have been before. Okay? And you've got your 80 micron flap leaving 350 is your 270 residual. So you have 20 microns to play with at the bottom there. Okay, that's a little bit of LASIK math, but I hope that, does that make sense? Absolutely. So the only other thing that is different about older patients having LASIK, but it's not different, it is different and it isn't different, is that obviously in older patients, you're going to be spending more time optimizing the ocular surface, because most people show up with a non-optimized, well, 50% of people over the age of 50 have a non-optimized ocular surface. And so in young patients, it's more unusual to need to optimize their surface before LASIK. But in older patients, well, it's part of the program. So we see patients at the first visit and we say, we need to optimize your ocular surface. We're going to take these measures. Let's do this. We'll schedule another visit, which we call a dry eye review. And the second visit, okay, the eye is good now. Now we can talk about having surgery on your eye. And by the way, Presbyon is 2 visits pre-op, not 1 visit pre-op, because you have to do the refractions in a certain way, and then you have to check them again. And if you do that, you get the success rates that I'm getting, that Sri Ganesh is getting, that everyone's getting. And that extra visit sounds like a lot of chair time, but it isn't. It's very short because the testing is very quick. But what it does is it saves you on enhancements. It saves you on a lot of things that you would have otherwise be doing afterwards. So there is always an opportunity for optimization of the ocular surface. But you know, there's a folklore about, no, you can't do LASIK in older patients. I mean, I got a German colleague who is the head of a big chain of eye surgery clinics, and he says you can't do LASIK over the age of 50. And I mean, we've had public arguments about this, and it's crazy because 54% of all of the LASIK that I do is in patients over 50. Because I'm doing presbyon. So someone who tells me you can't do it, it's like the guy's on another planet. Of course you can do it, but you have to be careful. You have to optimize the ocular surface. Kumar.
Thank you. I just had a question. If you have a 55-year-old, very, very early mathematical cataract in one eye and no cataract in the other eye, why wouldn't we select a lens-based procedure like eye-hands with no financial interest, which improves contrast? Because no corneal procedure is going to improve contrast. So what's your take on
whoa. Hold on a second. Eye-hands should be paying me a royalty.
Okay.
No, I'm serious. I mean, I didn't patent this idea because I thought it was just, you know, a contribution to the scientific field. But I should have patented the idea because eye-hands would have to be paying me now. Okay, eye-hands is a one size fits all spherical aberration IOL. It is a good IOL. It's based on presbyon. Thank you very much. You're welcome. So there's nothing wrong with the eye-hands. But what's the accuracy of your IOL calculations? I don't care if you're Warren Hill. Your accuracy is not even close to the accuracy of LASIK. Your control of cylinder, not even close. The lenses don't even come in the right sizes. You have to choose which postoperative cylinder you want to leave in the eye. You know, so look, intraocular surgery is wonderful.
What about contrast?
Yeah, I mean, I showed in my slides. Contrast in general goes up when you do presbyon. It doesn't go down. It's control of spherical aberration, not excess spherical aberration. And by the way, contrast does not go up with the eye-hands more than presbyon. It's less. And how do I know it's less? Because regardless of what IOL you put in, even in a monofocal plain IOL, there is in a clear lens exchange, we know from the publications that are coming out that there's a 3 to 4% loss of 2 lines of best spectacle corrected vision. And that's because the capsule and the unnatural synthetic lens do not transmit light as well as the untouched capsule and the normal lens. But there's no argument between us on a lens that's shifting refraction. Well, then you got to take the lens out, or a lens that's opacified. There's no argument between us because all I'm saying is that in the absence of significant refractive shift of lens and in the absence of lens opacity, the best starting point is presbyon, because you can always do the cataract afterwards. That option is a virgin option forever. And your advantage is already in the eye. You've got the 1.5 diopter depth of field already. So you're preparing the patient for a better cataract surgery. And you don't have to pay extra for an eye-hands. You can put an SA60 in. Or, you know, in India, you have amazingly good IOL manufacturers, even better. Biotech, they make fantastic lenses.
And is there a way of sorry.
I wanted to ask Praveen's opinion. Sorry, Praveen, I wanted to ask your opinion on presbyon and whether now you're convinced to stop doing PRK after what Dan told us.
Oh, the PRK. Sorry, somebody asked about that with the thin corneas. Well, oh, sorry, I got stuck because I was talking about 80 micron flaps. We don't have to do PRK. So there isn't a publication yet on PRK presbyopia. We have really, like I say, we do 1% of our surgeries are PRK. So I don't even know if we could even collect enough patients to publish that. There is no theoretical reason why you shouldn't do PRK presbyond, but realize that the software is written for LASIK. So what that means is there's no PRK button on the software, which means that you will need to program the presbyond minus 20% data entry. So if it's a -5, you don't put -5, you put in -4 for PRK. You have to take 20% off the data entry of the sphere and cylinder, because in like on the MEL 80, MEL 90, if you're doing, your CRS master, you click whether you're doing PRK or LASIK. All that does is it switches the nomogram 20% lower for PRK. The wound healing is different. The epithelial dynamics post-op are different. So that's why it's a different nomogram. Once your nomogram is adjusted for your LASIK presbyond, if you're going to do PRK, subtract 20%. But there's no physical reason why it shouldn't work. It's the same.
And one question, is there a way of simulating what the patient might see post-operatively by inducing spherical aberrations, say in a pair of glasses or contact lenses or something like that before you actually offer the surgery to the patient?
Of course, there's a way. You can buy an adaptive optics system and show it to them like that. Or you can show a graph of the study that was published in a peer-reviewed scientific journal showing that patients have increased depth of field when you change the spherical aberration. I mean, there's no, look, here's one of the fantastic advantages of presbyond is that you don't do contact lens trials. You almost mustn't do contact lens trials. That's the advantage of presbyond. It's called the Reinstein plus 150 test. Once you do this plus 150 test, which takes 5 minutes to do, you are demonstrating to the patient that they totally don't see the difference between the eyes. You're showing it to them in this test. So the way we do this test, and again, if we had the 4 hours, I could show you the test and show you a video of a patient, practically all of the patients where you do this test, the test is about surprising the patient about the fact that the eyes were not the same. So it's like a magic trick. You sort of like, you sort of show something and then they're looking over, you've got your little object here, right? And you say, okay, look at the object, and we're just going to take the object and we're going to blow and it goes away. And it's like a magic trick. You say, okay, read there. Oh yeah, is that okay? Reading the 2020. Okay, read here. Oh yeah. Oh, I can see the tiny print. Okay, now look in the distance. Okay, now look near. Now look at the distance. Now look near. Yeah, you see that? You can see everything. Did you realize that? That this eye was blurred? And the patients, 97% of patients go, huh? Wow, no, I didn't realize that. So the test is designed to demonstrate to the patients that they're going to tolerate it. So there's no need to do some adaptive optics thing. And it's 5 minutes. That's the other thing. I said it earlier. The Dell questionnaire, the Vivio glasses to measure the distances that people are doing during their daily lives. Do you prefer near or do you prefer intermediate? Do you want to drive at night? All of this, the complicated, fluffy process to decide which multifocal to put in is gone. We have a 5-minute objective hard endpoint test that tells you green light or red light. And over 95% of the time, it's green light. And it's a hard test. It's a hard endpoint. It's an objective way of knowing whether a patient can have the procedure or not some kind of fluffy subjective. And it doesn't leave hanging in the air this possibility that that the neuroadaptation won't work, and now you're really in trouble because the lens exchange surgery is, let's be honest, it's not risk-free. But an enhancement is not risk-free, but it's a hell of a lot less risk than a lens exchange surgery. And if you have to make an adjustment because they didn't adapt it 1 year and the chances of that is only 3%, well, then you just make a little adjustment. No big deal. No one got hurt. You know, do you see all of these questions are coming from our previous experience with monovision and with cataract surgery. And I'm trying to say, look, guys, we have a new paradigm here. We have a paradigm where we're able to find a static solution that overcomes the loss of the dynamic process using a natural aberration that will then be useful in the future when you get the cataract. It's a win-win-win situation for the refractive surgeon and the patient. I mean, I don't feel very strongly about this, you know.
Not very, yeah. But before you ask the question, Maz, I just wanted to let you know, Dan, that there are about 300 delegates listening in on this fantastic discussion. So going to be a lot of take-home points from what we're talking about. So thank you for all of that. And go on. I think, Maz, you were asking a question?
Yeah.
Or Vardhaman? Yes.
Dan, if you see a patient with a cataract and you wish to plan a cataract surgery with a presbyon, what would you do first, and what would be the time interval between both the procedures?
Oh, I just remembered a question that was related to this. What formulas do you use after the presbyon? And the answer is, it's the same as LASIK. So, which means that the Barrett-True-K is the best formula. So the Barrett-True-K works amazingly after presbyon for hitting targets. And our patients that we do cataracts on after presbyon, we set them plano minus 150 with the Barrett-True-K, and our enhancement rates are super low after that. So I just remembered that. Sorry, it's really early on Sunday. What was your question?
So you see a patient of cataract, and you
cataract,
and you have to plan a cataract surgery. So
that's right.
What would you be doing first?
Right.
The presbyon or the cataract surgery, and how much time interval would you be giving between the two?
Very good question. So, you know, there's exceptions to this, but the general way that we approach this is a patient who says, yes, I don't mind the cost. I want the best vision. So please do me premium cataract surgery. No, really. Okay, fine. So what does that mean? That means that we generally will target a hyperopic outcome after the cataract surgery with the monofocal IOL. And how much hyperopia? Well, you know, I'm a little bit mathematical about this. So I look at the spherical aberration on the cornea, and I know how much spherical aberration I can induce with a hyperopic ablation with the presbyon. So I kind of calculate everything to optimize it. So essentially, you would be putting, on average, I'm going to talk about on average, you'd be putting about a plus 125 into the non-dominant eye as a target, and a plus 175 into the dominant eye as a target. And so you need to explain to them, remember, these are cataract patients, right? So they can't see with the glasses. So you give them 2 wow factor moments. First wow factor is they're wearing glasses and they have cataract. And then after the surgery, they're wearing glasses and they have no cataract and everything's so bright and they love you and they think you're a genius. And then you wait and make sure that there's going to be no PCO, because if you do a YAG, you could shift the refraction slightly. So I don't know how long that's going to be for you where you are with your lens, but you know, if you have no epithelial cells and you do a good cleaning, a good polishing, and you have low PCO rate with that great square-edged old lens, then 6-8 weeks later you can do the presbyon. And here's the advantage: LASIK is more accurate than Barrett-Trouquet, Hill, RIB. All of the equations on the planet are not going to give you the accuracy of LASIK. So you nail the refraction with your LASIK, and you don't mind if you end up a little more or a little bit off with your IOL calculation, because you're going to nail it later with the LASIK. Does that kind of answer everything there?
Perfect. Perfect.
Yeah, Vardhaman, you had a question as well for that.
Yeah. So I just wanted to know, basically, like after people have undergone presbyon, how many of them eventually have demanded a reversal because of non-tolerance, and how many eventually undergo a reversal procedure?
Right. So we have done over 7,000 patients. So 14,000 eyes, but it's 7,000 patients since 2004. 6 patients have had a full reversal, both eyes for distance.
Wow.
It's very rare. 3% are not adapted at 1 year. And that's the plano ones, by the way, because the planos are the ones that least adapt. The other, it's lower for myopic and hyperopic patients.
Right.
What happens to those 3% of patients? And I realize I should publish this, but I'm just telling you this off the top of my head here. What happens to those patients is one of two things. We either, let's say someone is plano and minus 150, exactly on target. So there's nothing else we can do refractively, and they don't adapt. That patient has two options. Either we reduce the minus 150 so that instead of J1, they have J3. So you make it -1 or -0.75. And now they have J3 vision, or maybe J5, but they still have near vision. Or, and this is the 2/3 of the patients of those 3%, 2/3 of those 3%, they say, you put the contact lens in to say, well, I will take away a little bit like this. And you put the contact lens in and they go, oh, that's so much better. Thank you. Oh, I really want that. And then you give them the chart and, you know what? I think I'll just stay like this. Can you take the contact lens out? And then they say, don't do the enhancement. And then you prescribe the glasses, and they wear the glasses driving at night or whenever they need to have more binocularity. So our experience is that there isn't a problem if they don't adapt. And anyway, it's very few people, because there's always a solution. Either they accept the small discomfort that they have, and they accept that they can reverse it instantaneously with glasses anyway, or they get a minor adjustment and slightly compromise the near vision. But remember, they're getting the same near vision after a compromise that you would expect from a Zeiss trifocal in a restaurant. Because trifocal lenses don't work well in dim lighting. So it's like the compromise that we're like, oh, we're compromising. We have to make it -1 instead of 150. That's called a success on a trifocal eye. So our standards have been completely distorted in the presbyon world versus the outside world.
Sure. All right. Thank you.
But you're asking, you guys are fantastic. It's you don't have to take the course anymore. You've now asked all of the questions. I can't think of something that I haven't, except the actual +150 test, which does take a good half hour to explain. But once you understand it, it's very nice. Kumar, am I going to get Kumar to go over to Pravin to get presbyon, and then Pravin to go over to Kumar to get presbyon? Is that what I'm going to do? Or both of you go to Sri Ganesh? Or both of you go to Sri Ganesh?
Yeah, the both of us are going to come to you.
you know that it's on the internet. You know that how this happened with Sri, right? Because this was pre-COVID. Do you remember the time when we used to travel to meetings? And you can imagine, I love meeting people from all over the world. It's part of what I love. So when people ask me to visit, I go. However, it was getting a bit too much. It was really getting a bit too much. And he called me in September. He says, can I speak with you? And I was like, sure. And I called him up. And he said, Dan, I run a meeting every year at the end of November. And we have about 500 ophthalmologists, and we do live surgery. And I'd like you to be a keynote speaker. I said, oh, Sri, end of November is hard for me because I have my course the week before, and then it's Christmas, and it's really hard for me to get away, all the way to India for a weekend. He says, well, the thing is, I want you to do live surgery. I said, oh, well, all right, well, that's interesting, but I don't think I can do it. Well, the thing is that I want you to do live presbyond on my eyes at the conference. And I said, really? Okay. Okay, now you're starting to, okay, tell me more. He said, well, on the Saturday night, we have a big celebration, and you're going to bring your saxophone, and you're going to play with an Indian classical music group. Okay, I'm coming to the conference. So we did his presbyond at about 4 p.m. on the Saturday. And you can watch the thing on the internet. He put the thing on YouTube. And he was reading the small print on the Toberdex bottle as he sat up from the table. He was about a plus 175. And that evening, he was at the ceremony, and I played the saxophone with the Indian classical band. And the next morning, he was doing a small stuck down pupil, hard cataract, femto, phaco, the next morning. So it really was stretching our luck, in every possible direction. And it was a great weekend.
I was there.
So,
really?
Yep. I think we are almost out of time. We actually had planned a 1 hour long panel discussion, but I think, Dan, there's so many questions about your talk that became the panel discussion. And I think it was very, very insightful, a lot of learning points as well. So thank you again very much for being here for the entire session. And thank you for sharing what you did about presbyopic LASIK. Thanks, Dr. Kumar, Dr. Gaurav Luthra, Syed Maaz, and also Vardhaman Kankaria for being on the panel and asking such fantastic questions. So we'll have to move on and hand over this virtual hall to the next group of pediatric ophthalmologists who've been listening to our discussion for a while now and trying to figure out what these terminologies actually mean. So wish them luck, and thank you very much again, Dan, and have a good weekend.
Thanks, Praveen.
Thank you.
It's really nice being there. Thank you.
Great fun. Thank you so much.
Thank you.
Thank you.
Yes, Dr. Ramesh, sir, you can start, sir.
Okay, we can start. Okay. So good afternoon, everyone. Very warm welcome to this Strabismus for Everyone session. We have great speakers lined up for today to cover the practical aspects of strabismus for all of us. Before Dr. Aloka introduces, there'll be 5 talks of 6 minutes each, and then at the end of the lecture, we will have a panel discussion. I'm very happy to share that Dr. Aloka will be the co-moderator with me. Now I request her to introduce the speakers and move on with the program. Thank you very much for all the speakers and Aloka. Aloka, can you unmute?
Yes, I did. Can you see my screen?
Not yet.
All right.
Yeah, it's coming.
Thank you. Yeah. So we have a great panel today. First is Dr. Divya Natarajan. She's a consultant in pediatric ophthalmology, strabismus, and neuro-ophthalmology in LV Prasad, Visakhapatnam. She has special interest in complex strabismus surgeries. Next is Dr. Pradeep Sharma, who of course needs no introduction. He's a professor, head of pediatric ophthalmology, strabismus and neuro-ophthalmology at RP Center, AIIMS, New Delhi. He has more than 200 publications in national and international journals. He has several awards to his name, and he's the author of the Bible or the Granth of strabismus for all fellows around the world, called Strabismus Simplified. Dr. Federico Velez, welcome. He is the Associate Professor of Ophthalmology, Pediatric Ophthalmology and Strabismus at Duke University, Durham. He has multiple papers, and the most prominent and the recent one is Preferred Practice Pattern in Adult Strabismus Surgeries, released in Jan Ophthalmology 2020. Dr. Kavita Kalaivani, she is the consultant at Shankar Netralaya, Chennai. She is amazing in complex pediatric cataract surgeries, and she's been the mentor and guide to a lot of pediatric ophthalmologists in this country. Next, I welcome Dr. Lionel Cowell. He is the Director of Strabismus Services, Royal Victorian Eye and Ear Hospital, Melbourne. He has several papers, grand round publications and letters in several reputed journals. And very specific to this talk today, he is the author in the book Refractive Surgery and Diplopia chapter, which is in step-by-step LASIK surgery. So with this, we move ahead. I invite Dr. Divya to start her talk, 6 Pearls for Strabismus Evaluation.
I'll be talking about basic evaluation in a case of strabismus. Obtaining a careful history is often the first and most essential step in evaluation. The common complaint is an obvious deviation. Patients may also sometimes complain of decrease of vision, especially in one eye, symptoms of asthenopia, or double vision. It is important to note the age at which deviation was first noticed, whether it is constant or intermittent, whether it is noted only in one eye or is alternating, and whether it is more for distance or near. Birth history, significant antenatal events, history of prematurity, development history, and family history should be obtained in every case. History of previous or ongoing treatment, classes or patching or previous surgery should all be documented well. Old photographs provide a valuable clue to the ophthalmologist regarding the onset and type of squint. On inspection, an anomalous head posture may be the first clue. There may be a chin elevation or depression, a left or right face turn, or head tilt. Anomalous head posture is commonly seen in patients with a fixation preference, in incomitant or pattern deviations, in nystagmus, or sometimes even in an uncorrected refractive error. Inspection of lids and lid fissures is essential. What may look like an esotropia may just be a pseudo-esotropia because of the epicanthal folds or characteristic lid slants. Ptosis in one eye should be carefully examined. There may be a hypotropia of that eye with an elevation restriction, as in a case of monocular elevation deficit. Assessment of ocular motility involves testing of eye movements in all 9 gazes. There are 6 cardinal positions, each primarily obtained by the action of one muscle, and movement of the eye along that position gives us an idea of the action of that muscle. Here is a video that shows normal ocular movements in all 9 gazes. This should be done in every case for strabismus evaluation. During the movement, the extent of the eye movement as well as the normalcy with which the movement is achieved should be looked for. Comparatively, this video shows the large abduction deficit in the left eye. This is a case of left 6th cranial nerve palsy. The restricted abduction is also seen in levo elevation and levo depression. There may also be an oblique muscle overaction that can be seen as an exaggerated elevation or depression in adduction. The presence and amount of deviation can be assessed by corneal reflex test. A simple method is the Hirschberg corneal reflex test. This gives a rough estimate of the amount of deviation based on the decentration of the corneal reflex. If the corneal reflex is at the center of the pupil, there is no tropia. If the reflex is at the pupillary margin, there is a 15 degree of deviation. If the reflex is between the pupillary margin and the limbus, there is approximately a 30 degree of deviation, and if it is at the limbus or beyond, there is a 45 degree of deviation. Various cover tests establish whether there is a squint, the type of deviation and the amount of deviation, as well as the fixation behavior. Cover tests should be done for distance and near with a fixation target. Sometimes it should be done in all 9 cases. Cover test establishes a manifest squint when, on covering the fixating eye, the deviated eye takes up fixation. If there is no manifest squint, then a cover-uncover test is done to look for a latent squint when, on uncovering the eye, it quickly takes up fixation. A latent squint or a DVD can be clearly noted through a translucent occluder. An alternate cover test measures the total amount of deviation. Each eye is alternately covered, which brings out the manifest and latent squint in the eyes. The right amount of prism strength placed over one eye now neutralizes the deviation, and there is no further movement. So this is the final amount of deviation for which surgical correction can be planned. Examination of the sensory state of the patient tells us how the patient has adapted to these motor anomalies. These include tests for suppression, anomalous retinal correspondence, and stereo acuity, and must be done in all cases to assess the sensory functioning of the eye. Complete refraction, pupillary examination that can give a clue to the optic nerve function, anterior segment, and fundus examination must be done in every case. If there's a high myopic refractive error, look closely. There may be an esotropia with a restricted abduction and elevation. This is because of the nasal and inferior shift of the muscles due to a large globe in myopia and is known as myopic strabismus fixus. This needs to be surgically corrected. To summarize, good history taking, inspection for anomalous head posture and lid changes, visual acuity and refraction, complete motor examination, sensory examination, anterior and fundus examination completes strabismus evaluation. Thank you.
Thank you, Divya, for that crisp presentation. Now, having known that how to evaluate a strabismus, the next important thing is, what are the non-surgical management plan for a strabismus case? So now I invite Dr. Kavita Kalaivani to speak about when glasses can correct strabismus.
Very good afternoon to one and all, and I thank Dr. Ramesh for this opportunity. So it's a very important talk, actually, important topic, because as we all know, strabismus is not only a surgical problem. The spectacles and strabismus, when and how, that is how we'll go about this topic. So refractive errors and strabismus, how are they connected? So when I say strabismus and glasses, I mean refractive error. So how all can they be related? So refractive error correction can sometimes prevent a strabismus entity from occurring. Sometimes it can act as a cure by itself. Sometimes they just simply coexist, a refractive error and a strabismus. And rarely a strabismus can be caused because of a refractive error correction. So we'll see each one, how they do it. So prevention of a hyperopic refractive error correction. So how does prescribing a hyperopic correction prevent strabismus? So in the setting of a moderate hyperopia and or moderate anisometropic hyperopia, a hyperopic correction prevents the onset of sometimes an esotropia, an impending esotropia. Similarly, a strong family history of accommodative esotropia, when you see a hyperopia in a child with a sibling of accommodative esotropia, correcting the hypertropia prevents probably the onset of an esotropia later. Esophoria can be a pre-runner of a esotropia in the presence of a hyperopia. So all these situations, a hyperopia correction prevents probably the onset of esotropia. Similarly, intermittent esotropia, the presence of hyperopia, a correction of the refractive error might prevent the onset of esotropia. Similarly, when there is a myopia, does that have a preventive role in strabismus manifestation? Yes, sometimes large exophoria and myopia, when they coexist, correcting the myopia itself may correct the phoria. Similarly, early onset or early presentation of intermittent exotropia, when they have a very good control and we find a mild or moderate myopia, correcting the myopia can sometimes actually correct or prevent the onset of manifest exotropia. Similarly, an anisometropic myopia correction can be a preventive measure. So when we saw prevention, so does strabismus get cured sometimes with just correcting the refractive error? Yes, very often we see situations, especially when hyperopic refractive error is more than mild. In a situation of esotropia, typical in a situation called accommodative esotropia, where a hyperopic correction corrects the esotropia, sometimes fully when it is called a fully accommodative esotropia, sometimes partially when the esotropia gets partially corrected by glasses and needs additional treatment for the residual esotropia. And sometimes you need bifocal correction when the esotropia is distance and near has a larger difference when the presentation is with a high AC by ratio. So similar in this situation, a hyperopia correction actually is the main treatment for the esotropia. And we see a lot of situations where there is a residual esotropia, post-infantile esotropia surgery children who present with hyperopia, and correcting the hyperopia sometimes takes care of this esotropia. So we see a case scenario of a 4-year-old child with esotropia presenting since 4 months, a refraction of +4 in one eye and +5 in the other eye, with stereopsis reduced and Wirth dot showing left eye suppression, having a prism deviation of 30 prisms for distance and 45 for near. So this is a very typical situation where we see a moderate hyperopia with a little anisometropia and a deviation which is more for near. So here the step 1 which we follow would be to correct the full hyperopic correction and see what happens. So child becomes orthotropic for distance, but then esotropia is there for near. So here probably the AC by ratio is high, and as we see it is 6. So the next step what we do is give a bifocals with +3 add and then see what happens. It becomes orthophoric for distance and near. So this is a very typical situation where a hyperopic correction is helpful for the correction of esotropia, which is with high AC by ratio. Similarly, myopia in intermittent exotropia with good control can sometimes cure the myopia, and myopia can sometimes be used as an over minus therapy in treatment of intermittent exotropia. And sometimes myopia can be associated with high AC by ratio, where bifocals in this situation can be a cure. Other situations where unilateral sensory conditions like corneal scar or pseudophakia, aphakia, when it is unilateral or bilateral, correcting the refraction can help or improve a strabismus entity. So when you prescribe, how do we prescribe? A hyperopia, always full correction when there is esotropia or in pseudophakics and aphakics, but under correction in orthotropia and esophoria. Whereas myopia, almost always full correction, but over minus therapy can be prescribed in IDS up to -2 in each eye. And astigmatism, whenever significant, always full correction, though it does not directly have any role in management of the strabismus. So like I said, esotropia, exotropia, if there is a hyperopia and myopia, how do we go about it? If there is an esotropia, you correct whatever refractive error is there, full correction is the rule. But exotropia, you can undercorrect the hyperopia, but myopia, always full correction. So can spectacles cause a strabismus? Like I said, very rarely spectacles can actually cause a strabismus, especially in accommodative esotropes when we do not get a good follow-up. Sometimes the hyperopia can actually reduce, but undetected, so a consecutive exotropia can happen. Hyperopia correction in the setting of IDS can sometimes make the exotropia constant. If overcorrected myopia can sometimes cause an accommodative spasm and esotropia. Consecutive ET can become a problem in over-minus therapy. And of course, like esotropia and high myopia is a very known entity. And sometimes glasses in the form of prisms can also be used as a glasses, diplopia, and when there is an abnormal head. Oh my God. So managing strabismus is not always surgical. Numbers can do really wonders, but watch for adverse effects. Sorry about that little overshoot. Thank you.
Aloka, you can unmute, please.
I'm sorry, Dr. Kavita, thank you for holding your breath and going through the all the slides and teaching wonderfully as usual. I invite Dr. Pradeep Sharma to take the next topic, which is paralytic strabismus. What can I do as a general ophthalmologist?
Thank you, Aloka. So in this session, we are going to talk about diplopia mainly. And as we all know, we have to first step is to see whether it's monocular. As you all know, many of the conditions have been talked about and they can be causing it. In binocular diplopia, which is mostly the realm that we have to delve into, it may be because a myopathic problem or a neuropathic problem in the form of nerve palsies or even restrictive strabismus. So in concomitant strabismus, we may have either paralytic or restrictive. Spastic is very rare. And they should be distinguished primarily from one single observation that in restrictive, the passive ductions are restricted and limitation is much more than the deviation. Whereas in the paralytic squints, the limitation and the ocular deviation are almost pari passu or compared to each other. The other thing which in the glasses, Dr. Kavita did talk about, but I would like to stress, sometimes it can be because of decentration of normally properly prescribed glasses also. If they are decentered, it can cause a binocular diplopia. So that should be always kept in mind. Like in this case, she had a ESO because of the glasses. Whenever you have a paralytic strabismus, you should look for the fields and the fundus for papilledema, and even a simple confrontation fields in the OPD setting would be very helpful. When we talk about third nerve palsies, you all know it's a very complex problem. It gives interaction of so many muscles. But primarily, I would like you to focus on these steps. One is the pupillary reaction. Always look for that. It can distinguish whether it's an ischemic or a compressive pathology of the third nerve, whether it's partial, total, or recovering. So notice that in a partial, even pupil sparing should be watched for another few days. If it's a ptosis, look for unilateral or bilateral. It can differentiate between a fascicular and a nuclear type of third nerve palsy. Any aberrant regenerations would again have to be looked for. Any associated cranial nerves or other neurological problems, look for it. When to do imaging in these cases? All acquired pupillary involving cases should be imaged. If there are pupil sparing, also we need to do an imaging if these red flags are there, less than 50 years, incomplete nerve palsy in which follow-up shows pupil involvement, additional neurological features, children less than 10 years. Any aberrant regeneration is indicative of something more than just an ischemic problem, and if it's not improving in 3 weeks. So the pupil sparing cases specifically look for ischemic causes, hypertension, diabetes, coronary artery diseases, hyperlipidemia, or even nowadays the hyperhomocystinemia, which may be a problem. Observe for 5 days for these pupil sparing. If there is a delayed pupillary involvement, you have to be aware of it. Recovery will usually begin the pupil sparing in 3 to 6 weeks time, and by 3 months they are almost fully recovered. If no recovery is occurring, or the pupil starts dilating, or other telltale signs as we talked about are happening, then you have to do an immediate MRA or CT NG. In third nerve palsies, we have to be looking for realistic goals. Then in these, simple R&R would be there, and that will be nowadays application may be preferred rather than resection. In supramaximal recessions of lateral rectus sometimes are not enough. So what we have learned from Velez and Rosenbaum's group, that you can do a periosteal fixation of the lateral rectus in order to totally take away the action of the lateral rectus. A newer procedure which has come to our fold is a split lateral rectus shifted to the medial side and anchoring or giving the action on the medial side, as is being shown in this schematic diagram. It works very well, but these are cases in which the lateral rectus is not very tight, and you have to be very careful while doing surgery that you do not create a problem of ischemia or venous stasis. In peritoneal palsies, you can do a periosteal anchoring of the globe, and aberrant regeneration cases, you may do a contralateral surgery. In the sixth nerve palsies, we have had the partial VRT with the cross action, or even the Nishida's procedure, which has come recently. And as already talked about by Divya, I would not go, but you have to be careful about these strabismus fixus cases. In superior oblique palsies, you all know the child will come with a head tilt, and you would do the movements in the different gazes and look for the upshoot. But don't forget the fundus torsion, extorsion, which you should be able to see in a case. And finally, in a bilateral palsy should be suspected whenever you have head trauma, you have torsion, which is subjective, 10 degrees or more objectively measured, alternating hypertropia and alternating head tilt test, a V pattern, esotropia is there, and a chin down head posture. So these features, if you see in any case of a supraoblique palsy, suspect a bilateral problem. And in such a case, we will have to do it little differently. The surgical options are mostly the inferior oblique weakening, which may be done by various methods. And nowadays we have the anterior nasal transposition to help us take care of even 3+, 4+ inferior oblique overactions. And sometimes, as we talked about, if you have a bilateral supraoblique palsy, when the vertical deviation is not much, but it's the extorsion which bothers the person in down gazes, it's very nicely relieved by Harada-Ito procedure, and you may do an adjustable Harada-Ito in one of the eyes. So in short, I would like to complete my talk here. You have to be a squintellectual. Even a complex problem like a third nerve palsy may be very nicely handled if you are able to take care of all the points. Thank you all for a patient listening.
Thank you, Dr. Sharma, for that squintellectual talk. It's not easy to cover the paralytic strabismus in this short period of time. And thank you for all the pearls involving all the 3 important cranial nerves as well as some of the difficult diseases. So we'll discuss about it in the panel discussion. One thing what has happened in the COVID days, the distance between all our colleagues in the world has reduced a lot. At one place, we have a lot of difficulty. We are all going through a difficult phase. But academically, that's a blessing where the distance has come down very significantly. So I'm very happy that Dr. Koval and my friend Dr. Federico Velez has joined, one from each pole of the world, from extreme east to extreme west. I'm very happy that both of them have joined. And yesterday in the webinar, they remember Dr. Koval saying that always learning, always improving. It's my pleasure to invite Dr. Koval to speak about annoying diplopia most of the cataract surgeons and refractive surgeons face. Over to you, Dr. Koval.
Good afternoon, good evening. It's late at night here in Melbourne, Australia. Can you see that first slide? New strabismus?
Not yet. Yeah, now it's opening up. Yeah.
Good. Can you just start the timer? Thank you. So today I'm going to talk about the topic you requested, new strabismus. New strabismus following cataract surgery or refractive surgery. Firstly, refractive surgery. Hyperopia in refractive surgery is difficult. It's difficult because you can make the patient happy by substantially reducing their hyperopia. But if you don't completely eliminate their hyperopia, it's inevitable that the hyperopia will seem to return. When it returns, they develop blurred vision again, they get recurrent hyperopia, and they are at risk for esotropia. Cataract surgery and refractive surgery, anisometropia. If you have anisometropia before you start, for example, my patient there, right eye -8, left eye -2.5, if you reduce the anisometropia, some patients will have problems. They will have problems because axial anisometropia that is corrected in the spectacle plane is less anisoconogenic than if the anisometropia is corrected in the corneal plane or the IOL plane. So if you're planning to reduce anisometropia, you first need to demonstrate with contact lens simulation that it is safe to do so. Similarly, if you're going to introduce anisometropia, for example, give the patient monovision, some of your patients will have problems. And Zane Pollard has shown that the percentage of patients who have abnormal binocular vision following monovision, the percentage increases with time. In the 21st century, I see increasingly patients with abnormal binocular vision and diplopia after cataract surgery who have a combination of seemingly subtle, trivial, and insignificant motor, retinal, and optical problems. And because they have several of these, they develop abnormal binocular vision and diplopia. So it's common to have both motor cofactors and sensory cofactors. Common motor cofactors are pre-existing, hitherto asymptomatic small phorias, or acquired small misalignments. Sensory cofactors, common ones are anisoconia, and this can be optical from anisometropia or can be retinal, especially epiretinal membrane. And another common sensory cofactor is metamorphopsia. If you don't ask about these symptoms, you'll never get an answer. Metamorphopsia and anisoconia as sensory cofactors causing abnormal binocular vision and diplopia are very difficult topics. In some patients, metamorphopsia and anisoconia cannot be resolved. Yet in some patients, quite significant metamorphopsia and anisoconia seems to cause problems. So at the moment, there are no good guidelines as to how to manage these patients in advance. And some patients will have diplopia that seems to be precipitated by cataract surgery, but is unrelated to cataract surgery. Of patients over 60 who walk in my door with diplopia, 25% have sagging eye syndrome. Prostaglandin associated periorbitopathy is one of the common causes of sagging eye syndrome. A very under-recognized but very well documented cause in the literature of bilateral monocular diplopia. This can be seen after prolonged reading. So the patient who comes and tells you they have double vision after 10 minutes of reading, some of those will have bilateral monocular diplopia from the prolonged down gaze reading position. Field loss, of course, can cause retinal slip and diplopia. And finally, amblyopia. Cataract surgeons will tend to do the previously amblyopic eye first in a patient who needs cataract surgery. But that's probably the wrong thing to do, because by making the amblyopic eye visually dominant, the patient will be at risk of fixation switch diplopia. So these are some of the causes of diplopia that I get to see after cataract surgery and after refractive surgery. Thank you for having me.
Thank you, Dr. Lionel. I'm sure a lot of cataract surgeons are scared now of post-operative diplopia. Next, I invite Dr. Federico for strabismus red flag signs for general ophthalmologists. Dr. Federico.
Hi, well, good morning. And let me just share my presentation here. Can you see my screen?
Yes,
Not
we
yet.
can see it. Yeah.
Okay. Good evening. I'm Federico Velez, professor of ophthalmology at Duke University in Durham, North Carolina. I want to thank the organizers for inviting me to present this lecture on strabismus red flags. These are my disclosures, not relevant to this presentation. Red flag number 1, constant infantile exotropia in the first year of life is a red flag. Red flag number 2, acute onset esotropia, patients with a non-accommodative esotropia, not related to myopia, not related to occlusion, frequently associated to diplopia, comitant deviation, A-pattern esotropia, and a deviation that at distance is larger than at near. These patients require brain imaging. Red flag number 3, abnormal movements. Patients with nystagmus, vertical nystagmus, dissociated nystagmus, or acquired nystagmus are patients that require further workup, including brain imaging. Red flag number 4, acquired ocular motor palsies is well known. The third nerve palsy with a pupillary involvement. For patients with 4 nerve palsy, those that present with bilateral superior oblique palsy, underacting bilateral superior obliques with reverse hypertropia, large X cyclotorsion, B pattern esotropia, in a chin down position. For patients with unresolved 6 nerve palsy, recurrent 6 nerve palsy, or young patients with no risk factors. Red flag number 5, acquired ophthalmoplegia, as for example, this young lady with abducting nystagmus, mild limitation to A deduction on the contralateral eye, and a limitation to A deduction in a 1.5 syndrome. For this patient with hydrocephalus, A deducting nystagmus, bilateral 6 nerve palsies, and a large angle exotropia in ab gaze. Or this patient with an acquired immunodeficiency syndrome who presented with a limitation to A deduction. Patient was treated with antiretroviral therapy. Red flag number 6, patient with diplopia and neurological signs, like this adult male with a history of metastatic small cell carcinoma who is rapidly progressing to a left gaze palsy. He has normal convergence and he has contralateral nystagmus. There's ataxia, weakness, and a normal MRI scan. His antibody testing demonstrated a positive RE-ANNA2 antibody associated with breast cancer, opsoclonus myoclonus syndrome, patients with neuroendocrine tumors like the patient has, and also encephalitis. Red flag number 7, limitation to elevation, like this lady who actually has a Parinaud syndrome. Her bell's elevation is better than what she attempts to elevate, which actually causes retraction in elevation with esotropia. This patient had a demyelinated lesion in the midbrain. She was being treated with anti-TNF therapy. Red flag number 8, painful ophthalmoplegia, like this young lady who has limited A deduction in her left eye. Her saccadic movements are fast in the right eye, but her saccadic movements in A deduction on the left eye are mildly slow. This patient imaging demonstrated a large medial rectus muscle associated with myositis. And last, red flag number 9, patient with variable diplopia, like the case of this adult female patient who presented with a history of Graves' disease, no trauma, a normal MRI, and the ocular motility examination revealed a pattern of a consistent with a right superior oblique palsy. A week later, the patient had a comitant deviation, and 6 weeks later, she presented with a left hypertropia. At the same time, we noticed that her left eye conjunctival vessels were dilated, and he didn't have a brood. Here, images demonstrated that on the right white eye, she had an indirect fistula with posterior drainage, and on the left eye, she had an anterior drainage, indirect fistula. In summary, red flags include infantile constant exotropia in the first year of life, acquired esotropia, especially those who had larger deviations at distance, nystagmus, acquired, dissociated, and vertical nystagmus, acquired ophthalmoplegia, ocular motor nerve palsies, especially in the absence of risk factors or trauma, variable diplopia, painful diplopia, and diplopia associated with other neurological symptoms. I want to thank you very much for inviting me to present this lecture. It's been an honor. Thank you and have a wonderful day.
Thank you so much, Federico, for that wonderful pearls of showing what are the red flag signs. We have around 25 minutes of discussion, 22 minutes of discussion. So the first question I will start, maybe Aloka can see if there are any questions submitted. First, I will start with Federico. You said infantile exotropia is one of the emergencies and we have to investigate. What is your experience of getting any positive imaging finding or anything in these kind of patients? What are the things to look for in infantile exotropia patients?
Right. More than the emergency is that very different from the typical infantile esotropia, I frequently find that patients with infantile exotropia have other neurological problems. So I just want to be sure that the pediatrician is aware of it. And in this case, our general ophthalmology colleagues and other providers are aware that infantile exotropia is a patient that deserves further workup. The patient sometimes even require genetic testing, look for neurological symptoms, hypotonia. This is a very different patient. So even though it may be a common condition, I think is sometimes even overlooked. We frequently get referrals that are late because the patients were told that this was just a normal condition that will go away with time. And that's not the case with constant infantile exotropia.
Okay. Thank you, Federico.
The next question is for Dr. Lionel. In a patient with high myopia and strabismus, which one should be done first, the refractive surgery or the strabismus surgery? What's your take on this?
I would do the refractive surgery first because sometimes improving the refraction can improve the alignment. And I've seen this especially, say, with unilateral myopia and DVD. Just sometimes improving the refraction will improve the alignment. So improving the refraction will not work in a heavy eye syndrome. If someone has a heavy eye syndrome, I would probably do the strabismus surgery first.
Just to add on to that, Dr. Lionel, does it apply, the same rule applies for hyperopia and refractive surgery? Or do you do any selected, decision?
My selection bias for hyperopic refractive surgery is quite distorted. I tend to just see bad outcomes. I don't see many good outcomes, and I see Federico smiling. I'd be interested in your experience, Ramesh and Federico. Do you see many good outcomes from hyperopic refractive surgery?
Yeah, I would ask Dr. Velez and Dr. Sharma first, and then we can. Federico, do you have anything to say?
No, not really. I mean, the only thing that I said is that we have seen so many patients that decompensated from a refractive surgery and ended having a very bad diplopia or decompensated an intermittent or well-compensated form of strabismus. And after a monocular refractive procedure, they develop constant double vision that ended actually having to be treated with the strabismus. Yeah.
Dr. Sharma, any?
Agree that most of my refractive surgeon colleagues are not very enthusiastic for hypermetropic refractive surgeries. So that is true. I mean, they are not so successful in correcting that. Usually they have regression, but yes, if there are steady refractive error for consecutive 2 or 3 years, then one should, I think, go in for, I think when we are talking about that should be important when we're dealing with children, that we should not be jumping in doing refractive surgeries in children unless it is known to be constant for at least 3 years consecutive.
May I ask a question to Dr. Lionel, please? Sir, is there any, have you ever had an experience of combining strabismus surgery with the cataract surgery when they sometimes coexist, like long-standing infantile esotropia? And sometimes we do see some situations, and actually I have had a few experiences of operating together. So is that
the local medical legal culture in my country would not approve of combining those surgeries, so it would not be done.
I just had one comment about the previous question. Whenever it is decompensated, I think the refractive surgery does not really help. But I have a subset of patients where their refractive error is somewhere in the range of 3 to 5 at around 20 years of age, 18 or 20 years of age. They are fusing, and our refractive colleagues are okay to correct up till 4 diopters. I think in these patients, I have seen good success. In the selective group of this kind of patients, I've seen some success in terms of hyperopic refractive correction. Otherwise, it's not so encouraging.
I will make a comment, actually, but you're not going to find it because I'm sure it's impossible to find. But the very first paper I did in my life was actually treating adult patients with LASIK surgery. But there were like 4 patients. They were adults with accommodative esotropia and hyperopia. And these patients underwent LASIK procedure for hyperopia, and basically they resulted in well-compensated esotropia. I mean, basically they did not get better or worse. I mean, they were, but these were patients that had bilateral hyperopic refractive procedure, which is a little bit different from what I had mentioned, which is basically patients having monocular surgery or monovision just because of the need for the refraction.
Dr. Kavita, would you give any tips for a patient, say around 3-year-old with esotropia and say hyperopic correction of say +3, but the child is just not accepting the glass? Are there any tips that you can give to the ophthalmologist?
Yeah, that's a very good question. So when we face a situation where you need a hyperopic correction to be given prescribed fully, but the child refuses to wear the glasses, the reason could be some kind of an accommodation still playing and the child is not able to relax the accommodation. So we, in these situations, give a very short course of a cycloplegic like a homatropin for about 2 to 3 weeks till the child gets adapted to these glasses, since full correction is mandatory.
One question about the imaging. I think that's the question comes every time. I just want everybody to answer this particular question, all of you. In a patient of 6th nerve and 3rd nerve, what are your strategies to get imaging done? Is it all patients or is it selective patients? I will start with Dr. Sharma and then we can go to others.
I think I had the slides on that for third nerve palsy specifically, that if there are people involving third nerve palsies, we would like to do an imaging in all the acquired cases which are having a pupil involvement. If it's a pupil sparing, then you would like to differ. You may definitely do the blood test to rule out the blood pressure, diabetes, and all those other things. But you need to follow up for 3 to 5 days and see if the pupil is getting involved, because in some there may be a delayed pupillary involvement, and that would be an indication for doing an imaging. Those people who have a acute headache along with the acute presentation of third nerve palsies are the candidates who may be having an aneurysm. So in those, I think you need to do a CT angio immediately. Some of them may even...
Sixth nerve palsy, Dr. Sharma, anything on sixth nerve palsy?
Yeah, in sixth nerve palsies, again, like one thing is that I usually tell my fellows and residents never to forget to look into the fundus, as I had also mentioned. Papilledema is something which will lead you that something else is going on than just an idiopathic isolated sixth nerve palsy. But if there is no papilledema and there are no other signs which are neurological, then you may wait. But generally nowadays we see that people who are less than 50, it's better to do an imaging done. Those who are more than 50 and those who have other comorbidities like hypertension or blood pressure, which may be causing a monoocular ischemic neuropathy, those you may defer doing imaging. But in all the younger people, you should do an imaging even in sixth nerve palsies.
Dr. Koval, take on that?
Thank you, Ramesh. I don't think I've ever disagreed with anything Dr. Sharma has ever said, ever. But on this, I have learned from doctors who refer patients to me that with sixth nerve palsy, groups of patients that I would not have imaged for a month or 6 weeks, expecting that they have a microvascular cause that usually resolves. I have seen too many of those cases that have been imaged by the referring doctor and there has been a tumor. So this distorted selection bias that I have seen means that every patient who walks in my door with probable sixth nerve palsy is imaged straight away, because a significant percentage will have life-threatening pathology and a significant percentage will have sagging eye syndrome. And it's important to make that neurologically innocent diagnosis quickly, because it removes all anxiety about case management. Go on.
I would like to add that when you are thinking of a sagging eye or heavy eye, you may have to tell your radiologist specifically to do a little differently, because usually they will miss. They will give you a normal report because they are not expecting this nasalization of superior rectus. So you may have to tell them, this is what I have seen. Sometimes they get, unless they have been primed.
Well, certainly in my town, very few, I think there are 2 radiologists. My city is 5 million. There are 2 radiologists who can confidently recognize a sagging eye. And I always look at the films myself.
Yeah, I think most of the times the MRI is done, but it is not done what to look for. That specific thing will not be done in that cases. So that specific instruction to the MRI technician, I think it's very important. Federico, you have anything on the imaging part? Anything to add?
No, I totally agree with what Dr. Sharma said. I mean, patients that have no risk factors, I will 100% image them. And the ones that even have risk factors, honestly, many times you mention it and say, I want to get an MRI for sake of safety. So they go for it anyway. But
Dr. Federico, many a times we have our general ophthalmology colleagues mention that this squint is just intermittent, and why do you even want to meddle with it or operate it? So what is your take, and what is your line that you draw? When do you operate on patients with intermittent exotropia? This is for a general ophthalmologist. What to decide, when to decide about operating on intermittent exotropia?
You're asking me?
Yes, Dr. Federico.
Oh, okay. Well, I use two criteria to make the decision if I'm going to operate or not. One is what the parents see, and the other one is what I do see. I try to select two factors, and the number one for me is diplopia. If there's diplopia, I treat the kid. If there's no diplopia because the kid is too young, I try to follow the patient by measuring near and distance stereopsies. And that is an objective measurement that I try to get to determine when the kid is decompensated. The other one is the kid that is squinting. The parents are concerned because it's drifting so often. The control is really worse than 30–40% of the time the patient is awake. Then I would do surgery for that patient.
Dr. Kavita, any additional points you would like to add?
I agree with Dr. Federico that I tell the parents about like he said, what the parents observe. Like if there is a progressive deterioration, increase in frequency, and if others other than parents, like teachers and new people start seeing, then I tell them that is a time when probably it is beyond intermittency is becoming a little more frequent. And second thing is, like sir said, we do a serial stereopsis measurement for distance and near whenever possible, and then when we see a progressive deterioration, then we offer surgery and tell them the benefits of surgery versus not doing surgery when binocular vision is an issue. So that is how we try to convince.
Yeah, I think intermittent exotropia we see a lot here in India. There are two groups of parents I would see. Some parents think that whatever strabismus, it has to be corrected as early as possible in the life. They have that perception from Google or whatever. They'll say, is it too late? And there are second group of parents, even if there is a 40 prisms of exotropia with poor control, near distance disparity in the stereopsis, still they will say, no, I'll see only sometime. So the decision here, I think it's totally with the discussion with the parents, and as well as what exactly Federico sees, this is what is the consideration. And one more factor I see, whoever has insurance, they will push you for surgery. This is one more thing we have seen. Intermittent exotropia is a very difficult kind of surgery for all of us in terms of long-term success. I think this needs to be taken care.
I think the carry-home message that Dr. Kavita gave is very important, that stereo acuity has to be tested. And Dr. Federico, of course, added near as well as distant stereo acuity. So general ophthalmologists can start doing that, and that can be a pivoting point for the management. Dr. Divya, there are a lot of small kids that general ophthalmologists see, which has they refer to you for esotropia, and it ends up as pseudo-esotropia. Can you give carry-home message as to how to differentiate between a pseudo and a true esotropia for an ophthalmologist?
Yeah, sure. Actually, basic inspection, as I said, will help in most cases. Look for the epicanthal folds that may be present, or the mongoloid, anti-mongoloid slant of the lid fissures. So these will help. A broad nasal bridge sometimes may give the impression of an esotropia, but actually it's a pseudoesotropia. One easy way is to eliminate the epicanthal folds by pressing on the folds like this. So that way, we are now seeing the complete lid fissure, and then we don't see any esotropia. Another way is, of course, doing a cover test, and then there won't be any deviation. So these are simple tests. And one factor that we have to keep in mind is sometimes a pseudoesotropia may develop into an esotropia. So close observation is important.
Yeah,
Dr. Sharma, sir, please.
Yeah, Dr. Sharma, any tips on that?
I think Dr. Divya has rightly said. One more thing that sometimes, many times, even we may have a little difficulty in seeing a child whether he's really having a true esotropia or a pseudo esotropia. What I do, if a child is little older, we can do a Lang's 2 pencil test, a simple test. The stereopsis presence excludes a true esotropia. If there is a pseudoesotropia, he would be able to do the stereopsis testing. So simple Lang's 2 pencil test, which is like a bedside, I have found it very useful in children who can just be made to play, and even small children like 2 or 3 years old, I have been able to do this small game and it helps.
Yeah, one more thing, I think parents has to be assured, because even if you say pseudo esotropia, they will wait for and they will look at your face. Is it really? I'm seeing all the time. So this is the expression you will see in their face. So you need to really. And the second question they will ask, will the child be ever normal? I would never say at this point of time, child does not have it. I cannot guarantee what happens in the next, because all children have a chance of developing esotropia in their childhood, but these people have more chance. Having said that, my experience has been in pseudo esotropia. Intermittent exotropia is the most common strabismus what we see in India. In the literature, it's the 25% chance that they will develop esotropia, but here what we see is that. So that's another thing.
One more thing, Ramesh, I think just to add, always ask a refraction to be done. Because sometimes when the parents are saying an esotropia and you find it's a pseudo-esotropia, it may be that intermittently there is an ESO coming because of an accommodative effort. So if a mother says that I have seen an esotropia and you still see a pseudo-ESO, get a refraction done to rule out a variable esotropia.
Agree. I think I wanted to summarize all the talks. We have less than 1 minute. I will go with all the 5 speakers, one sentence as a summary for everyone, please. We'll start with Dr. Koval.
Beware of anisometropia, anisoconia, metamorphopsia as cofactors for strabismus in the elderly.
Federico, thank you.
Great. Look beyond the eyes. There's more beyond the eyes.
Thank you. Dr. Sharma?
I think you already said that you have to be squintellectual. You have to be looking for that. Don't get foxed by a complex procedure. Many a times, if you think, it may be a very simple solution for that too. So you have to be, I would agree with Federico.
Kavita, last word.
Yeah, never ever overlook a presence of a refractive error in the presence of a strabismus, because numbers can do wonders.
Divya?
Yeah, just proper history, proper motor examination, sensory examination. That covers everything.
Okay, thank you so much. Thank you for all the speakers. I think it's just 1 hour over now. It was really nice. At least we could discuss 10 issues in strabismus. I'm really thankful to all the speakers from all over the world, East Coast and West Coast. It's really nice. Not West Coast.
Thank you, Dr. Ramesh.
Thank you so much. And I would hand over the section to the neuro-ophthalmology now. Thank you so much. Have a good day.
Thank you for having us here.
Thank you.
Thank you.
Thank you very much for having me. Have
you.
a great day.
Thank you.
Okay.
Dr. Banju ma'am, you can start the session.
Hello, everyone, and welcome to the neuro-ophthalmology session, which is going to be the next session for the afternoon. And I welcome everyone to attend it. My co-moderator, Dr. Rashmin Gandhi, is with me here. And we have a keynote address by our guest speaker and panelists and speakers from over the country today. I welcome you all, and I'm just gonna start sharing my screen. So give me a minute.
Now you can share.
Yeah. Okay, can you see my screen?
Yes, we can.
Yes. With this, I'm just going to introduce our keynote speaker for today. He's not a small Simba, but he's a big lion in neuro-ophthalmology who's ventured into the shadowy areas and discovered a lot, which is really essential. And he's going to go through some of the essential neuro-ophthalmology tips with us today. And this is no other than Dr. Andrew Lee. Dr. Andrew Lee is the chair of the Blanton Eye Institute and the Department of Ophthalmology at Houston Methodist Hospital, Houston, Texas. He's the adjunct professor of ophthalmology at the Baylor School of Medicine, the Texas A&M College of Medicine, and he's also affiliated with the University of Iowa and the University of Buffalo. Dr. Lee has a lot of national and international he's on the editorial board of 20 journals. He has about 400 peer-reviewed articles, 40 book chapters, 8 textbooks, and over 300 national international meetings and a lot of named lectures. So with all this accomplishment, he looks fairly young, and we look forward to hearing you. Thank you. So I'm going to get the organizers to share screen now, because they will be displaying the next recording, which we have for Dr. Lee.
So I'd like to talk to you about acute headache, nausea, vomiting, and diplopia emergencies for an ophthalmologist. And you need to know a little bit about how acute headache, a fever of unknown origin, and associated nausea and vomiting can show up in the neuro-ophthalmic clinic or in the emergency room. And basically, if you hear that constellation of findings, acute headache, fever, nausea, and vomiting, and you add either afferent or efferent problem, diplopia or vision loss, it could be a potentially life-threatening neuro-ophthalmic disease. And the three I'm going to cover today are aneurysm, apoplexy, and neuromyelitis optica, but there are many others, but because we have limited time today, I'm only going to cover those three. We're going to talk a little bit about the rule of the pupil, and I'm going to show you how nausea, vomiting, fever, and headache can occur with an aneurysm. The rule of the pupil, a pupil-involved third nerve palsy is an aneurysm of the posterior communicating artery until proven otherwise, and that fever can be a part of a constellation of findings from any disruption in the hypothalamic pituitary axis, because the hypothalamus is in charge of some of your autonomic functions, including your temperature regulation. And that means it could be a central fever, not an infectious process. And the chiasm is very close to the hypothalamus. You need to ask every patient with vision loss in neuro-ophthalmology about some super weird things. That's nausea and vomiting, symptomatic narcolepsy, and hiccups. And the nausea and vomiting is coming from the area postrema, which is the vomit center in your brain. This is my dad's rule of ducks. If it quacks like a duck and looks like a duck and flies like a duck, well, it's probably a duck. And the most common cause of headache and nausea and vomiting in a young person is actually migraine. But once you add the double vision, or you add in bitemporal hemianopsia or loss of vision, you really shouldn't be thinking about this duck migraine. You should be imaging this. So here's a 24-year-old white female who has acute severe headache, nausea, and vomiting. She's working out with her personal trainer. She develops the acute severe headache. She was in the plank position at the gym when she felt an elastic band squeezing her brain. She wrote, "I reached to the toilet, sank to my knees, and proceeded to be violently and voluminously ill. A woman who was in the locker room saw what was happening. The patient was weak and in and out of consciousness at that point, and she was taken to the emergency room." This patient posted pictures on her blog of her in the ICU, in the neuro ICU, with all her lines and everything. And she doesn't actually look like that in TV or the movies, but she suffered a subarachnoid hemorrhage from underlying intracranial aneurysms. But her presentation is very consistent. Nausea, vomiting, acute headache, and if you add any neuro-ophthalmic problem here, you really should be thinking about aneurysm. And so our first imaging study for this scenario is non-contrast CT. What we're looking for is the subarachnoid hemorrhage inside this star-shaped cisterns here. And then we're going to follow that with a contrast CTA. And you can see the aneurysm here of the posterior communicating artery aneurysm. This is another case, and you can see the patient has ptosis. The eye is down and out. This is a third nerve palsy. They did the CT, which shows the non-contrast CT shows a subarachnoid hemorrhage, but the contrast CTA shows there's an aneurysm. We can see the aneurysm here, and they coil it, and it's a cure on the catheter angiogram, complete obliteration. And that is the rule of the pupil. A pupil-involved third nerve palsy is an aneurysm of the posterior communicating artery until proven otherwise. It can present with headache, nausea, and vomiting because of meningeal irritation. And the MRI scan of the head might be normal. That's why you need a CT, non-contrast, to look for subarachnoid hemorrhage, and that has to be followed with some type of angiogram. CTA, MRA, DSA. You need an A, an angiogram, to find this A, aneurysm. There is no A in MRI. And if you look at aneurysms, 1 in 50 people in the United States have an aneurysm. And because we see about 14 first-year residents every single year from my 3 ophthalmology programs, I know that after a 3-year residency, one of those residents is actually harboring, statistically, an aneurysm. 3-to-2 ratio for women, and if it ruptures, half the people die at the scene. Of the people that survive, 4 out of 7, even though they recover, have some form of permanent neurologic deficit. If, however, this aneurysm, this jalapeno pepper here, is identified and coiled or clipped, go home hospital day 3, have a nice life. So my choice of imaging study here is going to be CT non-contrast followed by CTA to look for the subarachnoid hemorrhage and then the aneurysm. We still need to do an MRI, MRA in third nerve palsy to look for non-aneurysmal causes of third nerve palsy. And so we have to do an MRI even if the CTA is negative, and catheter angiography if the MRI, MRA, or the CTA are not of good enough quality to determine whether there's an aneurysm. This is a 66-year-old white male who presented with acute headache, fever, nausea and vomiting, loss of vision, and double vision. They're seen in the ER and they are discharged. The ophthalmology examination on the outside, because the patient was complaining of diplopia, shows right 6 nerve palsy and a RAPD on the right. The remainder of the exam was normal. The outside ophthalmologist said, refer to neurop. They called our neurop fellow and the fellow said, come now. The other fellow overhears the first fellow talking to the patient say this, yes, you need to come back to the ER, but this time Methodist Maine. So any combination of bitemporal hemianopsia, optic neuropathy, and ophthalmoplegia should prompt consideration for chiasmal lesion, including pituitary apoplexy. It's often the 6th nerve that's involved because the 6th is in the substance of the cavernous sinus. And pituitary apoplexy should not go to the shopping mall emergency care center, the one that has the Krav Maga on the 2nd floor. That is not going to be able to take care of pituitary apoplexy. That's for colds and sniffles and antibiotics. That is not for aneurysm. So here's the anatomy of the sella, just to show you how this presents to us. So we've got a chiasmal syndrome because we have a pituitary apoplexy. It can go straight upstairs and cause bitemporal hemianopsia, but if it goes laterally into the cavernous sinus, it'll hit the 6th nerve first. The 3rd, the 4th, and the 5th are relatively protected in the lateral wall. And if you look at the clinical features of pituitary apoplexy, headache is the predominant complaint, but look what number 2 is, nausea and vomiting. And look down here, pyrexia, that's fever. 10 to 25% of the patients who have apoplexy have fever in addition to their headache, nausea, and vomiting. And that means you're going to get on the wrong track because you're going to think it's infectious meningitis. Anything can bring it on. Hypertension, surgery of any kind, medications, trauma, all sorts of different triggers. And the thing I want to point your attention to is the symptoms of compression that you are probably unfamiliar with is this autonomic dysfunction. If you have hypothalamic involvement, you'll have temperature dysregulation, and that means they can present with fever. And the nausea and vomiting often results from adrenal insufficiency. So the concomitant endocrinopathy in pituitary apoplexy is what produces the adrenal insufficiency, and that's the thing that kills people with apoplexy. So we really need to check their cortisol and start them on steroids right away. And that's what's causing the nausea and vomiting. So it's kind of an emergency. You can see here on this sagittal, there's a fluid level where the blood and the hemorrhage inside the necrotic tumor have separated, and because they're lying flat, it makes this fluid level, and you pretty much should admit this patient to the hospital. If they have deteriorating level of consciousness or decreased acuity, you probably should do surgery. This is my dad's rule of ducks again. This is the typical duck optic neuritis in the USA, a 20-year-old white woman who has acute unilateral loss of vision and RAPD, pain with eye movement, and a normal fundus that can recover with or without IV steroids. And of course, the MRI scan is going to show the typical periventricular ovoid white matter lesions. And if you look at the range of MS, it's geographically distributed in the same latitude in the north as in the south, and that means the United States, Canada, most of Europe, and in the southern hemisphere, a little bit of Africa, South Africa, and across the ocean to Australia and New Zealand. But in India and China and all these equatorial countries, the chance of it being MS is low. And so that's going to be not a duck. And you need to know about NMO. NMO is neuromyelitis optica. It affects women, predominantly affects and disproportionately affects people of color as opposed to MS. That's African Americans, Afro-Caribbeans, and Asians. And the Asian form of MS is more likely to be NMO. NMO can occur in Caucasian people, but you really should be worried when you see an African American or an Afro-Caribbean patient or an Asian patient with optic neuritis. And most NMO patients are actually misdiagnosed as MS initially. If you look at the prevalence of MS, it's 100 per 100,000 in that northern latitude and that southern latitude. But look at NMO's distribution worldwide. And the thing I want to call your attention to for this audience is in the Indian subcontinent and Asia, it's kind of got an in-between 2.6 to 2.0 per 100,000. And that means you should be thinking about NMO in every optic neuritis patient if they're from that middle zone where MS is less common. And neuromyelitis optica is the combination of optic neuritis, transverse myelitis with longitudinally extensive 3 segments, and NMO. The optic neuritis tends not to recover and is bilateral. The MRI scan might be normal or show lesions that are not typical for MS, and the lumbar puncture might show CSF pleocytosis greater than 50 white cells. We're going to be looking for bilateral involvement or longitudinally extensive involvement as opposed to the small segment in the orbit of typical optic neuritis. And once we see longitudinally extensive enhancement, that's defined as greater than a half of the optic nerve or 3 longitudinal vertebral segments for the myelitis, you really should be thinking about NMO. And in this paper, you can see that involvement of the chiasm or the tract or bilateral optic nerve is the typical pattern that we're looking for radiographically for NMO. And the reason you need to know about it in the talk about headache, nausea, and vomiting is this green line represents the aquaporin-4 rich areas. And one of those aquaporin-4 rich areas is right here at the base of the 4th ventricle, which is the area postrema, and down here in the medulla, that produces 2 weird symptoms, nausea and vomiting and intractable hiccups. And the chiasmal involvement is way anteriorly here, but right upstairs is the hypothalamus, and that means you might get somnolence, hypothalamic signs and symptoms, autonomic dysfunction, and fever. And we need to know if it's NMO. Here's this red line of NMO positive. Most of these patients are going to have a transverse myelitis or a recurrent optic neuritis event if we don't diagnose and treat them with immunosuppression. The cumulative survival on this Kaplan-Meier shows that. And if you're NMO seropositive, you're going to get transverse myelitis. And if you follow the cohort long enough, the majority of patients are going to get transverse myelitis. So I order the NMO IgG aquaporin-4 antibody for non-recovering, bilateral, or recurrent optic neuritis if the brain MRI is normal or not typical for MS, if they have CSF pleocytosis greater than 50, or if they have transverse myelitis. And the thing about this talk is nausea and vomiting or intractable hiccups in a patient with optic neuritis is an NMO symptom. So in summary, you should know a little bit about the emergencies that present with acute headache, fever, nausea, vomiting, and neurop, either with loss of vision or double vision. Those could be life-threatening diseases, and the 3 I covered for you today, aneurysm, apoplexy, and NMO. The rule of the pupil, if it's a pupil-involved third, it's an aneurysm until proven otherwise. You need an A to find that A. Fever can be central from the hypothalamic involvement, and the chiasm is close to the hypothalamus, which is also an aquaporin 4 rich area. And therefore, nausea and vomiting with or without fever and vision loss, you should be thinking about NMO as well as the other things on the list. And I thank you for your time and attention.
Thank you so much, Andy. Thank you, first of all, for joining us so early in the morning and for a wonderful talk. I think a couple of points which he really brought about and which we should remember is that in ONTD days, we were told that if you suspect patient having optic neuritis, you probably have some time in hand. But in India, as Andy mentioned, we do see a lot of patients with NMO. And if it doesn't smell like typical optic neuritis, then we really don't have time. We should act fast. And that's the reason why I think he included NMO as one of the important topics for his discussion. Andy, over to you. Any further comments?
Yeah, I would agree. I mean, a lot of us went into ophthalmology to avoid nausea and vomiting, but sometimes you need to know a little bit about nausea and vomiting in neurop.
Any further comments from Jyoti, Rohit?
Just to add that, yes, as you pointed out, sometime back, optic neuritis was not such a big thing, and we were getting them investigated before we started steroids. But now the fear of the fact that they could be NMO, especially in India, is really spurring us to give IV methylprednisolone at the very onset and the moment they come. So this is a very major change, which I think all of us must recognize and realize that besides, of course, ruling out infections, which can increase, or electrolyte imbalances pre-existing, which can exacerbate, and tuberculosis, of course, in India, we must aggressively intervene in these patients, extensively, investigate the MRI brain and orbits with contrast, flare, fat suppression for orbits. It's a must. It's no more, as a choice that in India we used to feel some time back that, if we don't or if we want over time, we'll get it done. But now, as Andy has said, it's a key investigation to do at the very beginning if you think it's optic neuritis.
Right. And I don't know if, but it's like how you'd see in the West, it's really a typical optic neuritis where the vision loss may not be as profound as you would expect in atypical, or they would start recovering by themselves in a couple of weeks. We do see a lot with much more profound vision loss out here in India. And even if we do investigate for NMO, they do sometimes turn out to be NMO negative or even MOG negative. In that case, sometimes there is a bit of a dilemma, how long to give the IV steroids, how slowly to taper, or do you follow the ONTT regime? Is there something you would like to sort of give us some tips on?
Yeah, so before we had the antibody for aquaporin 4, we had to make the diagnosis of DIVX clinically. So just because we have the antibody now doesn't mean you don't have to be a doctor. So you have to pretend like we don't have it. And so seronegative MOG and seronegative NMO, that's a real thing. The most common circumstance I see that in is after they've been treated with steroids, it can artifactually make the test go negative. And so if you think it's NMO or MOG, you're the doctor. Doctors make diagnoses, not those tests.
Yeah. Jyoti, do you want to add anything?
No, I think most is discussed. Once, as you typically said, in India, we can have patients coming with profound loss. So once we've ruled out any infectious cause, we should think in terms of NMO and start the treatment sooner, as what Rohit did mention.
Andy, how frequently would you want to repeat a negative NMO or MOG test? Suppose the patient does not improve. I mean, you've given steroids, the patient does not improve. He's at the presentation NMO MOG negative. So after how long would you think you should repeat a test? And the baseline is a cell-based assay, so you are feeling that it's fairly reliable.
Yeah, so the tests, both the MOG and the NMO are very good in terms of their specificity and sensitivity in the right clinical circumstance. The MOG is not as good, so I would definitely Repeat that one if you have high clinical suspicion. The NMO is pretty good, but if you think it's a duck, you should test them again. So my rule of thumb is before I call someone seronegative MOG or NMO, I'm going to test them twice. So 2 times, 3 is probably going to be diminishing yield at that point if you're using the correct cell-based assay and you're going to Mayo Clinic, et cetera. I think that if they're following the standardized protocols for the testing, 2 is enough.
Thank you so much, Andy. So if there are no further comments, then let's move on. Let's have cases discussed now, and then we'll come back and discuss these points if you have time. So now it's my pleasure to invite Dr. Manjushri Bhate, who is joining us from LV Prasad Eye Institute. And Manju, all yours.
Thank you. So I'll just get the share screen. Okay, do you see my screen now?
Yep.
Yeah, can you hear me?
Yes, we can.
Okay, so I'm going to talk about some mysteries in neuro-ophthalmology. Mysteries as in, not mystery, but some sort of puzzling cases, so to say. This one I've covered. So the first one is a young software engineer. She's an excellent historian, and she came to the clinic about 2 months ago. So what she said was she complained of episodes of double vision. She noted that the double vision, these episodes sort of started in the past 10 months. The episode lasted for about 10 minutes, and she had about 10 such episodes. She couldn't sort of give a cyclical pattern, but she said maybe 1 a month or something. And after 10 minutes, it resolved completely on its own. So just in what would you ask? I asked her if she had, what time of the day it happened, whether it was more associated with fatigue, as in more in the evening or more when she was tired. And also, she had no associated headaches, no recent infections. She was COVID negative. And this is a video of her at the time of the episode, which she's presented. So let's have a look.
और ये left रात मूव नहीं हो रही क्या देखो.
So here we can see she's got limitation of a deduction of the right eye.
So double दिख रहा है. Okay. कितना टाइम हो रहा है?
And she seems to have a bit of dizziness at that time as well. And she did complain of that later.
12:44. Okay. डबल दिख रहा है. कुछ डिफरेंस है क्या?
So there again, she's got the limitation of a deduction.
क्या डिफरेंस है? पता नहीं. ऊपर इस तरफ मैं इस तरफ देख रही हूँ. हाँ. ये है और अब मैं सामने देख रही हूँ. अब मैं इस तरफ देख रही हूँ, मुझे सही दिख रहा है. हाँ, बिल्कुल परफेक्ट दिख रहा है. और मैं इस तरफ डबल दिख रहा है. नीचे ये लेफ्ट है.
So essentially, what she's trying to say is that she gets a double vision when she looks left. And this is just a still of her eye position when she's looking to the right and she's looking to the left. She has a little, I thought she had a bit of lid retraction as well. So any guesses? What do you think is going on and what should be done next? Andy, do you want to go here?
So I would say there are several tip-offs on a case like this. So when we have an adduction deficit, that's like the medial rectus muscle, something wrong with that, or it could be INO versus pseudo-INO, but there are things that can mimic INO. So we always have these like INO-looking things, but aren't INOs. So we'd like to know if there's abducting nystagmus. One of the things that's interesting is when the patient is straight in primary. So normally when you have third nerve palsy, the eye is down and out. And so if the medial rectus is really weak, the lateral rectus will overact and it'll cause this huge exotropia in primary position. And in the literature, those are Webinos and Weminos because they're wall-eyed, but I prefer the term exotropic to get rid of the pejorative wall-eye thing. However, when your eye is straight in primary, it makes you wonder that it's restrictive or that it's a synkinetic movement and not really a paretic movement. So that's kind of what I'd be thinking about given the patient's complaint. And the last thing I will say is sometimes patients say their double is transient when they really mean it's gaze evoked. It's only present when I look certain ways, not that it actually comes and goes. And so that's a difference between myasthenia pseudo-INO and the restrictive or synkinetic pseudo-INOs.
Right. Thanks. Yeah, Rohit, Rashmin or Jyoti, Rachna.
So I would, of course, want to follow up with a convergence test to see how the eye moves in inwards when we attempt to converge. So that would help us to pick up an INO. And of course, as Andy said, that an abduction nystagmus is something that we are very concerned with. And of course, because of the retraction also to an extent, restrictive is something that I should, look for. But of course, after examine the eye also, sometimes we do fairly frequently come across cysticercosis in the orbital muscles. So there is usually that little bit of inflammation anteriorly to the muscle. So these are the things that I would probably keep in mind.
Okay. Well, this
I would just add also that sometimes these Dwayne people show up in our clinic, and you got to worry about those sometimes.
Yeah, well, all this is just transient in the sense it lasts only those 10 minutes. After the 10 minutes, like I've got a video where when she came to the clinic or when I saw her, it wasn't those 10 minutes. So her eye movements were completely normal. Her convergence was normal. There was no nystagmus of any kind. There was no strabismus of any kind. Her vision was fine, So this is just that 10-minute thing, which I've shown you just now. Anyway, so I'll just maybe in the interest of time. So as I said, post-episode, she was just absolutely fine, full range of movements, no double vision whatsoever. She was elsewhere tested for myasthenia, for thyroid, which was all negative. So I did a MRI and MRA, and that was normal. So anyone else wants to add anything or do any other, or think along any other lines?
So it was just that it was transient. It was not the variable that you were expecting in myasthenia. It's not that, and the ptosis also was not there at any time.
It was
and this is the exact picture she repeatedly has.
Yes, she takes photos, videos, in the sense she's just seen me recently, but she's very sensible, very sensible person. So I don't think she's just making it up, or she's very clear about what happened. So when I just dug deeper into the history, there was no headache, but she said, I kind of felt that this is going to happen, and then it happened. And she couldn't describe what feeling it was.
So some patients have like a periodicity to their episodes, and there's like these cyclic oculomotor spasm people and ocular neuromyotonia. Normally those people get like this slow movement of their eye outward like this. But if we would ask about periodicity and things, and those are like the cyclic oculomotor paresis syndromes, COPS, and ocular neuromyotonia.
Right, yeah. So at this point, I've kind of asked her to seek an opinion with a neurologist. I was thinking along the lines of a oculomotor migraine as well.
Right.
And
maybe that's...
yeah, so I don't know if migraine medications would help, but I'll see next week after she meets the neurologist. So that was a bit of a mystery, so to say. And I'll just quickly go on to the next one. This was a young patient who came following a history of dengue fever. So he was diagnosed, he had the dengue, he had low platelets, he received platelet transfusion, went home, and then in about 7 to 10 days, I think about 2 weeks, he presented to the neuro-ophthalmology clinic, and this is how he looked. So he had a partial ptosis. He had his eye was like kind of out, not so much down, a bit of anisocoria as well. He had -4 adduction and limitation of elevation and depression. And then again, so suspecting, as Andrew said before, straight away think incomplete third nerve, think of aneurysm unless proven otherwise. We went for an MRA and MRI. And interestingly, the MRI showed this, the whole course of the third nerve was lit up like some Christmas decoration out here, all the way, even here in this, it's stuck. So this kind of looked a little bit like an oculomotor neuritis. So again, in this sort of scenario, what would you do? How would you go about managing? And is it immune mediated is what I wanted to sort of ask the panel. Who wants to go first? Andrew?
Yeah, so we see ocular motor nerve enhancement in a lot of different infiltrative and infectious and post-infectious etiologies. It just means white cells are in there. I think that you have lumbar puncture and normal things.
Yeah, all normal, yeah. Sorry, my time's up. So, so yeah, these were just the questions for the panel, but these were the two interesting cases. And after 8 weeks, he sort of resolved. We did give a trial of steroids after ruling out infectious causes. I don't know if how much of a role they would have actually played. And that's it. And I just want to end by inviting you for our next weekend meeting at LB Prasad on iGenetics. Thank you.
Thank you so much, Dr. Manju. Let's move on to our next speaker, Dr. Rohit Saxena, and he's going to talk about disc edema. What next? Rohit? Rohit is a professor at RP Center at All India Institute of Medical Sciences, Delhi.
So thank you, Rashman, and thank you for the invitation. I'll just talk to you brief about swollen nerves, and of course we can keep discussing onwards for there, because this is one of the most common, presentations in neuro-ophthalmology. So I'll start with this first case. This case, she's a 26-year-old female. He came to me with diplopia of 2 days. Vision was normal, both eyes. She gave a history of intermittent headaches for the past 4 months. And she had actually, as is the Times, taken an online consult who advised her that probably it's related to increased screen time. And she was refracted at a local optometrist and very minimal change in glasses. And this happened 2 or 3 times, but nothing else. And she kept on managing her headache by analgesics and changing glasses, but nothing else. And 2 days ago, she developed acute diplopia and she landed up with us. And this were her fundus appearance. And you can see that there is disc edema that is there. It's not so gross, but yeah, it is definitely there. And an OCT, when in doubt, an OCT or a fluorescein angiography can help you in early papillodemas. You can see that the RNFL thickness is way off the charts. And this was quite clearly, when in doubt, of course, a fluorescein angiography can be done. You should see every patient whom you suspect having disc edema on a stereoscopic examination. So do a 90D on a slit lamp. That will tell you very nicely if there is any disc edema in these patients or not, and particularly early ones. So how do you approach this? You are first looking whether it's bilateral or unilateral. And bilateral, you will have a lot of things in your mind. You could have pseudopapilledema, you could have papilledema, hypertensive retinopathy, occasionally bilateral papillitis, and of course others like compressives and uveitis, inflammatory. All this would require you to think of a systemic problem, a systemic oblique neurological problem. On the other hand, if it presents unilateral disc edema, you're a bit worried whether it's hyperemic or pale. And that's one thing, although it may not be so easy to discern in the beginning. You are concerned with papillitis, ischemic optic neuropathies, again, pseudo disc edema, if it's a unilateral, say a drusen, CRVOs, and asymmetric papilledema, where the edema would kind of come over time in the other eye. And sometimes the other eye is atrophic, and that may help you to understand what probably is happening in this eye, which had preceded in the other eye. So this is how you're going to look at any patient with disc edema. You see always the other eye, what's happening to the other eye, if it's bilateral, if it's unilateral, or if the other eye is an atrophic eye. So these are among the kind of presentations of all these differentials of bilateral disc edema you're going to see. So this is what we often get confused with papilledema, and a lot of referrals and a lot of imaging happens in these children. And this is a pseudo papilledema. We'll just come to its differences. This is a true papilledema. What you can see a very angry looking disc. The edema is reached right up to the macula, but the exudates are towards the disc only. The rest of on the other side, the macula is normal. And this is another patient who you can see that there is very minimal or any disc edema at all, but you can see the exudates, hemorrhages. This is a grade 4 hypertensive retinopathy. So the key thing is to differentiate the various kinds of discs that present to you. And pseudo papilledema, the vision will be normal, although that would be true in early papilledema also. Like in our case, it was, the pupils are normal. They can only get affected in atrophic stages in papilledema. And otherwise, it's a small cupless disc. The vessels are normal. They can be seen very clearly. There is abnormal branching. Sometimes you can pick up drusen's. And of course, just in case you want to do an OCT or an FA, you're not going to find the pathological changes that you see. Another set of discs that you see, so the ones on the top is myelinated nerve fiber. Again, you need to see on a 90D to make sure that there is no edema. This is a myelinated nerve fiber obscuring all the vessels. This is an optic nerve hypoplasia. Again, sometimes mistaken for edema, where these lines are taken as fluid lines. And this is an optic nerve drusen. See the lumpy, bumpy appearance, but the vessels are pretty clearly seen. But the disc appears as if it is edematous. And this is a patient of acute optic neuritis. The edema is there. If you see carefully, you will see all the fluid that is here, but this is a very gentle fluid as compared to a papilledema that you're going to see, except of course in early papilledema, but even there, you're just going to see some elevation here. You can see some hemorrhages if you go very close, and that's how you need to clinically differentiate on the possible causes. You of course are going to have associated nausea, vomiting, headaches, 6 nerve palsy like in our case, usually bilateral presentations. Transient obscurations of vision is common. You'll have enlarged blind spot and a little constriction of peripheral field if you do the full field. Unfortunately, we do the 30-2, so we tend to miss the peripheral constriction, but enlarged blind spot is something which can be easily picked up. You need to, again, if it's disc edema, it's bilateral disc edema, you think raised intracranial pressure is the cause. You need to rule out the causes, which could be a space-occupying lesion, infections, inflammations, and of course a bleed. And most importantly, to do an MRI, which is very, very important and is an urgent investigation to do. And in indicated cases, you may require a lumbar puncture for infections or IIH. Our case standard landed up being an IIH. Her MRI was normal. Her field just showed enlarged blind spots. So the aim was to always do an MRI, rule out a space occupying lesion. It's a very key investigation. They may present with empty sella, but it's not diagnostic. And MRI with MRV is important to rule out venous sinus thrombosis. Our patient did not have any venous sinus thrombosis. The elevated CSF pressure on a lumbar puncture, and of course the composition should be normal. These are the ways in which you will diagnose an IIH. You manage by removing the cause. Weight loss is extremely stressed. It's a very important way of managing, especially patients present with recent onset weight gain. So it's very important to rule out or to remove this etiology. Blood pressure check, anemia, obstructive sleep apnea. These are key things that need to be managed. Diuretics, and of course the sheet anchor is the acetazolamide, which we tend to give up to 2 grams or sometimes even more as an initial intervention. And if the patient is progressively losing vision, you think in terms of an optic nerve sheath fenestration. If headaches and systemic problems are more, tinnitus, headaches, you may think and the CSF pressure is very high. It's an acute presentation with very high pressures. You think in terms of a shunt procedure, because the ONSF may not bring down the fluid to adequate extent. So it's important for us to investigate appropriately. First, of course, come to a diagnosis as to what is the cause, investigate, and then manage aggressively. Thank you.
Thank you, Dr. Rohit. That was great. In the interest of time, I'm just going to ask Jyoti to go straight to her case next. Thank you.
Yeah, I'll just be sharing. Just a minute. Yeah, so I just wanted to add to what Rohit said before I actually, just a minute. Before I just go on, you all can hear me and see my slides?
Yes.
Yeah, so a small test, this is for the general ophthalmologist, which I published in the American Journal of the American Journal of Emergency Medicine as an alternative method to look at the optic nerves in papilledema using the B scan. And what we actually do is just the B scan using the vertical transfer scan. You can get the same effect behind. As you can see here, the presence of subarachnoid fluid, which post-treatment tends to disappear. So sometimes in early cases, and also a very good tool to differentiate between optic neuritis because you don't find the same fluid. So this can not only help you confirm a papilledema or a disc edema secondary to raised ICP, but you can also monitor it over time because we cannot do repeated MRI scans. So thanks for that. And coming to my case, I'm going to be talking on myasthenia gravis, short case and a little bit about what to do and how to manage. A 4-year-old child, healthy child, was referred to me with query cavernous sinus lesion, which is seen on the MRI. This child had a drooping of the upper lid of the right eye, followed by the left eye within a span of just 4 days, along with an inability to move the eyes. Infectious, inflammatory, and hematological workup was already done and was normal. He was on treatment elsewhere on IV antibiotics, IV methylprednisolone, anticoagulants. Investigations, however, done, one had the MRI, but when we got it reported, it looked normal to us. So the MRI and MRV was done, which is normal. Now, this was the examination, bilateral ptosis, left eye more than right eye, but ocular motility, unfortunately, the first visit, I don't have the photographs. The elevation and the adduction was -4, depression was -3 in the right eye, and abduction was full. But left eye had absolutely total ophthalmoplegia. But interestingly, the pupils were very normal. And that's what we have to look at when we are suspecting to differentiate between a third nerve and myasthenia. Rest of the examination, the vision and the anterior and posterior segment was normal. So he diagnosed as a partial third nerve palsy and left eye total external ophthalmoplegia. Then we did the fatigue test, the Cogan's lid twitch test, and eyes test were negative, but we still had a suspicion of ocular myasthenia. So we got a second opinion from a pediatric neurologist to confirm the same. When did the single fiber EMG, it showed jitter, and they confirmed it, or they suggested it to be probably an NMDA disorder. The acetylcholine receptor antibody testing was positive, and the patient was then started on mestinon along with steroids and also azoran. In the meantime, for the eye problem, we had started occlusion therapy to avoid diplopia and a part of amblyopia therapy because the child was exotropic. And this was when the patient came back and was fine. So what interestingly found out, we asked the father very specifically, is there any variability in the day? And he was like, sure, that no, there is no. But we asked him to send the photograph of his child when he gets up, when the child gets up in the morning. And this was the image, first time when the child got up. So this was actually a thing which showed that even if you are not able to pick up the variability in the day, the first time when the child gets up, you're getting something where it was almost resolved, can give us a suspicion of myasthenia. After a week of treatment, you can see that the right eye was completely resolved. The left eye had an AD reduction of -3, elevation -2. Ptosis was still there, but there was a response which was seen. And this was after 3 weeks of treatment. Child landed up with a left exotropia, but EOM was completely full. The vision was normal, and the pupils continued to be normal. So I just want to say that OMG is a treatable autoimmune disease affecting the neuromuscular junction. It can affect any age. Clinically isolated to the extraocular muscles, the levator and the orbicularis oculi muscles. It mimics isolated cranial nerve palsies, gaze palsies, INO, blepharospasm, and occurs mostly in Asian children. Variable ptosis, it can happen in one eye, both eyes, diplopia. So when you have a patient who has ptosis and diplopia, suspect myasthenia with normal pupils. There's a lid fatigability. Ptosis increases after prolonged upgaze and Cogan's lid twitch, which I will just be showing you the video. When you make the patient look upwards for long, time, you can see that the ptosis worsens or develops if it's not there otherwise. The Cogan's lid twitch sign, which shows that when you make the patient look from down gaze to up gaze, there's little twitching that tends to happen. That is as seen in this video. The test in the clinics that can be done is a sleep test, which after 30 minutes, you look for a motility, how the ptosis improves, and an eyes test, which is a simple and effective test to confirm, like this done in an adult. And after 2 minutes, you see that it completely resolves. The pharmacological testings include the neostigmine test and the edrophonium tensilon, which is not available, but neostigmine can be even done in children. And after half an hour, you'll see an improvement not only in the ptosis, but also sometimes in the ocular motility, which has a good sensitivity test, and even for ocular myasthenia. Immunological test includes acetylcholine receptor antibodies, which help confirm the diagnosis. But remember, normal titers do not exclude the disease. It's more common for generalized myasthenia gravis. And in absence of these antibodies, you can look for anti-MuSK antibodies. The single fiber EMG is a more sensitive diagnostic test if you've done for the specific muscle that is involved, and then is a repetitive nerve stimulation studies. CT test to be done to rule out thymic hyperplasia or thymoma and an associated autoimmune diseases like thyroid function test. Treatment would be in coordination with the neurologist, pyridoxine, which is a prototype drug, and along with corticosteroids, which do well when it's a purely ocular myasthenia. And then depending on what the neurologist take a call, may need to start on azathioprine, either alone or with steroids. So just to summarize, if you see a clinical examination, because remember it's a clinical disease and you are able to pick up these findings, if they are absent, then you need to get an MRI scan to look for an alternative structural pathology. But all of these show it's clinically suspicious. You can do acetylcholine receptor antibodies. However, they are positive only in 50%. And if negative, any of these antibodies can be done. If that comes out to be seronegative, yes, you can do the single fiber EMG. If his findings consistent, although not specifically for AMG, we'll go into the confirmation of diagnosis for OMG. If the antibody, and then clinically do the chest imaging to evaluate thymoma and thyroid function testing. If there is seropositive, anyway, we know the diagnosis. But if the electrodiagnostic tests are negative, then consider empiric treatment. So you can give a therapeutic trial of pyridoxine and repeating the antibody testing in about 6 to 12 months. So finally, to take home messages, remember myasthenia is a clinical diagnosis. You have to do important tests to pick up in your clinic. It's a great mimicker, so suspect myasthenia if you are looking at any presentation of ptosis or diplopia, especially if it's unusual and with normal pupils. Give importance to the history, so ask for variability and fatigability. Don't get biased by diagnosis done elsewhere, so you need to look at your clinical diagnosis and always coordinate with neurologists for treatment. Thank you.
Thank you, Jyoti. That was yet another wonderful presentation from both our national speakers, Rohit from the north in AIIMS and Jyoti from the south in Bangalore, Narayan Netralaya. I might just ask Rachna to go straight, and then we'll have discussions for all with the time that we have in hand. So Rachna, do you want to start sharing your screen?
Yeah, I'm just doing it. Is my screen visible?
No, ma'am.
No, Rachna.
No, Rachna.
Okay. What about now?
No, not yet.
Open your presentation then.
While
share
Rachna
your
is getting
screen.
ready, can we have Andy to comment on myasthenia and dyschedema?
Sure. So I think that one of the important things of Rohit's case was non-localizing findings. Both papilledema and sixth nerve palsy are non-localizing. They don't actually tell you where the lesion is. So both papilledema and sixth nerve palsy are signs of increased intracranial pressure. It doesn't tell you whether it's the right side, the left side, infratentorial, supratentorial. And in fact, as in Rohit's case, maybe there's no lesion, it's idiopathic. The myasthenia case is fascinating too. I would just emphasize, never trust what the dad says. I only trust what the mom says. Never trust the dad on the kid thing. And selfie, selfie, selfie. Just take pictures. Let them do the ice test on themselves, the rest test and the sleep test on themselves, and take photographs and send it to you.
Thank you, Andy. I think Rachna has got her screen right. So Rachna?
Is it visible, sir, now?
Yeah, it's visible. Just make it a full screen.
Yeah, I'm doing that. Thank you, Dr. Ashmin and Dr. Manju, for giving me this opportunity. I'm just going to be presenting a couple of cases which presented with neuroophthalmic manifestations post-COVID. The first case is a 45-year-old female who came with complaints of binocular vertical diplopia, dizziness, and confusion since 4 days. She was COVID positive, recovered 4 weeks back. And at the time when she was admitted in hospital with COVID, her blood investigations showed elevated C-reactive protein levels, D-dimer, and interleukin-6. She was treated with remdesivir, dexamethasone, zinc, multivitamins, and vitamin C. And her past history was positive for diabetes, which was well controlled since 15 years. On examination, her head posture was normal. Hirschberg showed central corneal reflexes. Her cover test for both distance and near showed a left exotropia going to an alternate exotropia with an R on L in primary gaze and up gaze, which changed to an L on R in down gaze. These are her Prismba cover test measurements for distance and near. And this is her 9-gaze ocular motility pictures. And if you see, in her left eye, she had like a -1 limitation of elevation. And also a similar -1 limitation of depression was also seen in the left eye, but the patient did not have ptosis. The rest of her examination was within normal limits, and a diagnosis of a pupil sparing partial third cranial nerve palsy was made. Given that the patient also had a history of confusion associated with dizziness, we got an MRI of her brain done. And this typically showed an acute infarct, which was involving the left thalamus, which could explain her dizziness and confusion, and also an infarct affecting the left midbrain, which was at the level of the superior colliculus. So in conjunction with a neurologist, she was started on blood thinners, aspirin and clopidogrel 75 milligrams each, and rosuvastatin 20 milligrams. And it was said that she could have probably developed this infarct secondary to a hypercoagulable state, considering she had raised inflammatory markers. The second case is of a 34-year-old female who came with complaints of gradual blurring of vision in her right eye with pain on eye movement since a week. She gave a history of a similar episode in the left eye 3 weeks back, but she said it had improved within 10 days of onset. And her history was only positive, for she said that she had 2 weeks prior to the onset of the episode in the left eye. She had a mild sore throat, but otherwise was asymptomatic. She didn't have any history of weight gain using oral contraceptive pills, sleep apnea. And on examination, her uncorrected visual acuity was 2200 N24 in the right eye, 2025 N6 in the left eye. Her color vision was defective in both eyes. In the right, she could see only the demo plate with Ischiaras, and in the left eye, she could identify 7 of 17. And her pupil in the right eye showed a grade 3 RAPD. When we checked her fundus, this was the image that we had, like she had classical disc edema, which was seen in both eyes. And when we got a visual field done, she couldn't do a good visual field in the right eye. But her left eye, in spite of not having very good reliability indices, it still showed a central scotoma in the right eye. So based on these findings, we thought of a diagnosis of probably it was atypical optic neuritis with a very low probability of could this be IIH, but wouldn't fit in based on the findings that she had. She was advised an MRI brain orbits with contrast and MRV, which came normal. So then we asked her to get further tests for atypical optic neuritis, typically NMO antibodies, MOG antibodies, and a lumbar puncture with CSF analysis, but she was lost to follow up. Now, the reason why I've included this study, though we didn't test for COVID, was because we had seen this patient in July. And then in August, this was an article which was published in the American Academy of Ophthalmology, which said that COVID-19 has been linked to MOG antibody-associated optic neuritis and myelitis. So in retrospect, we thought that probably considering the patient had a history of a sore throat prior to the onset, probably we should have tested her for COVID, because that would explain the atypical optic neuritis that was seen in this patient. Now, just a brief thing about how COVID-19 can cause neurological complications. It could be either because of direct viral invasion of the endothelium with breakdown of the blood-brain barrier. This would happen if it's in the acute stage of the illness. In the little chronic stage, it could be an immunological reaction, or it could be a hypocoagulable state causing hypoxic metabolic changes. Now, there are many studies which also show ophthalmoparesis with cranial nerve palsies from COVID-19. This was a very interesting, this was an interesting article which showed bilateral 6 cranial nerve palsies with a third nerve palsy in a patient with COVID-19 who also had ataxia and areflexia, so was diagnosed to have Miller-Fisher syndrome. And that's found to be a very important association. A lot of patients with Guillain-Barré syndrome, of which Miller-Fisher is considered to be a variant, have been noted in patients with COVID-19. Apart from this, sometimes in patients who've been advised prone position ventilation, there's a risk of developing ischemic optic neuropathy. One of the drugs that has been studied, an interleukin-6 inhibitor, tolicizumab, has been reported to cause papilledema in some patients. There has been one case of AD stonic pupil reported with COVID, and also there are a couple of cases of IIH. We have also seen a patient in our OP, but because of lack of time, I have not included it in the presentation. So just a take-home message that when dealing with any neuroophthalmic condition, especially if there's an underlying history of a viral prodrome in the pandemic era, I think we should have a high suspicion of COVID. Thank you.
Thank you, Rachna. That was wonderful. I'd actually like to ask all the panelists, maybe starting with Andy, Rohit, Jyoti, Rashmin, if the patient does not have a viral prodrome and if there is no suspicion of COVID, I mean, should we still do a COVID test if they do present with neuroophthalmic symptoms? They could be asymptomatic. What would you, how would you go about? Would you think of that?
Andy, would you like to take it?
Sure. So at Houston Methodist Hospital, because we have very high prevalence rate of COVID in like regular people, we are testing everybody that comes into the hospital. Some of the people who have neuroophthalmic things actually just happen to have COVID because their prevalence is so high. However, the ones that are the most suspicious are similar to the case presented, where you have young person with COVID symptoms and stroke, and the D-dimer is what we're using to determine whether or not their thrombosis risk is high or not. So that D-dimer is like the fibrin split product. It's the marker of a thrombotic tendency. And so in COVID-19, there are probably multiple mechanisms by which COVID-19 causes thrombosis in the Virchow triad. It's both damaging the endothelium because it's a direct endotheliitis. It's got a hypercoagulable state involved in it, and it's got increased viscosity because this inflammatory cytokine storm component. So everybody with COVID-19 gets DVT prophylaxis with low dose enoxaparin. And if you're critically ill and we have D-dimer levels that are elevated, we're going to go to higher dose of prophylaxis. And if they've had a stroke, they're going to get therapeutic anticoagulation if there's no contraindication. So both NAION and stroke intracranially have been seen in our populations with COVID. And if that D-dimer is high, we're going to treat them.
Rohit, since you are also in an area where now the cases are rising and you must be seeing a lot of cases, what's your protocol?
Yeah, we are, but unfortunately, we don't test all of them. We are, I mean, of course, documenting those who have a previous history of COVID, but I mean, it may just be, it's anecdotal because there's no actual documentation, and ours being a tertiary center, we are seeing particularly papilledema. Raised ICT is something that is coming fairly frequently, and many have had COVID earlier. So some of them are positive and with a positive report, and some of them anecdotally give us the history that they had fever or symptoms suggestive, but they never got them tested. So it's tough to take a call, but at the moment, no, we're not, having a test for all the patients who are presenting. Andy.
I would just add the other circumstance when neurop is being involved is they're in this face down position for the intubation. And so we're seeing increased intraocular pressure and ischemic optic neuropathy. So it's just like the spine people who are in the prone position, that ischemic optic neuropathy from the prone position but instead of just hours at a time, it's like weeks at a time. And thank God that neurop is not the primary manifestation of COVID-19 because we'd be into all those ICUs, and I'm just I'm happy that that's not the reason they're in the hospital. But after they get out, we do see it. So I think it's under-recognized and underappreciated. And in our hospital, we say, look, if it's not an emergency, we're not coming. That's what we've been doing in our hospital. And so I think we're not seeing what's under there.
Thank you so much, Andy. I know it's very early for you, and thank you so much. We are really honored that you could join us, and as always, enthralled us. Thank you, Rohit, Rachna, Jyoti. In the want of time, we could have gone on and on, but in the want of time, I think we have to conclude. Manju, last words from you.
Oh, just thanks to everyone. I'm glad that we all could keep ourselves busy in the pandemic with webinars. Let's keep going. Thank you.
Yes.
Thank you.
Bye.
Thank you. Pleasure participating. Thank you.
Thanks. Thank
you. Bye-bye.
Yuvia.
Dr. Somshila, ma'am, you can start, ma'am. Okay. Unmute your mic.
Thank you very much. I hope some of our participants at least have logged in for the Yuvia session, and my co-moderator for the session is Dr. Malika Goel. I'd just like to share my screen. Four presenters session, and each of them is no doubt very, very well known and very, very knowledgeable in their own right. And just in case, because this is online, just in case I get cut off or you don't hear me, then Malika takes over. And if you don't hear either of us, then the presenters just go ahead and keep presenting. So we have, as I said, that the presenters are there, four presenters. We are very, very honored to have Professor Soon Fek Chi, who's going to give us the second presenter is Professor Ratinam, and she's going to talk about case-based approach in clinical examination, followed by Dr. Jyoti Biswas, who's going to go through diagnostic and therapeutic investigations particularly, and he's going to take a case of choroiditis and use that as an example. And last, but obviously not the least, is Soumya Basu, who's going to take us through ocular tuberculosis and what he has learned and what pearls he can give us. So to introduce the first speaker, it's my pleasure to introduce Dr. Chi Soon Fek. Most of you know her. She's no stranger to Indian meetings. In fact, I'm sure that she's very, very sought after by all our Indian meetings. She's a professor at SNEC, and she both cataract special departments over there. She's extensively published with more than 200 papers. She has published several, as well as several book chapters. She's the president of the Asia Pacific Intraocular Inflammation Study Group. She's a member of IUSG and IOIS. She's not after as a speaker, but she's also sought after for her live surgery, and I've been witness to that, where she can operate on the most complex kind of cases. Her research areas are both in cataract surgery and including her work on the femtolaser in various applications. And of course, in uvea field, we know her very well for her work on, well, whether it's viral uveitis or it's tuberculosis, VKH, and many other diseases. So I'll stop screen sharing and I'll hand over to Dr. Chi Soon Fek. Yeah.
So good evening, everyone. I've pre-recorded this, so I hope you can hear me now.
Yes, we can.
Okay, good. So let me start my talk. Thank you very much for inviting me.
Is the audio on for the talk? Malika, can you hear the talk?
No, I cannot hear.
Can you share with the audio?
Professor Chi, the audio may not be on.
My audio is on.
But we couldn't hear anything about the slides.
You can't hear anything?
Yeah, we could
Yeah,
hear
we can't
nothing.
hear you.
We can hear you now, but not when you are presenting.
Oh, okay. Maybe I'll go next and I'll just email someone my presentation. Would that be okay? Yeah, if I can just receive the email to send it to.
Yes. We'll send a mail, doctor.
Yeah, will you
Yes. Okay, sorry about that.
If you can stop screen sharing. Oh, thank you. So we move on to our second presenter, and I really wanted to talk about him, and that's why I'm just going to take a few moments to do that. Right. So Dr. Biswas, he's the director of uveitis and ocular pathology at Shankar Nechalya, and over 50 papers, 4 book chapters, including 4 of his textbooks. And as most of you may know, that he has recently been identified as one of the top 2% researchers of all times from a huge database. Malika, am I audible?
Yes, you are audible.
Yeah. And he's trained many uveitis specialists, either directly as being the fellowship director or indirectly people like myself, probably Malika. A lot of us have learned a lot from him over the years. So apart from all his various achievements, he's also the founding member, past president of USI. I think that the most important quality that connects with me, he's a very warm and modest storehouse of information, and he's a very compassionate and brilliant uveitis specialist. So I hand over to Dr. Jyoti Biswas. Could you share your screen, sir?
Just open my slides.
Okay.
Can you see my slides?
Is there any problem, sir?
No, we cannot see your slides. Sir.
Not yet.
Sir, first you need to open your presentation, then start share screen.
You open the presentation.
And go to Zoom. There is an option share screen.
Yeah. Can you see my slide?
Yes, sir.
Yes, sir.
Okay. Thank you, Somshila and Mollika, for giving me the opportunity. I like to share a simple case, a case to ponder. This is a 28-year-old gentleman from Karnataka. He was actually a doctor, MD radiologist. Chief complaint was floater in the left eye for 1 month. His vision was good in both eyes, 6, and 6. Intraocular pressure was normal. Anti-segment was normal. Right eye, what he brought with him, just choroiditis patches were seen in the superiorly. Left eye had vitritis and multifocal choroiditis. This is the photograph which he brought in that mobile, and I couldn't load it. So Array of investigations was done, which include color fundus photograph, autofluorescence, fundus fluorescent angiogram, indocyanine green angiogram, swept source OCT, and swept source OCTA, optical coherence tomographic angiography. We did lab workup, complete blood count, Mantoux test, quantiferon TB gold test, HRCT test, and we also did visual field. And this is the fundus picture of the patient. You can see the right eye fovea is normal, the central retina is normal, but in the superiorly, there was an active choroiditis patches, multiple. And in the left eye, you can see the multiple choroiditis patches, and one of the patches is very close to the fovea. We did autofluorescence as it helps us to identify the active lesion, and this showed there are some patches, both in active and heal stage. The arrows are shown that the yellow color arrows shows the active patches of the choroiditis. We did FFA and ICG spectralists, and in the right eye, we could see that very periphery, the choroiditis patches. And this is the late stage FFA and ICG. Fundus fluorescent angiogram showed choroiditis patches in the left eye more prominently. The right eye, it was in the far periphery, and we could see that lesions were all over the posterior pole as well as the mid periphery. We did the swept source OCT, which did not give much significant information, except if the retinochoroidal lesions was seen with that one. SSOCT showed right eye normal, left eye flow void areas and the superficial capillary plexus. Other investigations was the complete blood count of the normal. Quantiferon TB gold test was positive. Mantoux test was negative. High resolution CT test was normal. But the visual field in the left eye showed several defects. So our diagnosis was multifocal serpeginoid choroiditis. And to salvage the vision, as the lesion was very close to the fovea, we decided to give intravenous methylprednisolone, 1 gram diluted in 500 ml of saline with 3 consecutive daily doses. Treatment of inflammation, we put the patients after that oral prednisolone at 1 milligram per kilogram of the body weight. And though the Mantoux test was negative, quantiferon TB gold test was positive. As you know, that this multifocal choroiditis in our country, mostly of tubercular etiology. So I went ahead and gave the patients a full course of anti-tubercular treatment under supervision of a TB specialist. And this patient was also given the IVMP, as I told you, 1 gram daily for 3 consecutive days. And you can see that the left eye lesion started resolving. The lesion from the close to the fovea has stopped progressing. After 4 weeks, there was a significant improvement of the lesion, and the vision also remained maintained at 6, and 6. And this is the left eye pre-IVMP and post-IVMP over after a week. This is the post-IVMP lesions is seen over that one after 1 week. After 4 weeks, there is a complete resolutions of the lesions, and the visual field, the right eye is within normal limit, that central scotoma, the left eye. So this is the left eye vision, visual field showed significant central scotoma significantly improved. So in summary, we are dealing with a multifocal serpiginous choroiditis, and I just wanted to highlight what we do in such cases. There is a nice paper by Dr. Rima Bansal, where he has described multifocal serpeginoid choroiditis present tubercular etiology. And they have found that if the patients are on anti-tubercular treatment, the chances of recurrence has reduced significantly. So there is a difference between the multifocal and classic serpiginous choroiditis. Classic serpiginous choroiditis in our country, we see much less. This is TB endemic areas seen with multifocal serpiginous choroiditis. They are younger in people, younger patients, and they present with the vitritis. Juxtapapillary choroid is paired. There is a non-contiguous lesion, small, multifocal, varying geographic shapes, and significant pigmentations are seen, and their progress is rapid, and antitubercular treatment is helpful. In contrast, the classic serpiginous choroiditis is seen in that non-endemic areas. They're older people, there are no vitritis or insignificant vitritis extending from the juxtapapillary choroid. They're contiguous, large, solitary amoeboid lesions, and insignificant except at the pigmentations is insignificant except at the borders. Progression is relatively slow, and these patients are classically treated with the immunosuppressive agents. So this is a classic serpiginous choroiditis where the mostly treated with the immunosuppressive agents, and this is the multifocal serpiginous choroiditis, which is we are treating with anti-TB treatment with steroid, initially phobia-threatening cases with intravenous methylprednisolone. So etiology of this is actually, I believe, this is an immune-mediated inflammatory response to the Mycobacterium tuberculosis DNA, resulting in hypersensitivity reactions and clinically manifest as multifocal choroiditis. And it mimics what is called classic serpiginous choroiditis. So there's an elegant paper by Dr. Padma Malini and Dr. Narsingh Rao, where they saw a case of multifocal serpiginous choroiditis, which classic features fundus photography and fundus autofluorescence. This patient had retinal biopsy, and once I see the retinal biopsy, I am just quite convinced that this is a tubercular etiology, because we saw the giant cells and the lymphocytic collections, and this was positive by PCR, though acid-fast bacilli was not seen. So based on this paper, I tend to put the patients on multifocal serpiginous choroiditis on antitubercular treatment. So there are other variants of serpiginous choroiditis can be macular, and which is often have poor visual prognosis, or can be peripheral, which we have described in the recent Indian Journal of Ophthalmology, or can be amphigenous. We had a series of some cases which has been described in the ocular immunology and inflammation. Why should we investigate, and what investigations should be done? So I find autofluorescence is quite helpful to delineate active age from the healed age, and you can see that the green color showing active age, hyper autofluorescent, and black color indicates that hypoautofluorescence lesion. And this is the FA of the healed, and this is the reactivations of the lesions. This right side is the healed, and left side showed reactivations of the lesion. To find out the extent of the lesions, we found that the FFA is can be done, but ICG is better. You can see that more lesions as well as the larger size of the lesions. And you can see that the red circle indicates that there is, instead of one single lesion, there are multiple lesions are seen. To detect the complications, particularly CNVM, in a case of multifocal serpiginous choroiditis, we can do an optical coherence tomographic angiography, which can elegantly detect that neovascularization. But I have not seen any case of choroidal neovascularization in the active stage of the disease. So the role in active stage of the disease, I am not very convinced. So quantiferon TB Gold test is a test which is can be used along with the Mantoux test, and if it is a positive, it strengthens the suspicion of tubercular serpiginous choroiditis. I do visual fields test to find out the quality of the vision, and this patient, you can see that response to the treatment with the IV methylprednisolone followed by the steroid therapy. So differential diagnosis, I think only close differential diagnosis is APM-PPE and acute posterior multifocal placoid pigment epitheliopathy. These are viral prodrome is often present, but not necessarily all the time. They're scattered randomly, and fundus fluorescence angiogram is quite characteristic. Initial hypo, block fluorescence followed by the hyperfluorescence, and then resolves in 2 weeks, good prognosis. But I treat all such cases with the systemic steroid. I don't take chance for spontaneous resolution. So what treatment you should give? My way of doing is that to arrest the acute attack, I put the patients on intravenous methylprednisolone, but though not effective in preventing the recurrences and recurs on tapering the dose, so I put the patients in addition immunosuppressive intravenous methylprednisolone along with the immunosuppressive agents. This is one of the case. Another case where they put the patients in IV methylprednisolone, and you can see that significant resolution of inflammation. So why to immunosuppress? Larger period of disease inactivity, longer period of disease inactivity can be obtained. Reduce the potential side effects associated with the high dose systemic steroid. You can reduce the taper the steroid and take longer time to attain the desired level of therapeutic concentrations, not for acute exacerbations. So I gave these patients mycophenolate mofetil along with the steroid, but one can give azathioprine and cyclosporine also. For severe cases, they have described that cyclophosphamide has got a role, but I don't have any experience of using cyclophosphamide. ATT to use or not to use, I think is that I feel that ATT should be used all cases of multifocal serpiginous choroiditis in our country. But there is a chance of paradoxical reactions, about 14% of the cases. And in such cases that one need to hike up the oral steroid and add immunosuppressive agents. So take home message is suspect TB in all cases of multifocal serpiginous choroiditis, sufficient imaging, save the phobia and suppress if needed, and still remains an enigma. The protocol is not really standardized, but this is the way I treat a case of serpiginous choroiditis, multifocal serpiginous choroiditis. Thank you very much, Mallika and Somshila, for giving me the opportunity.
Thank you very much, sir. As usual, very comprehensive talk, and you've literally, I'm sure, clarified a lot of doubts with your strong concepts. Mallika, we have time for one question. Would you like to ask Dr.
Yes,
Jidhi?
yes, I would like to. So I would like to know what is the importance you give to the skin test and the TB Gold result. If they are negative, but the clinical suspicion is strong, would you still give anti-TB?
I give multifocal serpiginous choroiditis all cases antitubercular treatment. So based on the several studies and that one of the histopathologic study convinced me that these are most probably is due to the tubercular etiology. Even in the quantiferon TB Gold test or Mantoux test is negative.
Yes, I agree. We should go with mostly with the clinical.
So this is an intraocular TB, not that systemic TB. I consider it that way.
And have you had patients where systemic steroids has just not been enough, and you had to also give periocular steroid or an intraocular steroid to supplement?
I have given intravitreal dexamethasone, Aujudex implant in cases of recurrence of serpiginous choroiditis where in spite of the treatment, steroid treatment, not responding, and the patient has contraindications for giving the oral steroid. A patient doesn't want oral steroid. I have given intravitreal dexamethasone implant, and they show good results. And there are some papers also describing the utility of Aujudex injection.
Thank you.
Thank you. Thank you very much, Dr. GB. Time is eyeing me, so we go on to the next presenter. We'll go on to Dr. Ratinam first, and then come back to Professor Chi. So I'd just like to quickly introduce Dr. Ratinam. And I think, once again, she's somebody who doesn't need much in terms of introduction. She's the Chief of Uveitis Service at Arvind Eye Hospital in Madurai, and where she had also trained from. As you know, that she also has a PhD based on her research work on leptospirosis, which she had worked on systematically for almost 25 years. She's received many of our prestigious Indian and international awards, and she's also a member of IUSG. She's a past president of USI, including being its founding member. So she has multiple talks at various presentations. She's always part of most of the international fora for uveitis. What really affects me a lot and why I respect her so much, that all of you who met her know that she's extremely hardworking. She's a guide, mentor, and friend. And also she has multiple roles in which she excels as a mother and grandmother. And of course, she's a compassionate and brilliant uveitis specialist. So I believe she's not able to physically join, but thanks to the virtual platform, we do have a talk, and it's going to be played.
Sincerely thank the organizers for giving me this great opportunity to present a very interesting case of bilateral exudative RD following facial bleaching. I have no financial interest or relationship to disclose. 22 years old bride presented to her ophthalmologist 1 week prior to her wedding with history of acute bilateral vision drop. History was interesting. It was sudden, painless bilateral drop of vision for a week. She gave history of taking treatment for acne in the form of creams and capsules. She also gave history of multiple skin cream application for facial whitening at a beauty parlor as part of her pre-wedding preparation. There was no history of floaters, no photophobia, no redness, no tinnitus, and no headache. Her dermatology treatment used skin light cream, which had memetosone, which is a steroid which blocks the production of certain prostaglandins. On examination, anterior segment in both eye was absolutely normal. Vision in right eye was 20/200, left eye was 20/60. IOP was normal in both eyes. Fundus examination showed clear vitreous in both eyes. Right eye disc was hyperemic, left eye disc was edematous. Macula in right eye had multiple packets of serous detachment, left eye had macular fan. Posterior segment in both the eyes had inferior exudative retinal detachment. In addition, left eye had a peripheral healed scar. We came to the differential diagnosis of CSR, probably due to steroids in her facial lotions causing bilateral exudative RD. Second differential diagnosis was VKH syndrome following facial bleaching. There are quite a lot of literature support steroid-inducing CSR. And we have published Watt-Koyanagi-Harada syndrome after cutaneous injury. 3 of our female patients developed contact dermatitis at the place of bindi application, and further they developed vitiligo and Watt-Koyanagi-Harada syndrome. We published that in Ophthalmology in 1999. So with the differential diagnosis of CSR VKH, we proceeded with laboratory workup. Complete blood count, VDRL, TPHA, ACA were done, and we do PPD in every case because India is an endemic country for tuberculosis. In order to start steroid and or immunosuppressive, we always need to rule out tuberculosis. So FFA and ultrasonogram was also ordered. To our surprise, FFA did not support VKH or CSR. There was no starry sky pattern of VKH, no small stack appearance or inkblot appearance of CSR. Rather, it was just a serous elevation with pooling of the dye. The old scar remained old and it was not picking up any stain. Further to our surprise, there was a mass lesion in the right eye in B scan. We expect symmetrical choroidal thickening with exudative RD in VKH. Here is a mass lesion. So we thought it could be a metastatic lesion. So our differential diagnosis got revised as Muscadet syndrome and tuberculosis. Additional investigations were done as CT chest, CT abdomen, CT brain. CT chest showed a very interesting finding of mediastinal lymphadenopathy of tubercular etiology more likely than sarcoidosis. By the time we crossed 48 hours, and her PPD was 25 millimeter and ACE was normal, we reached the final diagnosis of tuberculosis. 4-drug anti-tubercular treatment was started with oral steroid of 60 milligram prednisolone. The lesion started resolving in 4 weeks, and in 6 weeks, they completely disappeared. The patient was comfortable and had vision of 20/20 in both the eyes. She had tubercular chorioretinitis earlier, which was the cause for the macular fan. We never expect macular fan in CSR or VKH. Probably because of the stress at the time of wedding, there is exacerbation of tuberculosis in both the eyes. She developed bilateral simultaneous choroidal tuberculosis, which is rare even in tuberculosis endemic country like ours. Thank you. Thank you for the opportunity.
So we're really missing Dr. Ratinam here. I think she's presented a very unusual and a very astounding case. And incidentally, she talked about a bride who got this disease and she's gone to attend a marriage currently and she's not able to log in from there because there's no connectivity, though she had everything set up. So I think that we could ask maybe first Dr. JB and then Dr. Chi and then Soumya to comment on this case. Dr. JB, so it's a bilateral exudative RD, but eventually she ruled out VKH and then CSR and then finally thought about tuberculosis.
It's an amazing case. I have not seen such bilateral tuberculosis with serous retinal detachment with the choroidal and mimicking like a VKH. So the way it is worked up and treated is quite nice and quite appropriate. I would have kept the possibility of CSR, one of the possibility in this case, the bilateral CSR. That is the closest diagnosis which has been ruled out.
Dr. Chi?
Yeah, it's an amazing case. I mean, we wouldn't see a patient like this in Singapore, I think, but I was just wondering whether CSF analysis was done and whether, you know, she had some CNS TB to get a bilateral involvement.
Soumya?
So hello, everyone. I think this was a very interesting case. Basically, we have three major differentials, CSR and VKH and tuberculosis. I think metastasis can be ruled out after all the extensive investigations. Now, CSR, if we consider that the patient was given high-dose steroids and there was no worsening, we can effectively rule out CSR there. So it's basically between VKH and tuberculosis. Now, very simplistically, if you look at it, the patient was also given high-dose steroids. And just the fact that the tuberculin skin test was significantly positive and there was evidence of systemic tuberculosis, mediastinal lymphadenopathy, does not rule out the fact that there could still be VKH in there. CSF analysis certainly would have helped for looking for CNS TB. It could have also helped looking for VKH in this particular patient. I didn't see an ICG in this patient. I guess an ICG might have helped in looking at ruling out VKH in a better way. Now, let's say this was TB. If this was TB, an exudative RD happening without any kind of mass lesions showing up on the FFA. I didn't see. Maybe I missed it somewhere, but I didn't see a mass lesion on the FFA. That seems a little difficult to understand for me. So for me, even though the patient has responded to a combination of ATT and steroids, I wouldn't still rule out VKH completely in this particular patient.
Malika?
I think if it was not for the mass on the B scan, we would have stuck with the diagnosis of VKH. And possibly the additional steroids that was given did cover for the VKH or any other autoimmune uveitis exudative RD. So it's only that mass, but I'm not sure if mass cannot be there in VKH, occasional case reports, if there are any, I would have to see. So
I don't think mass can be there in VKH. That's such a huge mass.
So I don't know.
Clinches the diagnosis, I would say. That's the only.
Did she say that there was a mass on B scan?
Yes, there was a mass on B scan, but surprisingly, it didn't show up on the FFA. If there is a mass that is leading to an exudative detachment, I'm sure it would show up as a large leak on the fluorescein angiogram. So that is something that I'm not very much convinced about yet.
So I had to ask a question that, Soumya, you know these cases that we have of bilateral exudative RD, which come in after drugs, for example. And they also have a lot of component of inflammation in them, though the presentation is slightly different. They have a lot of anterior segment involvement and secondary angle closure, high pressure. So this wasn't like that. Why can't this be a variation of that? Bilateral exudative inflammatory exudation, secondary to bleach, which is cortisone, a lot of cortisone.
I mean, nothing to my knowledge that I think you're talking about topiramate toxicity.
Exactly.
Yeah, but the intraocular pressure was, so the main pathology in topiramate toxicity is the rotation of the ciliary body and the angle closure glaucoma. So, I can't fit in anything else in there as far as drug-related disease is concerned.
So the basically, how do we rule out? I mean, of course, one was the doing the CSF analysis. Any other way to rule out between tuberculosis versus VKH?
JB sir is saying something.
I just want to say the response to the steroid will be, VKH will be very phenomenal. Within a week, you can get that resolutions of the lesions, whereas the tuberculosis will take time.
Yeah.
Also, maybe TB Gold, doing the TB Gold test might help. Additional information.
Already Mantu is positive.
Yeah,
20.
so another test.
Yeah.
How about audiometry? High tone hearing loss.
Yeah. That would have helped.
Yeah. So maybe we'll ask Dr. Ratinam when we see her next. And thanks for discussing this case. I think finally we're ready with Dr. Chi's presentation.
Yes, doctor.
Yes. Can we please have that now?
Please play. Hello, everyone. I'd like to thank Shoma Sheila for inviting me to speak on viral anterior uveitis clinical pulse. These are my financial disclosures with no relevance to my talk today. Viruses associated with anterior uveitis are predominantly the herpes family viruses, HSV, VZV, CMV, and also rubella virus. Other viruses include chikungunya, Zika, both of which are rare. So when do we suspect a viral etiology? When the patient has a unilateral involvement, either acute, recurrent, or chronic presentation, raised intraocular pressure at presentation, iris atrophy, KPs that are pigmented, small or medium-sized, or stellate and diffuse, and the presence of corneal involvement or early development of a cataract. So the viral phenotypes include anterior uveitis with granulomatous KPs with or without keratitis, which are likely to be caused by HSV or VZV, Boston-Schwarzman-like syndrome. This is mostly caused by CMV, Fuchs heterochromic iridocyclitis like uveitis. In the west, it's caused by rubella, and in the east by CMV. So how do we differentiate between HSV, VZV, and CMV in a patient who presents with acute hypertensive anterior uveitis? In a patient who's more than 60 years old or in the immunocompromised, we would suspect of VZV more than the other viruses. CMV has a slight male predominance and also tends to involve Asians more commonly. Laterality generally is unilateral, although HSV can be bilateral. This is not common. The cause is acute and recurrent in all three viruses. These patients may all have pressure spikes. However, in CMV, it's usually extremely high, up to 50 mmHg during acute episodes. Skin involvement may be present in HSV and VZV involvement, but not with CMV. Conjunctival injection in CMV tends to be mild as compared to HSV and VZV. The corneal sensation may be reduced in both HSV and VZV, but especially VZV, and is intact in CMV. Epithelial keratitis may present as dendritic ulcers in HSV, pseudo dendritic ulcers in varicella zoster, but no involvement in CMV. Stromal keratitis in the form of immune ring keratitis may affect HSV, VZV, and CMV, but in HSV, it tends to also more commonly be associated with disciform keratitis or interstitial keratitis. In VZV, it is more commonly nummular keratitis or limbal keratitis. Corneal scars may be present in about a quarter to a third of cases of HSV and VZV, but rare in CMV. Endothelitis may be present in all three virus involvements. VZV tend to be similar. They are medium to large, and they tend to be located centrally, pericentrally, less commonly diffusely, or in Arts triangle, and they may be associated with inflamed cornea. However, in CMV, the KPs, though they may be medium to large in size, tend to be single or few, and they may be located centrally or in the peripheral cornea. We may also see coin-like lesions or nodular endothelial lesions in CMV. The KPs may be pigmented in viral infections, but very uncommon to see pigmented KPs in PSS. The endothelial cell density tends to be significantly reduced in eyes with CMV. The anterior chamber activity tends to be mild in Posner-Schlossman syndrome, very, very severe in varicella zoster, and moderately severe in HSV. During the acute phase, HSV and VZV can cause pupil flattening or iridoplegia, can subsequently lead to sector iris atrophy, and in HSV it can also cause spiral atrophy. In VZV, because of the severe inflammation, it can also cause massive iris atrophy from vasculitis. However, for CMV, generally iridoplegia is absent. The iris atrophy is mainly stromal, and it can be patchy or less commonly diffuse. Heterochromia is mostly absent in these three viruses, although uncommonly it can be present with CMV. Posterior synechiae are typically absent in CMV, but may be present in HSV and VZV. Cataract may develop late in the disease in all these three viruses. Vitritis can be present in varicella zoster and is less common in HSV and rare in CMV. There are usually no choroidal scars. Glaucoma may develop in all these three viral involvement. These are clinical photos of HSV, VZV, and CMV, and you can see that it is difficult at a glance trying to clinically differentiate between HSV and VZV because they have got iridoplegia during the acute phase and they can have keratitis, although the pattern of keratitis involvement differs. They both can also have sector atrophy with transillumination. However, CMV is quite different. You will see that the KPs tend to be fewer and they have a mixture of medium and small KPs that may just be in the center or pericentral region, and sometimes they can even take on a linear pattern, and the iris atrophy, if it does develop, is usually patchy stromal involvement. So how do we differentiate CMV from a rubella virus Fuchs uveitis syndrome? For patients with rubella, they tend to present at much younger age, 20 to 40 years old. There's no gender predilection, unlike CMV, where the patients tend to be male and a little older, 40 to 60 years old, and tend to also affect mainly Asians. It tends to be unilateral in both conditions, but a few cases may be bilateral. The disease tends to have chronic cause. The pressure can be elevated in both conditions and can be extremely high in cytomegalovirus. Dermal manifestations are absent in both virus involvement. Conjunctival injection may be mild in CMV, but typically a white eye is seen with rubella virus. Corneal sensation is intact in CMV as well as rubella, and there is no epithelial keratitis involvement. Stromal keratitis in the form of immune ring keratitis may develop in chronic CMV but does not develop in rubella. There are usually no corneal scars in both of these virus involvements, although there can be endothelitis in CMV. The keratic precipitates in chronic CMV tend to be small to fine and stellate, but sometimes you may see some scattered medium to large KPs and also the presence of coin-like lesions and nodular endothelial lesions. They also tend to be very diffusely distributed and may be even pigmented. And for rubella, the KPs are similarly small, fine, and stellate, and very evenly distributed throughout the endothelium, but they never get pigmented, and the endothelial cell count is normal in rubella, but may be significantly reduced in chronic CMV. Anterior chamber in these two virus involvements tend to be mild. The iris in CMV may actually develop eudoplasia, where you see a mild mid-dilated pupil, whereas this is normal in rubella. Iris atrophy is a stromal atrophy in both diseases, and there may be transillumination in eyes with rubella virus. Amsler sign can be present when the eye is tapped or during cataract surgery, and in both viruses, but in rubella we may also see copy nodules at the pupillary edge. Heterochromia is uncommon with chronic CMV, but may be present in rubella, especially in light-colored iris. Posterior synechia is typically absent in both virus involvement. Cataract develops in CMV over time. However, in rubella, this is different. It develops early and therefore is often present at the time of presentation in about half of the patients. Vitritis is almost always present in rubella, but rarely present with chronic CMV. Coronal scars may be present with rubella, and interestingly, this hyperemia is also confirmed on fluorescein angiography, may be seen in both virus involvements, but in addition, CMV may be associated with a delay in arm retinal time. In both conditions, glaucoma may develop. These are clinical photos of chronic CMV on the left and rubella on the right, and you can see the similarity in terms of the fine stellate KPs that are evenly distributed, but CMV you can see in some eyes have got pigmented KPs that never develop in rubella, and you can see copy nodules in rubella that never actually develop in chronic CMV. In addition, chronic CMV may have the typical coin-like lesions or endothelitis. So the diagnostic test is to do an aqueous tap for qualitative and real-time PCR, and where available, Goldman-Whitmer coefficient. We should tap when the eye is active, such as during a spike of pressure when a lot of anterior chamber cells. Just be aware that you may have false negatives, and it may be necessary to tap the eye more than once. Treatment of viral anterior uveitis depends on the causative virus as well as the host immune system. So the mainstay of treatment for viral anterior uveitis is a combination of topical or systemic antivirals with topical corticosteroid or NSAIDs, cycloplegics, and intraocular pressure lowering medications. So the antivirals for HSV and VZV include acyclovir, valacyclovir, or famciclovir. For CMV, it is valgacyclovir. In a recurrent disease, we treat for at least 3 months, and if this relapses after discontinued treatment, the patient should be treated for 1 year, and then we can try to discontinue. However, if the patient relapses, then we generally go on to lifetime prophylaxis. This is a busy flow chart that shows the treatment of viral anterior uveitis that presents as hypertensive anterior uveitis. So aqueous sampling is done, and if we get a positive result for HSV, we should treat with oral acyclovir or valacyclovir, and this is given at a therapeutic dose. And if there's epithelial keratitis, we then add acyclovir or ganciclovir, and these patients should be given topical steroids for inflammation together with cycloplegics for anterior uveitis. If there's persistent or recurrent anterior uveitis, the acyclovir or valacyclovir is continued on a maintenance dose, and the topical steroids tapered very, very slowly. Now, this is the same treatment if we get a positive result for VZV, although the dose of the antivirals differ. If we get a positive result for CMV, it really depends on whether the patient is presenting as a Posner-Schwarzman syndrome or as a chronic anterior uveitis. If it is a Posner-Schwarzman syndrome and who has infrequent attacks at healthy disc and cornea, we will just treat the patient for the attacks with pressure-lowering medications, topical NSAIDs, and short-term topical antivirals, and we send by anti-glaucoma medications for the next attack. And if we have got frequent attacks, then and also optic nerve damage and dropping endothelial cell count, we want to give topical ganciclovir gel and topical NSAIDs or mild topical steroids and anti-glaucoma medications. In a patient who has got positive result of CMV with chronic anterior uveitis, who also has got glaucomatous optic neuropathy or dropping endothelial cell count, we give topical ganciclovir gel 0.15% with topical NSAIDs or mild topical steroids and anti-glaucoma medication. Now, if this patient or a patient with chronic recurrent Boston-Schwarzman syndrome does not respond and still is positive on repeat tap after this medication, we then switch to or we add ganciclovir 2% eye drops given every 2 hourly with topical steroids. And if this resolves, we then just continue on a maintenance dose of eye drops or switch the patient back to gel. Now, if this does not work, we then sometimes add the gel to the eye drops. And sometimes if this does not work, we then go on to oral medication. And once this is controlled and the patient CMV negative, we then take backward steps and stop the oral medication and switch to eye drops and then to gel and gradually try to taper the topical steroids. For rubella, there is no treatment, and therefore it's important to actually avoid steroids and to monitor for glaucoma. In summary, aqueous analysis is necessary for specific viral diagnosis. HSV and VZV anterior uveitis is treated with oral antiviral therapy with topical steroids and cycloplegics. The initial use of topical ganciclovir is preferred for CMV anterior uveitis, and treatment failures should be given oral valganciclovir. Due to the tendency for viral anterior uveitis, especially CMV, to relapse, long-term prophylaxis may be necessary. Thank you very much for your attention.
Can't hear you, Somshila.
Doctor, you have to unmute your mic.
Can Malika help?
Are you sharing?
I'm sorry. Can you hear me?
Yes.
Okay. What's the problem? Is doctor muted?
Can you hear me now?
Yeah.
Yes.
Oh, okay.
All right. I'm sorry, I was busy with the other session.
Sorry about that. So I just wanted to thank Professor Chi. I think that got missed, for taking such a comprehensive talk on the subject. I think that most questions, even some questions that I had, have been answered by her talk. And I thank her for spending her time. I know it's pretty late for her in Singapore. So thank you once again, ma'am. And we hope to hear much more from you in the future. So the last speaker is Dr. Basu, my colleague from LV Prasad Institute. He's my boss in the uveitis services. He trained from the University of Mumbai. He did 2 retina fellowships here. And then he went on to do 3 research fellowships at various very well-known centers. His research work is on the molecular diagnostics and immune pathogenesis of tuberculosis. His PI for several clinical trials. He has multiple research grants, and he is published widely, especially in his field. At his young age, he's already the section editor for journals and a reviewer for nearly all major journals. And what I really like about him, that he's always inquisitive. He questions the conventional concepts and therefore probably comes up with new ones. So I'm going to ask him to quickly be the last but not the least in this session.
So thank you, Somshila, especially for acknowledging that I'm still young. On that happy note, I'll start my talk. So first of all, I must admit that I've chosen a very expansive topic. You can't cover this up in 10 or 15 minutes. And I must also admit that since this is a controversy, everyone has his or her own opinions. And while I present my opinions, it's important for the audience to listen to all types of opinion and then take their own call on this controversy. Now, firstly, I think we have to, while this may sound very obvious, we must first understand that TB uveitis is a real disease. It's caused by a bacterium. It has multiple clinical presentations, some of which you can see here. And it responds to anti-TB therapy either by direct resolution of the lesions or by non-recurrence after you have stopped the treatment. And we really don't have to be too defensive about ocular tuberculosis. It's not that we are always at a loss just because we are not able to get the bacteria from the ocular samples. Now imagine a chest specialist treating tuberculosis. All that he or she has is this chest X-ray or at best a CT scan of the chest and telling you the pathology. You can just see some spots over in this X-ray, and which is nothing compared to what we get to see in the eye, in the fundus or even on the slit lamp. A very beautiful picture of the granuloma expanding like this with serpiginoid borders. Dr. JB just discussed about it. Or a beautiful vasculitis lesion. You see the exudation around the blood vessels. You see a retinitis lesion overlying the blood vessels. Not only this, you have tools in your hand such as the autofluorescence that tells you how to differentiate between activity and resolution of the lesion, or let's say a more invasive test like a fluorescein angiogram, which shows you the capillary occlusions, or it shows you the leakage from the vessels, which differentiates between the active or the inactive vasculitis. So we really have a lot of tools in our hand, and we don't have to feel defensive about this disease. Now, while there are a lot of questions that can be discussed about ocular tuberculosis, I thought of including just 3 important questions which I think the audience here would be very interested to know. How do you approach the diagnosis, whether you focus on the clinical sign or the immunological test? What is the role of PCR, and where does how does the anti-TB therapy help in these patients? So the first question is, and this was alluded to by Dr. Malika a little while ago, what do you really focus on, the clinical sign or the immunological test? Now, especially in a TB endemic country like ours, the focus should always be on a clinical sign. And this works both ways. So, for example, you have a patient with non-granulomatous anterior uveitis, or, for example, a bilateral exudative RD. Let's forget Dr. Ratnam's case for a while, but a bilateral exudative RD or a sunset glow fundus. In such a case, even a very high tuberculin skin test or an associated quantiferon TB gold test is not going to take you to tuberculosis unless you have ruled out the more obvious causes, which, for example, for non-granulomatous anterior uveitis, it would be HLA-B27. For a bilateral exudative RD, you would first like to rule out weak age. Only when you have ruled out these conditions completely, you would start thinking of tuberculosis as a cause. So it's a clinical sign that should always get the predominance. The other part is we are all aware of the possibility of a false positive immunological test, a MON2 test or a quantiferon TB gold test in a TB endemic countries. This is repeated in every other meeting that you attend, either by the speaker or by the audience. But we should also be alert about the possibility of a false negative immunological test, which could either be due to a faulty technique or due to biological causes which are specific for the given patient. And finally, whenever you are applying all the criteria for the diagnosis of ocular tuberculosis, remember it is imperative to rule out the non-TB entities which are specific for a given clinical sign. I think this last sentence is the most important part in the diagnosis of ocular tuberculosis. Now let's look at the MON2 test a little bit more, because this is something that all of us have questions about. Like I mentioned earlier, beware of the false negative MON2 or quantiferon TB gold test as well. For MON2, this could be due to a faulty technique, somebody injecting subcutaneously instead of intradermally, a poor quality tuberculin, disseminated tuberculosis. It's very well known that patients with miliary tuberculosis have a negative MON2 test very often, and various causes of immunosuppression, which could be HIV, drug-induced, neutropenia, or diabetes, and especially in very, very young patients. So all these could be factors for having a false negative MON2 test, even when the clinical picture is staring at you and telling you that this is tuberculosis. A little bit more about MON2, and this is where the role of BCG comes in. We all keep talking that, just because our entire population is vaccinated with BCG, it means that the MON2 test doesn't have a role. Let's all remember that if BCG is given in infancy, and we all know that in our country, BCG is given in the neonatal period, then after the age of 1 year, and especially after the age of 10 years, BCG has no impact on the result of the MON2 test. So if we are clear about the age, let's not get distracted by the possibility of BCG vaccination in these patients. Now, here is a patient which I presented several times in earlier meetings, but it's still very relevant. The patient is a 28-year-old male who came to us with these choroiditis lesions in both eyes, smaller in the right and larger in the left eye. The tests for tuberculosis were negative in this patient, and there was no history of TB contact. So my colleague treated this patient with oral corticosteroids, and within 5 months, you have seen that all the lesions have disappeared completely, and you're only left with these pigmented lesions, which incidentally are overlying the blood vessels. Now, this patient came back to me about a year later with such a large tuberculoma covering several disc diameters on almost the entire macula. Now, what I should have done at this point of time is do a quantiferon TB test. In fact, it is very much advised that you should do both the quantiferon TB Gold test and the MON2 test together for these patients. But I just looked at the previous clinical picture, ruled out the possibility of this being a fungal granuloma, also found out that the patient is a migrant worker, and based on these multiple criteria, I treated this patient with anti-TB therapy alone. And with this treatment, just within 2 weeks, you can see how the lesion has melted down, and in 5 weeks' time, it's almost completely gone. So trust the clinical sign all the time, even if your skin test is negative, or even if your quantiferon TB Gold test is negative. Now, a little bit about the PCR. Now, unlike the MON2 test, which has a tendency to be false positive, the PCR has a tendency to be false negative because of various factors about which I think many of us are aware of. But here I would like to emphasize the possibility of a false positive PCR because of the presence of bystander Mycobacterium tuberculosis DNA at the site of inflammation. And this we found out when we tested patients with culture-proven non-TB endophthalmitis for TB PCR, and we found that 16% of these were positive for TB PCR, while the controls were negative. So let us not also be carried away by a positive PCR test in these patients. And finally, the role of anti-TB therapy. Now, anti-TB therapy can work in two ways. One is the resolution of inflammation, which we can see when the patient is treated with ATT alone, or non-recurrence of inflammation, especially when the patient is treated with ATT plus corticosteroids. And here the recommendation is that we should look for a minimum duration of at least 2 years. Now, here's a patient of retinal vasculitis of tubercular origin. You can see a retinitis lesion overlying the blood vessel here. This, in our experience, opinion, whatever you call it, is infection driven. And this patient, when treated with ATT alone, you see that within a month or 2 months time, I don't remember the exact time duration, but how the lesions have disappeared completely. And here is another patient with 2 tuberculomas sitting here and here. And this patient, in 2 weeks time, you see the resolution has begun to appear. And in 2 months time, there's only a small bit remaining over here. On the other hand, when you have a picture like this, which we call as serpiginous-like choroiditis or multifocal serpiginoid choroiditis, you have this large activity around these kind of patients, Dr. JB mentioned, have to be treated with adjunctive corticosteroids. Otherwise, they have a very high risk of paradoxical worsening. Summarize, ocular TB is caused by active infection. The clinical signs are always more important than the immunological test. PCR is yet to be useful. We don't know if it might be later. And anti-TB therapy is effective either alone or in combination with corticosteroids. Thank you for your attention.
Thank you, Soumya. I'm sorry you had to put up with the buzzers. You were very much on time. We just delayed from the session. So I just like to very quickly thank all the speakers once again. And over to you, Malika, as you're staying in for the next session. Thanks for being my co-moderator. Thank you and bye, everyone.
Bye-bye.
Okay. Can we move on to the retina session now?
Yes, doctor.
Yeah. Okay, I will be sharing my screen for the introduction. Can I share my screen here? Okay.
Yes, ma'am.
Yeah.
Your permission.
Okay. So I would like to welcome all the illustrious guest faculty here for this HOA meeting, and I'm extremely thankful to all of them. This will be roughly our program. Professor Rosenfeld from the Bascom Palmer Eye Institute will be speaking on non-exudative macular neovascularization in AMD, and he will be introduced by our chairperson, Dr. Lalit Verma. We are thankful to Dr. Lalit Verma for accepting to be the chairperson for the panel discussion, and he needs no introduction. There is a talk by Professor Vishali Gupta on the fluid story in AMD. Another esteemed guest faculty is a panelist, Dr. Pramod Bhende. Dr. Raj Narayanan will be speaking on the new drug, brolucizumab, his experience at LV Prasad Eye Institute. And then these are the panelists from the HOA. So this session has been supported generously by Novartis. So without further ado, we will start with the first talk. We'll invite Dr. Vishali Gupta for fluid story in AMD. Dr. Vishali Gupta, please.
And thank you, HOA, for the very kind introduction and the opportunity to be part of this symposium. So I'm going to talk about the fluid story in AMD. The fluid, the core knowledge of the fluid dates back to a long time ago, the moment we started doing trials nearly a decade ago. Starting with the cat, it was found that any fluid on the OCT means a kind of bad news and it should be treated. Started with the time domain, coming on to spectral domain. The various trials after trials showed the importance of the fluid. And not only the trials, if we go into recommendations of various societies, all the societies unanimously recommend that the moment you see fluid, please treat. So I will be talking about what is exactly the relevance of the fluid, diagnosing, time to treatment, treatment interval, and finally the visual outcome. Let's look at the fluid. There are actually three categories of the fluid that we see. The first is this, the fluid which comes under the RPE. And honestly, this is the fluid none of us pays much attention to but we should, because this is where the entire action is in the early part of the disease. Then comes the fluid, which is intraretinal, within the subretinal, and intraretinal, that is within the retina. The question that we need to answer is, all these three categories, are they same or are they different? Now let's look at the intraretinal fluid. Intraretinal fluid is honestly the bad guy of the all, because the moment you see appearance or persistence of intraretinal fluid, it generally means poorer visual outcome. And this is not what I'm saying, it's just the analysis after analysis. If we look at the post hoc analysis of view 1 and 2, presence of intraretinal fluid at baseline and even at a later stage means the visual acuity is going to be not so good. Secondary analysis of CAT study again indicated that if intraretinal fluid persists after injection, it means a poorer visual outcome during anti-VEGF therapy. Post hoc analysis of EXCITE again shows that even if the fluid disappears, but the new cysts appear after the loading dose, again it means the bad news, means poorer visual outcome. Subretinal fluid, on the other hand, is a slightly better guy compared to the intraretinal fluid. And in many studies, actually it was shown that if you have the subretinal fluid at the baseline, and even if some bit of subretinal fluid remains after your treatment, they are actually associated with a good visual outcome. So let's see what the trials say. The VIEW 2 study did the secondary analysis and reported on the baseline subretinal fluid. And this mentioned that the presence of subretinal fluid at the baseline does not really affect either the initial or the final visual acuity following anti-VEGF therapy. Secondary report of the CAT studies mentioned that persistent subretinal fluid did not affect the visual outcome during anti-VEGF treatment. Ancillary study of the EXCITE said that if the SRF also keeps on coming repeatedly, this may actually lead to poorer visual outcome. And the logic was that if you allow the SRF to come again and again, it may lead to formation of intraretinal fluid, which we all know is the bad one. There was a wonderful study, fluid study, to study the tolerance of subretinal fluid. They had two arms. After giving the loading doses, the one arm was intensive group where they kept on drying the subretinal fluid, whereas the other arm was the relaxed group, where after the intraretinal fluid had disappeared, even little bit of subretinal fluid was tolerated and injections were not given, just based on the SRF. Very interestingly, they found no significant difference between the intensive group and the relaxed group for a mean change in the best corrected visual acuity from baseline till 24 months. This is just to show you an example of a patient, and as you can see, the main component is subretinal fluid. The initial loading doses, 3 months, doing fine, no more injection given, and this is 9 months later. The vision is still maintained because the subretinal fluid has gone. The fluid study again said that unresolved SRF, if you let it stay for very long, may lead in time to intraretinal fluid, which means that even subretinal fluid, though it's a good guy, if you let it go on for very long, this again may result in the formation of intraretinal fluid, which in turn would compromise the vision.
Patches in case of lacrimal leprosy or a biopsy and
there's some voice somewhere.
Mr. Seshadri?
Yeah, it's gone.
Can you mute?
The last one is subretinal fluid, the sub-RPE fluid, I'm sorry. Now, this is the fluid. There are not many studies actually who have paid attention to this part of the fluid. And this is where the membrane actually is. If we look at the studies, most of the studies reported that if you have PED at the baseline, it has a very little impact on the visual acuity or visual outcome after anti-VEGF therapy. Secondary analysis of the CAT again showed that sub-RPE fluid does not influence. However, the real-world data from Timothy Lai indicated that PEDs could be associated with poorer visual outcome. And some other real-world studies did indicate that if there is a fluid in the sub-RPE space, it might indicate recurrence of neovascular AMD. Now, I would show you two examples of subretinal fluid. Now, this is the patient sub-RPE. I'm sorry, this is sub-RPE. You can see a PED. The fluid is mainly beneath the RPE. Patient is receiving injections, and you can see the height of RPE going down. And this is what we should be monitoring, because the earliest sign of recurrence of membrane will come beneath the RPE. I'll show you an example if we don't pay attention to this little fluid under the RPE. Now, this is type 1 CNV, and we all know it is type 1. So we look at the baseline. At the baseline had mostly subretinal fluid, which is a good guy, as I mentioned. And then there is the pigment epithelial detachment. So he receives injection, subretinal fluid disappears, he's doing well, but you just see a little bit of streak beneath the RPE. So the patient was lost to follow, but honestly, even if he wasn't lost to follow up, I might have ignored this streak of fluid. And here is this what happens. Now, when he comes back after 14 months, there is not only sub-RPE, there is subretinal, and there is that bad guy intraretinal fluid. Now you keep on injecting and injecting, but the visual outcome is going to be bad because the compartmentalization of the fluid has changed. So I wish in future that if I'm seeing this kind of a streak of sub-RPE, I would be doing more of OCT angios, monitoring them, and probably not ignoring or let them go to develop onto this stage. So the story of fluid continues to evolve, but the moral of the story is any fluid anywhere indicates active disease. I'm not saying you start injecting, but you got to be aware that any compartment means there is some disease activity happening. Resolution of the fluid correlates to the visual benefit. The magnitude may vary depending where the fluid is. And the most stable central foveal thickness is associated with better visual outcome. So it's important to look at the fluid and to treat it at the earliest. Thank you very much.
Thank you very much, Dr. Vishali Gupta. That was an excellent talk. We will discuss all the talks together. So the next talk is by Dr. Rajanarayanan on brolucizumab experience.
Can you see my slides?
Yes.
Yeah. Once again, very good evening to you all. Thank you to Dr. Mallika Goyal and HOA for inviting me to share my experience on brolucizumab. After the wonderful talk by Dr. Vishali Gupta, which set the stage for different compartments of fluid, I'll not go into that aspect in detail, but share a few characteristics of the molecule. But before I these are my disclaimers. I'm talking on behalf of Novartis, and also acknowledgements of Dr. Michael Stewart and Dr. Subhakar Reddy, who was my fellow in sharing some of the thoughts on my slides here today. Brolucizumab is a single chain variable fragment. If you see overall here the antibody, and you see the constant portion of the antibody when it's removed, you are left with the variable chain, the light chain and heavy chain, but when you all put them together, they become a single chain variable fragment. So that's the advantage here, that you can shorten the size of the molecule, and you can see here the differences between the other molecules, aflibercept, ranibizumab, and bevacizumab. Brolucizumab is very small, 26 kilodalton. You can see the other molecular weights over there. What this allows is packing a higher molar dose in one injection. You can compact in one small volume, you can load more of the dose. So 6 milligrams is something which you can load in 50 microliters. And this helps in the longer duration of action of brolucizumab. And this also, the smaller size also helps in deeper penetration of the antibody or the variable fragment. So you can imagine that when the CNVM is in the choroid, the molecule has to penetrate all the layers of the retina, the RPE. It has been shown that in preclinical studies, the penetration of brolucizumab is close to 2 times deeper inside the RPE compared to ranibizumab. And that's why, as Dr. Vishali showed, brolucizumab has a more drying effect, a better drying effect than either ranibizumab or aflibercept. It has not been compared to ranibizumab in the Hawk and Harrier, but in the preclinical studies, it has had a much better drying effect. So even the PEDs, they get flattened out much faster and easier. While we have all had experience in the recent past with the available anti-VEGF, that the PEDs do not flatten easily with most of the anti-VEGF molecules. The other good thing is that it's Q12-week dosing, that is once in 3 months, that you have to inject these patients after the loading dose. And this is a graph from the Hawk and Harrier trials looking at the patient's visual acuity, those who had intraretinal fluid, those who had only subretinal fluid, or those who had PED. As per most of the studies so far, including the fluid study which Dr. Vishali pointed out, SRF can be tolerated a little bit in the macular degeneration patients, but in the Hawk and Harrier trials, the SRF, if you dry the SRF also, those patients actually had slightly better vision compared to those who had retained some amount of SRF. This is as per the VRSI survey, the injection burden. In wet AMD, it's about 5.6 injections that we give in the first year. But when we looked at the recent survey, when we asked our specialists in India whether they would completely dry the subretinal fluid or would they tolerate some amount of subretinal fluid, it was a split down the middle. 50% of the retina specialists actually would tolerate some amount of subretinal fluid. The other half were not sure, or they would go for a complete drying. Going to some of my cases, I have had, because brolucizumab was launched only October, first week, we just have a 1 month follow-up for all my patients so far, which I'm going to present now. This was a gentleman who had treatment-naive macular degeneration, presented in October. The vision in the left eye was 21/25 and was injected brolucizumab. This was the pre-injection. If you see the horizontal scan, you can see a PED, subretinal hyperreflective material, very little intraretinal fluid, but some amount of subretinal fluid. And 1 month after the injection, the vision remains stable, as you would have expected, because there is already some amount of scar, but you can see that there's no fluid now. And the PED has also settled down significantly. This is the pre-injection. Post-injection, PED has come down significantly. That's one important point which I want to highlight, apart from the different longer duration of action. Another patient who had received 3 injections earlier in the left eye, just concentrated on the left eye. He had come in March, but then he was lost to follow-up due to COVID. And that's where, again, longer duration action molecules would be useful now when you don't want patients to crowd the clinic. This patient came in October 21/25 vision, and this was showing a lot of subretinal fluid, PED, intraretinal fluid, and after a month, the vision was still the same, but you can see that the fluid is completely gone. While these are kind of advanced cases of AMD, what we are trying to achieve now with AMD is, fine, I don't want too much of improvement. Yeah, it's good if we get improvement in vision, but at least if we can reduce the number of injections and frequency of visit, that will be a big achievement for our patients. This is another patient who had received in the right eye ranibizumab injection, but the left eye was treatment naive. 2060, you can see subretinal fluid and shrum. And then after a month, it was 21-25, all the fluid has gone away. One concern that we have is about inflammation and vasculitis. One of the patients which I had not given the injection, but the patient was injected elsewhere, did present to us with severe inflammation similar to what you may suspect in endophthalmitis, but she had hypopyon immediately on the day of the injection. Whatever reports are there so far, they mention after the second or third injection, or even the earliest which has been reported is the 14th day. But our patient had on the same day severe inflammation, which I managed along with my colleague Mudit. And this patient resolved again within 5 days. Within 5 days, you could see the entire funda, the fluid had gone on OCT. So it worked in terms of drying the macula, but sometimes inflammation, vasculitis can be a concern. So what next? What should we look up to? Because brolucizumab is there, but a lot of people are cautious. It works very well, but we have to be careful in patients. The port delivery system is something next that we can look up to, where you just inject like a reservoir. The drug can keep on filtering like a coffee filter over the next 6 months. It's a surgical procedure though, but that's something which some of our patients can look up to. It's a surgical procedure though. With that, I would like to thank you for your attention.
Thank you very much, Dr. Raja. I would like to now invite Dr. Lalit Verma, the chairperson of this session, to introduce Dr. Rosenfeld. And then we will have a recorded talk from Dr. Rosenfeld, who will join for the discussion.
Thank you, Malika, for having me here. And it's my proud privilege to introduce a giant personality in the field of retina. And I think all the retinologists know him very, very well. In fact, he is a household name in majority of the countries, primarily for his work on Avastin. Rosenfeld is a professor of ophthalmology at Bascom Palmer University of Miami. His primary interest is in ARMD.
The slideshow, I don't think it is slideshow.
Okay. His major contributions have been in the clinical development of anti-VEGF therapies and use of OCT-guided treatment using anti-VEGF, and the clinical development of a lot of OCT instrumentation. He has been the principal investigator and chairperson of numerous AMD trials, and of note has been his usage of OCT-guided anti-VEGF and Avastin for exudative macular diseases. In fact, he has been the pioneer of Avastin. He first showed Avastin was effective when given, not intravitreally, systemically, and then as an interval injection. And this has led to huge cost saving all across not only US, but all across the globe. And one data had shown that more than 50 billion in US has been saved because of this cheaper molecule Avastin, but very effective. In addition, he has helped develop both spectral domain and swept source OCT, which are being used everywhere nowadays. And more recently, he has been applying OCT angiography to study both the non-exudative as well as the exudative AMD, and developed new OCT clinical trial anatomical endpoints. And in collaboration with Dr. Wang's research team at Seattle, he and his team have successfully imaged non-exudative subclinical neovascularization and choriocapillaries using and the choroid using SS OCT angiography. So I, on behalf of the entire panel here and as well as the HOA, invite, and we are very eager to hear his keynote on the topic of detection, natural history, management of treatment naive, non-exudative macular neovascularization, because this is an entity which is emerging using SSOCT. Thank you, Dr. Rosenfield, for agreeing to be part of this great session, and we look forward to an interesting presentation from your side.
Yeah, Mr. Seshadri, will you play the talk, please? It's not running.
Greetings from Miami. It's a pleasure to be with you virtually today to provide you some insights into the use of swept source OCT angiography for the detection of treatment-naive, non-exudative macular neovascularization in age-related macular degeneration using swept source OCT angiography. I'm presenting to you today on behalf of the Bascom-Palmer OCT research team. My financial disclosures include research support from Carl Zeiss Meditech. I'm also a consultant and chairman of the Advanced Retinal Imaging Network, and there are licensing agreements between the University of Miami and Carl Zeiss Meditech. None of this work would be possible without the outstanding efforts of my clinical research fellows, in particular Jin Yang and Mengxi Shen, and my faculty collaborators, Bill Foyer and Giovanni Gregori. Also, this work would not have been possible without our ongoing collaboration with Ricky Wong's group at the University of Washington, Seattle. They've been crucial in the development of algorithms and hardware for the success of this project, as well as the scientists and engineers at Carl Zeiss Meditech. Here are the important take-home messages. Swept source OCT angiography can detect treatment-naive, non-exudative macular neovascularization long before exudation develops. A characteristic feature of these lesions is a double layer sign, or shallow, irregular retinal pigment epithelial elevation. The risk of exudation over 2 years increases 14-fold in eyes with dry macular degeneration that have these treatment-naive lesions. And so far, we haven't found any obvious anatomic changes, such as the size of the lesions, choriocapillaris flow deficits, or choroidal parameters that predict exudation. So in Western AMD, traditional paradigm shows that there are drusen in the central macula, and these drusen increase in volume. In fact, they undulate and grow over time. Occasionally they go away without any obvious sequelae, but most of the time they go on to exudative AMD or geographic atrophy. And almost all eyes go on to geographic atrophy now with anti-VEGF therapy. So here's a case of a patient that presented back in January of this year, 20/40 vision in both eyes with drusen. And you can see here on the spectral domain OCT, the irregular elevation of the retinal pigment epithelium consistent with drusen. And on the RPE elevation map here, you can see the bumpy appearance of the drusen. Now, when would you see this patient back? Well, in my clinic, a patient with drusen without any evidence of exudative disease would be seen back in about 6 months. Well, this patient came back 4 months later with a massive macular hemorrhage in the right eye, count fingers vision at 1 foot. You can appreciate on the B scan here, the blood under the retina. So could this have been predicted, and could it have been prevented? Well, we've identified a new type of lesion in AMD. We called these lesions in the latest paradigm treatment-naive, non-exudative macular neovascularization, and it can arise in eyes with drusen or in eyes with geographic atrophy, and that's going to be the topic of my lecture today. So we've identified these lesions using swept source OCT angiography, and I've been a strong proponent of the Plex Elite 9000, and it's been my baby since we started developing it in 2013 with Zeiss and University of Washington, Seattle. The algorithm that we use to identify these lesions is known as optical microangiography, which was developed by Ricky Wong's group. We use motion correction software known as Fast Track. In this study, we performed 3x3, 6x6, and 12x12 raster scans. and we identified macular neovascularization using boundary-specific segmentation. Now, back in 2017, we published the segmentation that we've been using on all of our lesions, particularly in this study, and it's called the ORC slab. It goes from the outer retina to the choriocapillaris, and this gives beautiful images of macular neovascularization. But in this early image that you see here in the 3x3 scan, you can appreciate not only the lesion in the center, but also the retinal projection artifacts. We now have retinal projection artifact removal software, as well as software that measures the area of the lesion. So we use all these algorithms in all the eyes that I'm going to be presenting to you today. So using this ORCS lab, we can identify type 1 and type 2 macular neovascularization. We can identify type 3 macular neovascularization, or RAP lesions that are in the outer retina. And we can also identify polypoidal choroidal vasculopathy, both the polyps and the branching vascular network. So these subclinical, treatment-naive, non-exudative neovascular lesions were first identified in the 1970s by Sarks in Australia and Dick Green here in the United States. They found them in autopsy eyes, histopathology specimens, in eyes with dry macular degeneration. And then Ingrid Kreutzig's group and Larry Nuzzi's group in the 1990s used indocyanine green angiography to identify these neovascular lesions in eyes with dry macular degeneration. And they were imaging these patients because they had wet AMD in the fellow eye. So can swept source OCT angiography detect these subclinical lesions as well as ICG angiography? So we published this work back in 2016 where we compared swept source OCT angiography to ICG angiography. And this is just the first case that we identified, which is a beautiful case, dry macular degeneration. You can see here on the B scan, there's no exudation, but there is a double layer sign, a separation of the retinal pigment epithelium from Brooks membrane. On fluorescein angiography, there's no leakage. On ICG angiography, there's this fried egg appearing or donut appearing plaque. And when we blow this area up in a 3x3 image and look at the B scan, you can appreciate a double layer sign, a separation of the RPE and Brooks membrane in the area where the lesion is located. And if we then project OCT angiographic flow as pink in this region, you can see there's flow in this space where there should not be any blood flow. And when we look at the side-by-side comparison of the ICG plaque with the OCT angiographic image, you can see how beautifully the OCT angiographic image depicts the plaque. Here's a second case that we found. This is a patient with dry macular degeneration. We thought these were drusen, but actually the lesions on the side are drusen. The lesion in the center is a double layer sign. You can see the difference in internal reflectivity between the true drusen on the side. So we look on fluorescein, there's no significant leakage. We look on ICG angiography, we can appreciate a plaque. And when we blow up this region of the ICG and we look at the B scan through this region with flow, you can appreciate the pink, where the flow underlying this, what we thought was a druse. This is a double layer sign. And here's the side-by-side comparison of the ICG plaque with the lesion that we can obtain on OCT angiography. So we showed that swept source OCT angiography is as good as ICG angiography. So now we can use swept source OCT angiography to determine the prevalence, the incidence, and natural history of these lesions in eyes with dry macular degeneration. So what we did is we set up a study. In the study, patients had dry AMD in one eye, wet AMD in the fellow eye. It was a prospective study starting in August 2014. We officially followed patients through March 2018. The follow-up was variable due to the need for anti-VEGF therapy in the patient's fellow eye. And the one-year data on 160 patients was published in February 2018. There's a 15-fold increase in exudation if an eye had one of these subclinical lesions compared to an eye without a subclinical lesion. And in 227 eyes, the 2-year experience was a 14-fold increased risk of exudation if non-exudative neovascularization was present in the eye with dry macular degeneration. So overall, the prevalence was 13.2%. And if we looked at eyes with drusen or eyes with geographic atrophy, it didn't matter. It was the same in both populations of eyes. And the most common lesion is what we call a type 1 lesion, or a lesion under the retinal pigment epithelium, as opposed to a type 3 lesion. So here's that first case I showed you. She was followed for 27 months. And although the lesion grew, there was no exudation. The lesion just got bigger. And we continued to follow this patient. I saw this patient back in October. And what you can appreciate, it slowly has gotten larger, but there's no exudation. This is that second case. Patient was followed from 2015. You can see over 20 months, the lesion grew in size. However, there was no exudation. And then for some reason, 2 months later, we did see a little bit of fluid on the B scan, but the patient was asymptomatic and the lesion did grow a little bit in this case. So we continued to follow the patient. A month later, there was a little bit more fluid. The patient was symptomatic, so we decided to treat, and the fluid resolved. The lesion did not grow significantly at this time. And over time, this patient got 6 anti-VEGF injections over 10 months. You can appreciate here that the patient did exceedingly well. The lesion really didn't change in size, and the patient had 20/20 vision. And now we continue to follow this patient. This patient was seen last in September, an additional 30 months of follow-up, 1 anti-VEGF injection over 30 months, 27 months since the last anti-VEGF. And what you can appreciate is the lesion's getting larger and the pigment epithelial detachment is actually getting smaller, but there's no exudation at this time. So growth does not mean there's going to be a lot of exudation. And this is a type 3 lesion that I find fascinating. You can appreciate here that the lesion's in the retina. You can see a little dot on the en face imaging. We followed the patient for another 3 months. The lesion's getting bigger. The dot on en face imaging is getting larger. You can see now there's exudation, but the patient is asymptomatic. But 7 months went by before the patient became symptomatic with exudation. And then we treated with anti-VEGF. And this patient ended up doing exceedingly well, but did require a lot of anti-VEGF therapies, 20/25 vision. And this is what the patient looked like in March. The lesion is gone, but on subretinal pigment epithelial slab en face imaging, you can see what happens to most of these lesions. There's a little bit of atrophy developing. You can see the hypertransmission defect on the B scan. And then an additional 27 months, the patient got more anti-VEGF therapy. And over 29 months, the lesion, the neovascular lesion is gone, but the atrophy is slowly getting bigger. And that's going to continue to grow. And that's the legacy of AMD. No matter what we do, geographic atrophy will form after anti-VEGF therapy. So does the presence of these subclinical lesions increase the overall risk of exudation? You bet. Here's a Kaplan-Meier plot. The y-axis is the need for anti-VEGF therapy. The x-axis is months of follow-up. The upper line are those eyes with subclinical neovascularization. The lower line are those eyes without. You can see at 1 year, there's a 21% risk of exudation if you have one of these lesions compared to 3.6% if you don't. And after 24 months, a 34.5% risk of exudation if you have one of these lesions versus 7% if you don't. Overall, that's about a 14-fold increased risk of exudation if one of these lesions are present. And it doesn't matter if it's intermediate AMD or geographic atrophy. And you know what? My colleague Seung-Young Yu in Seoul, Korea has found the exact same thing in eyes with polypoidal choroidal vasculopathy. She found that if you look at the fellow eyes with dry macular degeneration that have active polypoidal in the fellow eye, they have these subclinical polypoidal lesions that you can identify beautifully using swept source OCT angiography. This is an example of the polyps and the branching vascular network, no exudation here. And here's another case with polyps, branching vascular network. You can appreciate even this little polyp here on the OCT swept source images. So swept source OCT is all you need for polypoidal choroidal vasculopathy. And we have a paper that came out in September in the American Journal of Ophthalmology with Seung-Young Yu and her colleagues showing that swept source OCT angiography is as good as ICG angiography for the detection of polypoidal choroidal vasculopathy. So far, we have not found any association of exudation with the size of the lesion prior to exudation, the growth of the lesion prior to exudation, changes in the pigment epithelial detachment volumes associated with these lesions prior to exudation, and changes in the surrounding choriocapillaris flow deficits or changes in surrounding choroidal vascularity prior to exudation. We are currently investigating other possibilities, maybe changes in the flow velocity within these lesions or flow velocity within the choriocapillaris, changes in the choroidal blood flow perhaps, or maybe there's an immunologic trigger, maybe using a C3 inhibitor known as pegcetacoplan or APL2 can induce exudation from these eyes with the double layer sign of their subclinical lesions. Why do I say that? Well, now I'm going to digress into a new treatment that's in phase 3 clinical trials for geographic atrophy, for dry macular degeneration. It's called pegcetacoplan. It's a cyclic 13 amino acid inhibitor of C3, and there's 2 of them linked by polyethylene glycol linkage, and it prevents C3 cleavage. And just as a reminder, this is the complement pathway, alternative classical and lectin pathway. They all converge on C3 and then go on to create enophalotoxins that are highly inflammogenic, as well as membrane attack complex. Pegcetacoplan blocks at C3, blocks everything downstream, and completely shuts down the complement pathway, total inhibition. So I'm just going to digress here into the phase 2 study known as the Philly study. It's completed, it's published. This looked at 2 doses of APL2, 15 milligrams monthly or 15 milligrams every other month versus sham. And for the sake of the study, we're going to combine the sham groups. The primary endpoint was at 12 months, and then we followed the patients for another 6 months, and the end of the study was at 18 months. So we looked for the growth of geographic atrophy. That was the primary efficacy endpoint, and the primary safety endpoint were adverse events. This work is published in February Ophthalmology, but I'm just going to touch on the outcome. Here we have the sham group. The lesions grew very quickly. When treated, the every other month group slowed it down a little bit. The every month group slowed it down by 29%, highly statistically significant. Convincing slowing of growth of geographic atrophy. But we had some adverse events. There was a dose-dependent increase in exudation. Here we have overall, there was about 11% risk of exudation, but APL2 given monthly had a 21% risk of exudation, a 9% risk if given every other month, and in the sham group, there was only a 1% risk of exudation. What was going on? So I proposed to Apellis that we look at baseline images. I bet, I told them, that in the baseline images, we were going to see double layer signs, which you can see on structural OCT. And it was those eyes with double layer sign that were more likely to develop exudation. And that's what we found. Highly statistically significant difference between those eyes with double layer sign versus those eyes that didn't have a double layer sign, and those eyes that developed exudation, and those eyes that didn't. So now we're moving forward with a phase 3 study. It's fully enrolled. We're going to get the results in about 18 months. And once again, it's 15 milligrams APL2 monthly versus 15 milligrams every other month. But now we're prepared. We're going to be watching for the onset of exudation, particularly in eyes with double layer sign, which are included. They're not excluded because that's part of AMD, but we're actively monitoring those eyes for the risk of exudation. Now back to our patient. Here we have that patient with a massive hemorrhage in the right eye, count fingers vision. Could this have been predicted? Yes, it could have been predicted. Here's the thickness map from the swept source OCT angiographic image from January. Here's the structure map showing the drusen. Here we have the angiographic flow map showing not 1, not 2, but 3 independent neovascular non-exudative complexes. And you can see with the B-scan the double layer sign through this lesion. So we knew this patient was at risk for exudation. So we scheduled her to come back in March. She canceled because she was afraid of COVID-19. We then rescheduled her for April, but she canceled because she was afraid of COVID-19. And then she appeared in the emergency room in May with sudden loss of vision and exudation. I call this patient a COVID-19 casualty. And could this have been prevented if we had seen her sooner? You bet. Or what we're working on, home OCT monitoring, so we can get these patients in as soon as possible. So in summary, swept source OCT angiography can detect treatment-naive, non-exudative macular neovascularization long before exudation develops. A double layer sign or shallow irregular retinal pigment epithelial elevation is a characteristic feature of these lesions. You look for them on structural OCT, you'll see them. The risk of exudation over 2 years increases 14-fold in eyes with dry macular degeneration that have these treatment-naive lesions. And so far, the only trigger that we've been able to identify is C3 inhibition with pegcetacoplan or APL2. No obvious anatomic changes precede the onset of exudation. So I thank you for your attention, and I will be logging on so I can answer your question. Thank you.
Thank you, Dr. Renfield, for a wonderful talk and making us aware of this entity, which a lot of people do not pay attention to. You see, all of us do see this double layer sign, but this COVID-19 casualty patient you showed was really an eye-opener. So, Malika, can we have the panel discussion now?
Yes, sir. Yes, sir. Exactly. We can start it now.
So has Rosenfield joined in, or?
He will be joining in another 10 minutes, I think. So we can start with the first two talks at least.
Okay. Can we have the gallery view now? Yeah. So,
Mudit and Satish, can you please come online? We can see your videos. Can you unmute yourself?
So we have a excellent panel besides Vaishali and Raja. Who
Sorry.
Presentations. We have with us Dr. Pramod Bhande, Dr. Satish, Dr. Raja Reddy, Mudit, besides Vaishali. And so let's start this discussion. Honestly, Vaishali, once you started, all of us can unmute. And because we are a total of 5-6 people only.
Mudit, where are you? Okay.
I am here only, ma'am. I am just logging in through another device because this is not somehow allowing my video. So I'll just log in through another device. Just 1 minute and I'll be there. I'm already here.
Okay.
Yeah. Once you differentiated between the good guy and the bad guy, Vaishali, you see, although for me, honestly speaking, all fluids are bad.
All are bad.
Yeah. So even though, there may be people who may say that SRF is not so bad, like you showed very nicely that sometimes SRF, you showed that last example where long-standing SRF could lead to IRF also. So if you can't take care of SRF, then you start saying that SRF, this is not affecting the visual acuity. But to my clinical thing, I would like to treat all fluid. So this fluid story is artificially cooked up by these companies and all drugs which do not work. You showed, CAT study, VIEW study, as well as other studies. But for me, all fluids are bad. I try to eliminate all fluid. In case not, then I may, give up or put the patient on a closer follow-up. So I would like to start with Vaishali has already spoken about the views of Pramod Bhande first, and then Satish and Raja Reddy. Pramod.
Probably what we can say is anything excess is bad. Too dry or too wet, I think probably either way you can put it. But as I agree with you, like all of us probably will comfortable to see the dry macula.
Yeah.
That's, what I feel personally.
So no, the thing is, suppose a patient presents, because first patient of Vaishali was welcome, Phil Rosenfield. How are you?
Hi, greetings.
Good morning to you.
Good evening.
There must be early morning there. Yeah.
8:30 a.m.
Yeah. So we just started first question only. Maybe, we'll have quick questions on fluid story, as well as some questions on the new drug, that is brolucimab, because Dr. Raja presented, and then we'll come to your talk immediately after that. So Dr. Vishali had presented about the fluid story. So I just started one question to the panel, that for me, honestly speaking, all fluids are bad. If I can't get rid of it, then I start, comparing which is worse and which is better. So Vishali had presented that SRF is a good guy and IRF is a bad guy.
No, not too good a guy, but the
No.
visual acuity.
Yeah. My question to Pramod was that, you see, do you try to eliminate all fluid, or maybe if IRF is gone, SRF is still there, you will not try?
Well, I give a try, probably to dry it fully, probably again give it for 3 or 4 injections. And if I feel this is still holding on, there is no change, and rather I'll be more worried about fluctuating fluid and it's stationary, maybe after, I won't wait for 6 injection or 7 injection and subsequent follow-up is just holding on. I give a chance, wait for, but I'll have a close follow-up and probably wait some more time without giving further injections.
Dr. Satish?
Yeah, I mean, ideally speaking, I think drying of the entire macula is what we aim at. But in spite of our repeated attempts of giving multiple injections, if we still have a minimal of subretinal fluid which is left behind, I wouldn't mind leaving it for and watching these patients every couple of months, and that is what I would do.
So
I would try around about.
Here comes the key, this thing, that it's a stable fluid, not increasing and not waxing and waning. Maybe then you can give it a try.
Yeah, we would like to watch that, and then again, once if it is showing signs of increasing, probably we'll go back again and injecting.
Or will you convert now that you see Raja's talk also was there about the new kid on the block, that is the brolucimab, and a lot of pressure is there, to push this drug for drying effect or increasing duration, as he cited 2 examples there. So would you try brolucimab? Suppose SRF is there, would you try this new kid on the block?
Yeah, the new kid on the block definitely has got very promising results as far as drying up of the retina is concerned. But the only point of concern to me, whenever I go back to all the literature, whatever has come out through this particular drug, is the inflammation part.
Yeah.
Which is what that especially the vasculitis component, that the retinal vasculitis more onto the arterial side is what is the matter of concern. In fact, Raja was also presenting to us one of the cases, and fortunately for him, it has recovered. But the literature says that a lot of patients have not recovered.
We'll come to Raja's, that one patient where, the patient developed hypopyon, that's okay. Phil, our question was that there is a patient who had IRF as well as SRF. We did try multiple anti-VEGF injections. IRF gone, SRF is now stable. Do you advise to shift to brolucimab or watch the patient periodically?
So when I see a patient that has fluid after repeated injections, it doesn't bother me. I know the drug is working. People don't think the drug is working, but you can test that by giving the drug and seeing the patient back 1 to 2 weeks later. If the fluid disappears, then you know the drug is working, because that's when you have maximum effect of the drug. If the fluid doesn't disappear 1 to 2 weeks later, then it's not VEGF-mediated fluid. So I think it's always fine to treat if there's a little bit of fluid, but I'll never watch a patient with a little bit of fluid unless I give them that challenge where I give them the injection, see them back 1 to 2 weeks later, or extend the interval and see if more fluid reaccumulates. But the way I interpret fluid is, in a normal patient that's responding to VEGF, I interpret fluid as a good sign, a little bit of fluid, because what it's telling me is you still have healthy tissue there that's generating VEGF, that's causing the fluid to appear. Because we know once you go to atrophy, there's no fluid.
Yeah.
So atrophic maculas don't generate fluid, and it's the normal tissue that's producing the VEGF. So that's just telling you that there's good visual potential. So Unlike other people that think subretinal fluid is beneficial, subretinal fluid isn't beneficial. It just indicates that there's healthy tissue there responding and generating VEGF. That's how I interpret it. And I don't switch drugs unless it worsens.
So one of your slide, Phil, had shown that majority of the patients of AMD ultimately land up in atrophy.
Yes, I totally agree.
Yeah,
That's
yeah. So do we
published a paper.
Do we want the minimal fluid to be there or not?
So after the original Lucentis trial, Marina and Anchor, we went back and looked back in 2008, 2009, why patients lost vision. And even then, it was apparent that patients were losing vision from atrophy. They weren't losing vision from hemorrhage and fibrosis. And we published this paper in 2011. And since then, paper after paper has shown that atrophy is the problem. Okay, it's not under treatment, it's atrophy that's the problem. So this is why I switched my research focus totally to dry macular degeneration and atrophy, because to me, that's the future. If we can prevent atrophy, then we'll never have neovascular AMD to begin with. It's all about dry macular degeneration, disease progression, stopping atrophy.
So your take on this, Raja?
No, I agree about the fluid aspect in the sense what Dr. Rosenfeld mentioned about if there is fluid, then there is some active tissue underneath. That's a very important point he has made. And while I'm happy to see the fluid after a period of stabilization, I'm not concerned with the minimum amount of subretinal fluid if the vision is stable and there is no intraretinal fluid. So if there is some amount of fluid after a period of stabilization, I may just watch the patient, and that's what the fluid study of an intensive treat and extend versus a relaxed treat and extend was showing. But overall, even the VRSI survey, which I showed you as one of my slides, 50% of our retina specialists actually are tolerating fluid. Although the question was a very simple question, we didn't ask at what point of time and all those things, but there are people who are now tolerating some amount of subretinal fluid.
So all of us agree with one point that we have very low threshold for IRF, but if the patient after IRF has gone, there is some amount of SRF, we do try to get rid, but with a stable visual acuity, we can monitor these patients. Is that okay, or anybody want to change this?
Yeah, this is fine, but I would like to say that the fluid study and the others, when they say that the vision was not affected because of fluid, it's because they have just 2 years of data to say that. So we don't know whether the persistence of fluid over a longer period of time in itself damages the photoreceptors and alters the visual outcome. We don't know. So we cannot say that it is protective to the vision. And our target should be to eliminate it.
Yeah, that is. So once Raja, you says we will monitor, or Phil, once you say we'll call this patient a follow-up, then how frequently you call him for follow-up?
So let me just add, I would never watch a patient that I'm actively treating with fluid because I think the treatment is working, but a little bit of fluid doesn't mean that the treatment has failed. All right. So I would continue to treat. Maybe I would extend the interval, but I would always treat a patient with fluid.
So
that's my strategy.
So Pramod, so you also adopt the same policy that even if there is a fluid, suppose vision is stable, instead of stopping the treatment, you extend it, and the way we do every 2 weeks, then after 4 weeks, so that we know presence of fluid, like Phil said, means there is VEGF there. But
probably yes, but
visual may not be there. That's all.
Yes, what I would prefer maybe, extend the follow-up. But if patient is still stable, I will not just say go ahead, treat and extend, but I will follow. If there is a change, probably again I'll take a call accordingly.
Let me ask Mudit, your view on this, whether you want to just follow up or you want to treat and extend. Unmute. You can unmute yourself.
I apologize. Yeah. So like I said, thanks for the great discussion. And like what you had said, sir, in these cases, I would probably prefer to treat and extend instead of just following. It will also depend on other clinical factors. How much is the
You
visual?
are doing this now only, or you have been doing in your patient? After
I have been doing it in my patients. I also trying to follow them along with what's the visual acuity. If the vision is probably worsening, that then again becomes an indicator for me to re-inject. But otherwise, also in the presence of fluid, I do prefer to treat and extend.
Rajarami?
Yeah, I think the thing is we'll educate the patients regarding the evidence, and evidence shows that you treat and extend, and most of the time patient decides whether they would like to get injected or
A
not.
patient will go by whatever you counsel him.
Yeah, our counsel would be to say extend the interval that you would require injections. Yeah, treat and extend.
Do we then agree with this philosophy of Phil, that patients who have, even if there is a stable SRF with the stable vision, we can increase the interval of injections?
That's right.
Any other comment from anybody on this point?
No, related.
No, I don't know if, sorry. Go ahead, Dr. Malika.
No, I'm coming to a different point, so you can go ahead.
No, sir, my point of related to the brolucizumab, I don't know if Dr. Rosenfeld or anybody else has any thoughts on treat and extend with brolucizumab when the actual dosing itself is Q12 weeks. Would you ever think of a treat and extend with brolucizumab?
Because the experience with brolucizumab in treat and extend is not very great. You see, I think we have just started, especially in India, we just started, using very few centers have started.
So we don't have data. So what are the thoughts? Would you even ever try, or what are, what would be the challenges of treat and extend with brolucizumab, if you ever think about it?
Yes, Phil.
Well, I love the saying, you never get a second chance to make a first impression. And back in the spring, I transitioned a number of my patients on Eylea to Beovu, brolucizumab. And these are patients that needed injections every 4 to 6 weeks, but we're doing well, a little bit of fluid, but we're doing well with good vision. And when I got my cases of inflammation, in which their vision dramatically declined, fortunately, I had 3 cases, fortunately, they all recovered, okay? But I personally will never use brolucizumab again. I don't think there's any justification for putting patients at risk. And I have a colleague, Tom Albini, who sat on the review committee for ASRS and Novartis, and they still don't understand what's going on. So it's not like they're going to come out with an improved form of Beovu that they're convinced isn't going to cause inflammation. So I personally, and I wrote that commentary with David Browning, and there's a response coming out in the American Journal of Ophthalmology, I really do acquaint it to the 737 MAX. I think we need to ground this drug until we figure out what's causing the inflammation. And the effects of the Beovu on the patients that I saw, and it doesn't happen with the first injection. It happened like after the third injection. And I just didn't see the benefit worth the risk. Maybe I got an extra week or 2 out of the drug. So that's my impression.
Does it mean immunogenicity has some role to play because it doesn't happen with the first injection?
That's the thought, that because it's a single chain molecule, that it's not as stable as we have with Eylea and Avastin and Lucentis, and it's uncovering some epitopes that may cause sensitization and inflammation. That's one theory, but there are a number of different possibilities.
Honestly, here you see a couple of months back only brolucizumab was launched in this part of the world, in India, and this fear is so much that it's very difficult to shift a patient who's doing well on other anti-VEGF, ask him to shift on brolucizumab primarily because the drying effect is more, or the Q12 dosing is there. So there have been some people whom, yes, Malika.
A related point to this is that if you were to use it, the indication should only be that you need to dry the lesion and not because you want to extend the treatment interval, because that's not a good enough reason. So even if you did use, what proportion or which of your 3 patients presented with pain versus painless loss of vision, quiet white eye? Because I understand about 70% of them present only with floaters and blurred vision, no pain, no redness.
you know, we have a lot of experience with this sterile inflammation because going back to Lucentis, you know, the early phase 1, phase 2 trial used a lyophilized form of ranibizumab, and we had terrible inflammation. And fortunately, Genentech cleaned up the drug. That was a contaminant because it's made in bacteria, by the way, just like BioView. And it could be some bacterial contaminant, some exotoxin, but they cleaned up the drug and the inflammation went away. That's why we currently use Lucentis at 0.5 milligrams, because when we went higher, we got terrible inflammation. But when they cleaned it up, as you know from the Harbor trial, you can go up to 2 milligrams Lucentis without inflammation. And we've had episodes of Eylea inflammation, but you know, the inflammation occurred years, 5, 6 years after we had experience with Eylea. So we had confidence that there was Eylea that existed that didn't have inflammation. But with BioView causing this inflammation, again, sterile inflammation, wide eye, lots of floaters, vision loss, okay? And you get the Decimate folds in the cornea too with that talcum powder-like hypopyon, no fibrin. So it's a characteristic feature of sterile inflammation. But I don't have any track record of good BioView use without inflammation. I have no reason to trust the drug at this point.
Raja, patient number two of yours, where you shifted that patient. He was not a treatment naive patient, and after multiple anti-VEGF injection, but you said vision did not improve. But is the patient happy with the reduced dosing?
No, so this was the first visit after the injection. Even if the patient is happy or not, I'm happy when I can see that the retina is drying or there is a response to an anti-VEGF. But then later on, what happened was the infection, the inflammation patient presented to us. So these were patients whom we had injected before we encountered the inflammation patient. So Mudit also co-managed that patient. That patient also had Decimate folds and had a hypopyon, which went away completely. Within 5 days, it looked as if this patient never had an inflammation.
How were those 5 days spent? Because this was, I think, within 2 or 3 injections of yours, this occurred, and this created a furor. And in fact, all of us started thinking whether shall we give or shall we not. Mudit, you co-managed, yeah.
Fortunately or unfortunately, I mean, one thing which we were confident of is that the inflammation would go away, but we were not sure what's going on inside, whether there's vasculitis or not. But I think the patient, she is the family member of a retina specialist. So the retina specialist who gave the injection probably had a tough time. But I think overall, I would say that this patient, what was different was this inflammation happened on the same day of the injection, within a few hours. It's not the second or third injection. It's not 2 weeks later. It happened on the same day. And the next day when they presented she had hypopyon and DM folds. So that was something very, very unusual in this patient. But again,
you gave steroids to this patient?
We did, but the inflammation still persisted. We gave for about 6 to 8 hours, very frequent dosing, 1 hourly. But then it didn't, and that's why we had to take her up for surgery. We gave intravitreal antibiotics as a precaution, but there was no growth in culture. The PCR was negative, and it just vanished in the next 3 days. The inflammation vanished. So that was the pointers towards inflammation.
I would like to comment.
Yeah.
Inflammation per se does not bother me. Hypopyon or some inflammation or fibrin, you feel very good about it. And even if there is endophthalmitis, it doesn't really kill you because you can take 2 hours. The problem is with the occlusive vasculitis of bacterial variety, where you're just helpless. You don't even know. I mean, you can't do anything about me.
That is scary, actually, very scary.
And I would ask myself, is drying the macula so important to me to put my patient to that risk of causing arterial occlusion? And honestly, I'm scared. I don't have the answer to that.
So have you started brolucizumab, Vaishali?
In trial, yes, but after the Macular Society, they presented the reports of the patients. No, I mean, I haven't given. Because I would discuss it with my patients, and I have discussed all odds with every patient, including the risk of occlusion. And when you talk to the patient, believe me, nobody wants to take that risk. I mean, I won't do it for my father also. I will not take that risk.
Pramod?
Yeah, I agree with Dr. Vishali. Actually, again, we don't have hands-on experience as of today, but we had an internal discussion in our department. We formed our policy, identified that what are the proper potential cases where we can use this. Obviously, not a treatment name. We have put a vision criteria, everything, but till now we could not fit any patient in that criteria. So though we have brolucizumab available with us, we have not injected in a single patient yet. And as you rightly mentioned, there are a lot of pressure from company.
Yeah.
We are holding on, trying to resist that way. But we
I'll
put
tell
our
you,
strict guidelines.
one of my patient, this lady, she has her son is a doctor in US. She got 2 vials of brolucizumab immediately after FDA approved in October. So, but still they are lying in a refrigerator. And she also brought that report of 44 cases of occlusive vasculitis. So she asked me, because she is doing pretty well on aflibercept, and that aflibercept also we are giving, treat and extend. Now it has reached 10 weeks. So she keeps asking me, when you keep them in refrigerator, that's the best place.
Probably bottom line, I feel our patient is stable with existing treatment. I think I do not want to change it.
Yes, yes.
It's a great drug, but as Phil said, maybe after a little bit of cleaning and playing around, we'll be more confident.
If you do inject it, I guess you need to monitor the patient every 2 weeks for inflammation because they may report late. So if
you also have to make sure there is no pre-existing inflammation.
Yeah.
And ideally that should be done on laser flare metry. I mean, a retina surgeon cannot look in the eye and say there is no pre-existing inflammation. Now that's a big rider to me,
Also, what Malika said, see, it's practically being ours as a referral center, practically impossible to follow this patient every 2 weeks.
And
That's a practical difficulty.
12 weeks. The basic aim is that you call the patients after 3 months.
Yeah.
Yeah, I agree. Exactly.
The purpose for which brolucizumab, is being promoted is extend to 3 months. So if that is not served, Malika, then calling every 2 weeks, patient will be on your head.
So as I mentioned, the indication can only be a non-drying macula. It's not to extend the duration interval. That cannot be the indication.
Absolutely.
Okay, any comment by Rajarami or Mudit on this, Satish? Otherwise,
Yeah,
we'll move to Phil's talk here.
Yeah, so the same point. I mean, the most surprising thing was for the patient which we had encountered was the fact that the inflammation came within a few hours. And like Dr. RN had pointed out, this patient was a relative of a retina specialist. So she started monitoring the patient just few hours after the injection and started her on intense topical steroids immediately. And yet, in spite of it, the inflammation did not resolve. We had to go inside the eye. There was at the time of presentation a dense vitritis, and though subsequently the fluid resolved, but I think I will be again very apprehensive in probably subjecting my patient to that risk of such an intense inflammation. And contrary to our belief that this would have happened after second or third injection, we now in this patient saw immediately within a few hours of the injection, the inflammation occurring.
Yeah, Mudit, I believe this case, I think a culture report was negative.
Yeah.
But is there any reason to believe, because the way history, everything goes more like I will go in a favor of infective etiology than actually toxic etiology?
So, sir, I did the surgery for this patient. I did the tap and I went ahead and cleared the exudates at that point of time. What we saw in this patient was initially a hypopion, corneal edema, folds, but there was not a significant lid edema again. And then when I went inside the eye, I did not find any exudates or anything, only vitritis and vitreous inflammation. We washed it off. And just 5 days later, we have a documented fundus photograph. There is hardly any sign of infection. It predominantly looked just like an inflammatory response.
So culture negativity does not rule out infection in any case.
It doesn't, true.
Okay.
But the picture of the retina at the time of the surgery was absolutely like a non-infection. I mean, there was no other exudates per se, just intense vitritis.
You
So
could
could
subject to
it be
PCR also?
it could have responded to systemic corticosteroids?
We did not give systemic corticosteroids. We gave this patient topical steroids at that point of time. Initially, it could have possibly, yes, but we thought to err on the side of caution. We went ahead and did this. I mean, it
But
could possibly have been
you gave antibiotics, no? Intravenous antibiotics.
Yeah, we did. But
Is it a vitrectomized eye, Dr. Mudit? Somebody was telling us a vitrectomized eye. Did the patient undergo vitrectomy previously?
Yes.
Okay.
So this was
the PCR were done?
Yeah, we did send it for PCR, true. Yes.
Anything PCR, you get it on PCR?
No, the PCR has also not revealed anything. We sent it for a bacterial PCR also, and we also sent it for a microbiology. The culture and smear, everything was negative.
Okay.
I just want to add, that's a beautiful photo. That's exactly what you see. The decimate folds, the talcum powder, it's beautiful.
That is the real picture actually.
And this was on the 5th day, the fundus photograph. This is not pre-op, or the previous. Within 4 days, it just vanished. So, and this was the OCT is post brolucizumab injection 5 days. This was pre-injection on the top, and below is 5 days after the injection. So it worked for what it was supposed to, but unfortunately, it also had substantial side effects.
Okay, I think we have had a lot of discussion on fluid compartments, newer drug brolucizumab. Phil, we enjoyed your talk, great talk, and also the importance of showing the importance of SSOCTA to pick up this double layer sign and prognosticating that some of these patients, like you said, 13 to 14-fold increased chance of developing. So my question as a clinical practitioner was, as how, if suppose we identify this double layer sign in these patients, how and when should I treat?
Right. So while swept source OCT is a great technique for identifying these lesions, once you start looking for these, you can see them on structural OCT very nicely. So any spectral domain will reveal this double layer sign, and you can, with experience, get high sensitivity in identifying. So people think that if these lesions are growing, that's a bad sign. But what we've come to appreciate is lesions growing like this may be actually a good sign. It's the body's attempt to recapitulate the choriocapillaris under the RPE. They're growing for a reason. And it's been postulated for years. And Christine Curcio and Bailey Freund have a beautiful paper that came out in Ophthalmology this past year, showing histopathologically that where that subclinical lesion was located in this eye, you had perfectly preserved RPE and photoreceptors, but wherever the lesion wasn't located, you had atrophy. So you're losing choriocapillaris, and as Jerry Luddy has shown histopathologically, you have these buds of neovascularization popping up all over the back of the eye. We just don't see them. And some of them continue to grow and they form these subclinical lesions. And then something causes those lesions to develop exudation. And that's what we're trying to figure out. This is an area of active investigation. We were just having our research meeting on Friday, continuing to try to figure out what is the trigger for causing the exudation. And I think Vishali is going to appreciate it all comes down to inflammation. It's all about low-grade inflammation in the back of the eye. That's what we're beginning to think, because C3 inhibition triggers the onset of exudation from these lesions. So we think it has something to do with the microglial cells, macrophages, switching back and forth, pro-phagocytic, pro-angiogenic. But as I tell my colleagues, exudation, as we were just talking, exudation doesn't scare us anymore. If you want to scare a retina specialist, give them a big area of atrophy, right? There's nothing we can do about that. So little exudation, no problem, we treat, but don't treat the subclinical lesions. There are two studies, the PROCON study and the PREVENT study, that were run in the United States, where they took patients with wet AMD in one eye and high-risk dry AMD in the fellow eye. And they treated in one study, every 3 months, they randomized to Eylea versus sham. And in the other study was every 3 months Lucentis versus sham. And the idea was to prevent exudation. And guess what? Every 3 months, Eylea had no effect, right? So it didn't prevent exudation. So whatever the trigger is, it's occurring over a short interval of time. And right now we haven't figured it out other than because of the Apellis study, the C3 inhibition.
So moral of the story is don't treat just, only if they become symptomatic, or like you showed that patient who had a big blotch of hemorrhage, then only this is an indication for treatment.
Oh, no, don't wait until the hemorrhage.
The
only reason she developed the hemorrhage was because of COVID-19. But we really do need home OCT monitoring. And it's going to happen, it's going to be a cost issue, of course. But I think for high-risk patients, being able to monitor them at home is going to be a great advance forward.
Probably,
Vishal.
Even if everybody can't have it at home, you can have Uberization of the current OCT equipment.
Right. So I've been jealous of my colleagues that can do virtual healthcare visits, and just meet on Zoom with their patients. So if we had some way to get an OCT in our patients, maybe we have the big drugstore chain, CVS and Walgreens. Maybe at every Walgreens, you put an OCT and patients can go in every week and get scanned, right? Yeah.
I like that term, Uberization of OCT.
Excellent.
Yeah. And the other point was about this, you see, did it ever occur to you, because you say we do not know the trigger factor, they are just growing, that inflammation could have a role, and did you ever think that you could combine steroids? Because Raja has been working on this also. Raja, are you there?
No, he's left.
He has left.
Okay. Yeah.
So he's working on what? I missed that.
You combining steroids with anti-VEGF in AMD. I remember a long time back, Augustine used to, do this triple therapy and in such cases. Yeah.
Photodynamic therapies.
Triple therapy. I remember that.
Maybe steroids may be beneficial, but
had a patient,
then you have other risks, right?
I had a patient where for PCV, where the RP detachment was not responding to aflibercept, and one injection of dexamethasone implant just settled the detachment.
So if I may just add, we have had some pretty good experience. I have seen some of the patients of Dr. Raja Narayanan, where he has treated PCV specifically with anti-VEGF and steroids, and they have some very good results with those patients. Yeah.
So what have been the indications, like when and how?
So most of his cases have been recalcitrant patients. The fluid has not gone away. And those are the ones where he has gone ahead and injected along with an anti-VEGF dexamethasone implant. And those patients are doing pretty well.
The other second part of your talk was regarding this newer molecule which you have been trying, complement pathway, which is pegcetacoplan. Honestly speaking, we just took some pictures from your slides. That's it. But honestly speaking, we do not have much know-how about this drug. And you pointed out this Philly study, phase 2, showing promise. Could you please brief us the practical points out of this?
Sure. So there was a history where complement inhibition was not working in AMD. I did a study with the C5 inhibitor systemically, it didn't work. And Genentech obviously tried the factor D inhibitor. But the C3 inhibitor, and there's a drug from Iveric called Zimura, and their data was just released, their 18-month data, and their data is positive too. So it seems as though inhibiting the complement cascade can slow the growth of geographic atrophy, which is interesting because genetically, there's no evidence that complement plays a role in the growth of geographic atrophy. There's overwhelming evidence that complement plays a role in the intermediate stage of AMD, in the growth of drusen. So now we want to take these complement inhibitors and start using them earlier in AMD. So maybe the hope is to prevent any exudation. if we can just slow down the whole disease process. So it looks, the phase 3 for the Apellis drug, pegcetacoplan, is underway. It's fully enrolled. The Iveric drug is enrolling now for their phase 3. And a few years back, there weren't many other options, but now there are at least 4 other companies in the United States that are pursuing complement inhibitors. So moving forward, I think this is going to be a big area for the retina specialists. And for those of you interested in inflammatory disease, think about where you'd like to use a complement inhibitor and what particular diseases.
Vishali is listening, I think.
Yeah, we are all looking for the precision medicine and treating the exact interleukin and exact complement. Looking forward to your research, Phil. It will help us.
Any other comment by any of the other panelists, Mallika, Pramod, Satish?
We have to wind up the session because there's an oration after this.
Yeah.
So thank you very much, Mallika, and thank you all. I mean, it's wonderful to see you all.
Thank you, Vishali and Raja, for great talks. And Philip, we are honored by your presence here.
Good to join you. Great discussion. Thank you.
Thank you so much. Thank you.
Thank you.
Thank you.
Mallika, for the opportunity.
Thank you. Thank you, everyone.
Bye-bye. Stay safe.
Bye, everyone. Thank you so much. And just a small word of thanks to Professor Rosenfeld for such a brilliant talk.
Yeah.
And to
Thank
our
you.
speakers, Dr. Vishali and Dr. Narayanan, for another talk. And to all of my co-panelists, Dr. Binde, Dr. Lalit Verma, sir, Dr. Satish Agram, Dr. Mallika Goyal, for all those insightful comments which we got, Dr. Rajarami Reddy, the insights which we got from the panel. So thanks once again to all of you for such wonderful talks and for your pearls of wisdom. And our thanks to Hyderabad Ophthalmic Society for giving us this opportunity to talk together, come together for this discussion. And lastly, a small word of thanks for Novartis for their help in organizing this meeting. Thanks once again, everyone. Thanks for your evening and thanks for such brilliant.
Thank you very much. Thank you.
Stay safe.
Stay safe. Yeah.
Yes, yes, yes.
Very important. Very important.
Yeah.
Bye-bye.
Bye.
Bye.
Thanks, Mudit. Thanks a lot.
Yeah, thank you so much, ma'am. Yeah, thanks, ma'am. Yeah, bye, ma'am.
Adri?
Yes, doctor.
Yeah, see, none of these people will go to the hall A because
Yeah.
all retina people,
Yeah.
they will not be interested. That's why I did not speak up.
Sure. Take it.
They will get confused actually. So.
Okay.
But I thought we were going to have oration in both halls.
That is for delegates, ma'am, because we can transfer only for the delegates.
Okay. Right. Then I'm leaving from here and I'm going to hall A now.
Okay, doctor.
Should I relay?
Thanks a lot. It was flawless.
Yes,
Excellent.
doctor. Thank you. Yeah, you can relate, Anup, to hall B.
Yeah.
It was so expensive then, each slide.
It was ridiculous. In order to share lectures, we had to share slides, and to make each slide would cost $1 or $2, and you'd have 100 slides, and you have to pass them out to other people. Thank goodness those days are gone. But now we're only two-dimensional. Someday we'll be three-dimensional. You see, we'll just beam the whole person there. It can happen.
So the reason we're getting delayed is the other hall is not finished yet. We're just
we have finished. Rishi, we have finished.
for them to wind up so that.
No, Rishi, we have finished.
So you have two halls going?
Yes, we have two simultaneous halls.
No, right. Rishi, we have finished.
And one hall
Yes,
is.
Rishi, we have finished.
What are the topics in the other halls?
Pediatric ophthalmology, neuro-ophthalmology, oculoplasty, the entire gamut. Right now, there's retina running at this point.
Oh my gosh. That's a huge meeting to be putting on virtually. I can't believe you've done it.
It was an 8-hour meeting. We started at 12 p.m.
Gosh. Amazing. And do you have a whole team of technical people working on it?
Yes, we have the event organizers, the same people who organize Keracon. They're the event organizers. Great. Are we live?
Yes. Everybody, it was a wonderful day-long conference for the first time in the virtual platform. And we were very lucky to have more than 750 delegate strength with so many multiple, very, very interesting sessions. Just to give you a brief background, Hyderabad Ophthalmologists Association was started by a group of very eminent ophthalmologists from Hyderabad, of which Dr. Narendra Swarup is also one of them. And it was started way back in 1996 with the main idea that along with science, we should have some social camaraderie so that one doesn't grab over the other. And over the period, it has grown into a very strong scientific body. And we have a wonderful team which works very, very cohesively, and each considers that it is the entire conference is his duty and works towards it. So over the last couple of years, we have been having quarterly meetings on different scientific topics. And after a few years, we started the concept of having an annual meeting. Once in 2 years, we have a mega event. And this year, we were supposed to have a mega VISTA, but because of the COVID situation, we had to go virtual, and we hopefully have all of you along back with us next year when we hopefully can conduct a physical conference. I welcome all of you here, and especially Professor Mark Terry, who's going to deliver the Narendra Swarup HOA oration today for the year 2020. As all of you know, Dr. Narendra Swarup was one of the senior most ophthalmologists in our state. I had the opportunity to meet him a couple of times, especially in the radio station way back in 1987-88. He has initiated this Hyderabad Ophthalmology Club, which is today known as the HOA. The present existence came only in 1996. He was a great surgeon, an avid scientist, and also a very, very extremely respected teacher. With these few words, I would like all of us to just stand by for the lighting of the lamp, and then Dr. Rishi would introduce Professor Mark Terry to all of you. Vinay?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. This is the first time I've done a virtual lighting of the lamp, but it's actually pretty nice. All right. So without further ado, I'll go ahead and introduce our guest for today. Just going to try and share the screen. I hope my slides are visible.
Yes.
Professor Dr. Mark Terry is the director of the corneal services at Devers Eye Institute at Portland, Oregon since 1990. He's also a professor of clinical ophthalmology at Oregon Health Sciences University. He had his undergraduate degree at Yale University, medical degree at St. Louis University, completed residency in ophthalmology in San Francisco, and following which he had a Cornell Fellowship in 1985 at the University of Oklahoma under the mentorship of J. James Rossi. He is a profound academician with a vast career in cornea. He's lectured extensively all over the world in over 25 countries, and several of them he's gone several times as an invited speaker. My first memory of Dr. Terry was during my fellowship when he came to one of these lectures to Shankar Nitrale. I was a fellow and I was given the honor of tailing him and helping him with his conference-related work. And it was a great learning opportunity. First time he taught us DLEC at that time. He has a lot of research published in areas of corneal transplantation, corneal physiology, refractive surgery, dry eye, and endophthalmitis. In 2000, after a year of laboratory development, he began the first US clinical series of endothelial keratoplasty that was named DLEC. These cases began the new era of modern corneal transplantation across the world. Over the past 20 years, he has pioneered developments in endothelial keratoplasty with over 150 peer-reviewed publications on DSEC, DSAEK, and DMEC. He's the president of the International Endothelial Keratoplasty Group, EKG, which was founded in 2002. And this group continues international collaboration in the development of EK. He has several awards to his credit, some important ones being the Lifetime Achievement from AAO, the Patent Award from the Eye Bank Association of America, and he's also a member with thesis of the prestigious and exclusive American Ophthalmological Society since 2007. He is a family guy. He's married to Cindy and has two beautiful twin boys, Charlie and Nicholas, born in 1988, whom he treasures. Dr. Terry, I've seen this every time he gives a talk. The last slide always has a picture of his family, whom he thanks for letting him take time away from them to come and lecture all over the world. We welcome Dr. Terry to give the HOA Professor Dr. Narendra Swarup oration, who very much like him was an avid teacher and was involved in research and academics for most of his career. He was a popular teacher, socially conscious person with a gentle personality, who also happens to be my grandfather. Welcome, Dr. Terry. I'd like to invite our president, Dr. Nandkishore, to virtually hand over the medal.
Professor Terry, it's our privilege to award you this oration. Please accept it on behalf of Hyderabad Ophthalmologists Association.
Thank you very much. Thank you very much. Wow, that's quite the medal and the casing.
Yes, and we also have a plaque for you. I'm not sure if you can see it. So these will be coming to you by post, and they shall be posted tomorrow.
That's going to be very expensive to send all the heavy weight.
Yeah.
Thank you very much.
It will be our privilege, and we are very, very honored that somebody of your stature is giving the oration this year.
Thank you.
Without further ado, I'd like to just ask you to go ahead and give your oration on the topic of the day, which is the continuing evolution of endothelial keratoplasty surgery.
All right, let me get this together here and move this over. Okay, let's see. Just give me one moment here. There we go. Is the screen sharing right now?
Yes, it's fine.
Wonderful. Well, thank you very much, Rishi. I do remember my trip to teach DLEC in India and how you were such a wonderful host and how you guided me around. You were a much younger man back then. I haven't changed, of course, in those 18 years, but it was my first experience in India, and I remember it very, very fondly. I'd like to thank you, Rishi, and Rajesh Vogla, my dear friend, for inviting me to give this talk. Before I do begin, I do want to go over the fact that I'm honored, very honored, to be able to talk in memory of Dr. Swarup. He was trained in the UK. I don't know if that was made before. And as you said, I understand he was a superb clinician and professor. But one of the aspects of him that got to me was the comment by many that he was loved by his patients and adored by his students. I don't think that a professor could have any better honor than that. All the awards that are given by societies don't compare to the ability to be loved by your patients and adored by your students. He did not go into cornea, which is unfortunate. I'm sure he did some cornea, as he did everything else, but he did specialize in squint and plastics. As was said before, he was a professor, and he founded the squint department and published his clinical research. He did have a lot of charitable and socially responsible work that he did. I found it interesting that he was the founder of the Lions Club in Hyderabad, because I'm very much involved with the Lions for the past 35 years. And it's a wonderful organization, and the fact that he helped to get it going in Hyderabad is very important. And then the work that he did when he supervised the camps and the rural eye camps was very important. My favorite of all the pictures that was sent to me was the fact that he had a family tradition. Family should always be a priority. We get so caught up in our work that I think that we need to always recognize those that support us. And he certainly supported his family. He founded the Swarup Eye Hospital. And I do believe that the distinguished service of ophthalmology is now carried forward by second and third generations of distinguished Swarup surgeons. It really is an honor for me to pay tribute to this incredible man. And I'd like to once again thank you for your kind invitation. Now on to our lecture. First, the disclosure is that I do have some financial interests. I received royalties on the DELEC instruments that I designed. Since no one in the world is doing DELEC anymore, those royalties no longer exist. I do get some financial unrestricted educational grants for my endothelial keratoplasty breakfast that I hold at the Academy each year. Well, I'm going to tell you something that's been my passion for the past 20 years, and that is the revolution in corneal transplantation, where we have the selective endothelial replacement. We're going to talk about going from DELEC to DESEC to DESAIC and then to DEMEC, and then something extra at the end. The evolution of endothelial keratoplasty has been truly remarkable. When you look at these OCT images of the evolution, we can really get a sense of where we were and how far we've come. If you look at the DELEC, this was a hand-dissected donor placed in a hand-resected bed. And the operation took about 3 hours, the first one that I did. And by the time we had done several hundred DELEC surgeries, we had it down to about an hour and a half or so. But it still was one of the most delicate surgeries I've ever performed, and remained that way even as I gained my skills. It was much improved when DESAIC came along, and no longer did we have to dissect a recipient bed. We could simply strip off Descemet's membrane, a far easier maneuver, and then just place the DESAIC graft on the back of the cornea like a wart. But when DEMEC came along, there were new skills to be learned, but also we ended up having perfect anatomic replacement. If you look at the DEMEC OCT looks exactly like a normal cornea. If I showed you two OCTs, you would not be able to tell the difference between one that had DEMEC surgery and one that was a normal cornea. That's how beautiful this surgery of selective endothelial replacement has become. I'm going to show you now a video, which is the very first endothelial keratoplasty surgery ever done in the United States. It was the second surgery in the world. Mellis had already done the first case in Amsterdam. And this is a video that I made in March 2000. That's 20 years ago, over 20 years ago. And I made this video, and it truly was a videotape that we made in those days, because I knew this was an historic moment, that we were doing the very first endothelial keratoplasty. And I want you to compare this, this technique of deep lamellar endothelial keratoplasty to DEMEC surgery and see how far we've come in terms of the level of experience needed for the DELEC versus the DEMEC.
Patient surgery was performed March 14th.
There's audio on this, so I'm going to let the audio go.
Portland, Oregon. This is a video of the very first patient done in the United States. The preoperative ring topography incision is made 1.0 millimeters posterior to the limbus with a guarded diamond knife.
Very large incision back then. 9 millimeters.
A stat incision is made through the limbus into the anterior chamber. In this patient study, Helon has been injected into the anterior chamber to fill the chamber and maintain pressure.
This is a Devers dissector we designed especially for the surgery. It's in the stroma. This is not in the anterior chamber.
Care is taken to ensure that the lamellar pocket reaches to every edge of the limbus.
So I'm creating a total lamellar dissection, limbus to limbus, in the deep
The
stroma.
tree fine is entered into the lamellar pocket. It can sometimes be a tight fit.
This is a specially designed instrument to get a trephination similar to what you would tree find on the surface, but to do it intrastromally.
And once centered on the cornea, the rotation along the arc of the incision is performed. Once the anterior chamber is entered, Helon can be seen to exit from the superior wound, and the tree fine is gently removed. A 75B replacement.
And these are the original Cindy scissors that we used to cut out the posterior layer.
These scissors can take us to the mid-distal area, but then special low-profile scissors are necessary to complete the distal cut. Once the disc is free, it is then pulled through the pocket and again placed upon the corneal surface to check for uniformity of cut and edge smoothness. A sicko needle is then used to completely evacuate the Helon from the anterior chamber and the pocket.
This donor's been
The
prepared.
Owsley insertion spatula is then coated with Helon, and the healthy endothelium donor disc is carefully separated from the overlying anterior stromal tissue and placed endothelial side down onto the Owsley spatula, protecting the endothelium with Helon.
That was
the
hand
Owsley spatula
dissected
is
as
brought
well.
into the operative field, and with air in the anterior chamber, it is gently inserted through the pocket into the anterior chamber, then brought up anteriorly until the donor and recipient interfaces adhere, and the spatula is gently retracted out of the eye, slide on the layer of Helon, protecting the endothelium. Air is immediately injected into the anterior chamber to stabilize the tissue into its NSS, and the pressure is normalized. An air bubble of approximately 90% the size of the graft is then left in place to maintain it. Immediate postoperative topography is seen to have a very round. This patient's postoperative recovery was quite rapid, and here we see on post-op day 13 that the central graft endothelium was working quite nicely, with a clear graft and a very stable interface. Indeed, the central cornea is clearer than the peripheral recipient tissue. The superior wound is healing nicely, and the compressive forces of the limbal sutures diminished considerably by the 3rd week. The Netherlands for his original work and development of this procedure.
So that surgery was very delicate and took a long time, and I was nervous during most of it. But it was so important to show the American Academy of Ophthalmology that at that meeting in 2000, that this surgery was possible and that we could move on from all the problems of penetrating keratoplasty to a new era of endothelial keratoplasty. Now, this is not the same eye that you just saw in the video. It's actually the 5th case in the United States that I did. And it's 20 years post-op. I saw this patient just a few weeks ago. And the vision was 20/25. The patient only had 3 diopters of astigmatism, and that's because of that very large incision superiorly. It was against the rule. But the endothelial cell count was 708. Now, the first 4 cases in the United States that I did, those corneas were clear until the patients passed away. The average age of these patients was 77 years old, and this is 20 years ago. So this patient did survive the 20 years, and now we have data, information, that these endothelial keratoplasties, even with DELEC surgery, survived at least 20 years. Well, we were very excited. I was extremely excited about this procedure. I knew that my DELEC results would be better, just simply because of the physiology of it and the anatomy. And what we found was that the visual rehabilitation for DELEC was in 2 months, not in 2 years, like it would be for a PK. Most importantly, these patients did not need a gas permeable contact lens needed. They often didn't even need spectacles. The average vision on these patients, because it was a hand dissected deep lamellar resection, the average vision was about 20/30, 20/40, but only 8% achieved 20/20 vision. They had a much improved quality of vision compared to PK because they didn't have that irregular astigmatism. This is something that surprised us, is that the rejection rate was reduced to 9%, whereas before it had been 18% of rejection rate in penetrating keratoplasty. And the endothelial cell loss was comparable to what PK was. Now, I went on to train over 70 surgeons, many of them from India, to do DELEC surgery. But actually, only about 15 of the 70 surgeons performed DELEC surgery. And when I asked them, why aren't you doing this surgery? It took so much time to train. And they said, well, we do agree that it is better, DELEC is better than PK. However, it's not easier and it's not faster. It took until 3 or 4 years later that DESEC surgery came on the fore through the efforts of Garrett Mellis. And in DESEC surgery, as you all know, the descemet's membrane is simply stripped off the recipient. No longer did we have to do that very tedious and very delicate dissection in the deep stroma, limbus to limbus, on the recipient. We now could simply just strip off the back surface of the cornea. And then we had to still do a hand dissected donor. But then with the use of microkeratome, that eliminated the need for the delicate dissection of the donor. And now we had DESEC, or decimate stripping automated endokeratoplasty. And this enormously improved the ease of the surgery. This is our standardized DESEC surgery. And we've done the same technique since 2004. We make a scleral incision because we want a larger incision for insertion of the tissue. And a scleral incision induces very little astigmatism compared to a corneal incision. And they strip it under Helon. It's not necessary to use an air bubble to strip the tissue. And then we scrape the periphery in order to create a rough surface in the periphery that allows greater adhesion of the tissue. We leave the central cornea very clear. We keep the cornea as small as we can, the pupil as small as we can. And this is our donor tissue. It's been cut with microkeratome. And there's the layer that we were going to transplant, the posterior layer. These are Charlie forceps to insert the tissue. We insert through a larger 5mm incision in order to not crush the tissue. And then the air bubbles put in place. We get rid of the interface fluid by sweeping the interface with a Cindy sweeper. And then we close the wound with 3 dissolvable sutures and cover it with conjunctiva. We leave an air bubble in there that's smaller than what we do with DEMEC, and the operation is over. Now, what has the literature taught us about DESEC inserters and DESEC surgery? Well, we have now the definitive study, the corneal preservation time study. And this study, led by Jonathan Lass, has taught us a lot about DESEC surgery. It's shown us that the method of graft insertion doesn't really matter. So there was a lot of controversy about, well, should we use forceps? Should we use pull-through? Should we use injectors? And the CPTS study, looking over 1,300 cases by very experienced surgeons, found that it doesn't really matter in terms of graft survival or the endothelial cell count of the tissue. But it doesn't matter what type of inserter you use. It's just important that you do it well. Now, there were other advances that made EK more acceptable than DELEC. DELEC never came to be a popular procedure because it was so difficult and took so long. And DESEC now started to take hold as a popular procedure because the surgery was vastly easier than DELEC. The other aspect in the United States, at least, was that we had to develop a new code, a new procedure code for this new procedure. It was so different from everything else, we couldn't code it as a penetrating keratoplasty. So once we obtained a code and we went through the bureaucracy of the American Academy of Ophthalmology and the bureaucracy of the American Medical Association, we finally got a new code for EK. And this allowed us now to actually bill for the procedure and be paid by the government through Medicare. And then other insurance companies follow. The other aspect that made DESEC take hold and become popular in the United States is that 2 eye banks in the United States, our eye bank here in Oregon and the North Carolina eye bank, they learned that we taught the technicians to pre-cut the tissue so the surgeon no longer had to take the microkeratome into the operating room and cut the tissue and possibly destroy it and ruin the operation. We could now have technicians before the surgery, day before the surgery, pre-cut the tissue. And this eliminated the risk of the surgery. It took the risk to the eye bank instead of to the operating room. So when we look at that comparison again, from the surgeon's perspective, before we compared DELEC to PK, And now we have the perspective DeSake versus PK or DeLeck, and the surgeons all said it's easier, it's faster, it's better. And that's what was necessary to get endothelial keratoplasty become an accepted operation. DeLeck was an endothelial keratoplasty procedure, but it could not be accepted until it was easier and faster, even though it was better for the patient. And so the factors for getting any new operation into acceptance is it has to be not only better for the patient, but it has to be easier for the surgeon and faster. And when DeSake became easier and faster than penetrating keratoplasty or DeLeck, that's when it took off. The pre-cutting and the acceptance by of the code had a turning point in 2011, where you can see DeSake started taking off and PK started going down. And it was in 2011 they crossed, and now DeSake in the United States, or endothelial keratoplasty in the United States, is a preferred procedure for endothelial disease. Well, what about DMEK, Descemet's membrane endothelial keratoplasty? Once again, if we look at the evolution of endothelial keratoplasty, the OCT shows us that we went from something that does not look at all like a normal cornea to something that looks much more like a normal cornea, but not quite because of the edges and the thickness, to some post-op result that looks exactly like a normal cornea. So the primary reasons for learning DMEK as opposed to staying with DeSake is that DMEK represents exact anatomic replacement. As I've always told my students, you know, we should always strive for what is been created. We should strive for what God and evolution have told us is best. If we can have what is the normal state, then we've really accomplished our goal of returning the patient to a normal vision, a normal life. We found that DMEK gives us better visual results than DeSake. We may not measure it all the time in Snellen visual acuity, but we do know it's better in terms of aberrations. We do know it's better in terms of color perception. All the qualitative aspects of vision with DMEK is better than DeSake because of the normal anatomy now. There's definitely a faster visual recovery with DMEK than with DeSake. And what was surprising again was that we had a lower rejection rate than DeSake. If we look at the rejection rate, it's less than 1% in the first 2 years after DMEK surgery. What's even more remarkable and more compelling about DMEK surgery is that we can get 94% of our patients off steroids at 1 year, and that's huge. Now, there's been explosive growth in DMEK in the United States, and it's catching up to DeSake. However, when we look at least 2018 and still 2019 of the Eye Bank Association of American Statistical report, we do see that EK now far outstrips PK in terms of endothelial replacement. However, when you look at DMEK, DMEK only makes up 21% of the corneal transplants, and DeSake makes up 38% of all corneal transplants. And if you look at the popularity of DMEK in the United States in terms of the total EK procedures in the United States, 30,000 cases of EK procedures, DMEK only makes up about a third of those, even though it's now 2020 and it's still stuck at about a third, maybe slightly larger. Well, this is odd to me because I've always wondered why do surgeons do what they do? Why do some surgeons do one operation and others will be an entirely different operation for the same condition? Why aren't we all doing Descemet's membrane endothelial keratoplasty when we know it's a better procedure for the patient? Well, let's go back to this question. And we've asked it of DeLeck versus PK, and then we asked it of DeSake versus DeLeck and PK. And from the surgeon's perspective, when you ask them about DMEK versus DeSake, well, they'll say, yes, we agree with you, Mark. We agree with you that it's better for the patient to do a DMEK than DeSake, but it's not easier and it's not faster. And so once again, as we go through the evolution of any new procedure, you have to make it easier, you have to make it faster, or surgeons will not accept it. And you have to make sure that it's paid for. Well, at Devers Eye Institute, Lions Vision Gift, or eye bag, we've been trying to make it easier, faster to standardize, as have others around the world. And so what we've found is that if we have pre-stripped tissue, just like when we had pre-cut tissue for the sake, having the tissue already stripped for the surgeon by the eye bank is a huge barrier to acceptance, overcoming a huge barrier. We then put a stamp, either an S or an F stamp, and this is also provided by the Lions Vision Gift or the eye bag before the surgeon even gets the tissue. The technique, we've learned things from our colleagues. Friedrich Kruse has taught us that if we overstrip the recipient by just a little bit, we will have a bare stromal surface to put the new graft on, and that preventing that overlap will help to prevent rebubbles. We've learned from Mellis that we need to have a glass injector to have the easiest time of it, and Mike Stryko, my associate at Devers, has developed a wonderful glass injector, as have others. There's many techniques for unfolding the tissue. We found for Edville Urick developed a technique years ago of a no bubble tap unfolding technique. And Jose Guel from Barcelona has shown us that if we use SF6 instead of using air, we have longer support of the tissue, and this can reduce our rebubble rate. So this is what happens now in the United States for most of our surgeons now. We make DMEC even easier and faster by having pre-stripped, pre-stained, pre-marked, pre-trephinated, and now pre-loaded tissue, so that when I obtain my tissue, it looks like this. It comes already in the glass injector, already stained, stamped, ready to go, patient ready. So now what is DMEC surgery like for us? Well, it's a clear corneal incision instead of a scleral incision. Instead of that large 9mm incision we were doing for DLEC, it's now a clear corneal incision. It's 3.0mm or less, depending on the injector you use. Most of the other steps leading up to injection of the DMEC tissue are the same as the sake. You score and strip desiccated membrane. We do this over Helon, not over an air bubble. It's much easier over Helon. And we overstrip, not understrip. We do place an inferior peripheral rhodectomy because this is needed to avoid pupillary block. Even with an inferior PI, you can sometimes get a reverse pupillary block, but that's very rare. We prevent upside down grafts, and this is critical because even in the best of hands, a surgeon can sometimes mistake the DMEC tissue for being right side up when it in reality is upside down. And that's a terrible surprise to have the next day. So we never have upside down grafts at the end of surgery because we have a mark showing us which side is which. We use the SF6 gas, and the gas bubble size is 90% fill of the chamber. And we always make sure that the peripheral rhodectomy inferiorly is uncovered when the patient's in the upright position. If I were to give one tip on how to avoid complications to DMEC, I'd say go to this website. This is a free website. It was developed by a former fellow of mine, Peter Veldman, who's now at the University of Chicago. And in this website, he has beautiful drawings and live videos or videos demonstrating the common tissue conformations of the DMEC tissue. After you inject the tissue, it can take these shapes. And he gives you a step-by-step method of unfolding the tissue, unscrolling the tissue, so that you can have successful surgery. So I can't emphasize enough that this patientready.org website, I find, is just a superb teaching tool. Now here's an example after the tissue's already been sent to us. This is when we were stripping our own tissue, but I've stained the tissue, I'm aspirating it up. I want to show you in this video some of the tapping techniques that we do. And so we take this glass injector, we're putting it through the incision. And once we're in the eye, we tend to rotate the injector so we can get it right side up. And then we'll slowly inject the tissue. Now the key on this is to make sure that the chamber is shallow before you take this out. But we can see we've already had shallowing from the peripheral paracentesis sites. I don't always suture the wound first. I'll sometimes leave it open. And then we're going to get this tissue to unscroll. We'd like to make sure it's in the proper position. And so I'm releasing some fluid here to shallow the chamber, The The key to the surgery in my mind is a shallow chamber. Now this would be easy to unfold, but I went for a double scroll. I'm shallowing the chamber. If you don't have a shallow chamber, you can't unscroll the tissue well with this injection technique. We're tapping the periphery to open by pushing fluid through the scroll to open it up. We're compressing and releasing at the other side to move the tissue over. So we're creating fluid waves to move it one way, and we moved it too far, so now we're going to move it the other way by compressing. And this is just creating fluid waves to move the tissue about. I can release some fluid from the main wound gently, and that opens up an edge. I can tap at the at the periphery and these fluid waves, or I can compress and release the periphery. I can shimmy. I can create a vibration of fluid waves. And once I'm getting it all centered up, if I like the centration, then I can put a very small gas bubble and then expand it as we go. We want to keep, I released a little fluid there to open that edge. And we want to keep the eye in primary gaze, and we have that open. This edge can be taken care of over here by simply releasing some of the gas and then tapping that out. Now here's that same case. This is 3 weeks post-op, and the vision was 20/20 + 1 with no glasses at all. And this is the kind of result that you can get with DMEC. Obviously, it's a great example of a great case, but we don't see 3-week post-op vision like this very often with DSAIC or with other forms of endokeratoplasty. Now, there are challenges and complications with DMEC. It is a new skill set. DSAIC skills do not transfer. You gain a little bit of appreciation of air bubble use and gas bubble use when you're doing DSAIC. However, if you think that if you're a great DSAIC surgeon, it doesn't mean that you'll be a great DMEC surgeon. You still have to learn these skills. You need to learn to open the graft with tapping and fluid waves, which you don't need to learn with DSAIC. And you need to keep the chamber very shallow with DMEC, whereas you would like to have a deep chamber with DSAIC. Postoperative interface fluid with graft edge separation is common in DMEC and not with DSAIC. You get a higher rate of rebubbles with DSAIC, but it's much easier to do because with DSAIC, the tissue is floating in the anterior chamber when you go to rebubble, and you have to reposition it, get the interface fluid out. With DMEC, the tissue only has part of it down from the cornea, and the rest of the tissue is attached. So it's simply a matter of just putting another air bubble in there. And DMEC challenging is challenging in complex cases. So I do not do DMEC in aphakia, ACI wells, and tubes using an injection with tapping technique. You need to use a pull-through technique in order to be using it DMEC in those cases, or you can simply do it DSAIC. Now, there are other popular techniques of DMEC that I mentioned. One is the endo-in pull-through DMEC, and the other is PDEC, which is very popular in India, and Amar Agarwal has been a proponent of that for many, many years. I'd like to thank Rajesh Fogla for this video of an endo pull-through technique using an IOL injector. I could probably have Rajesh right now give the narration on this. But as you see on this, after the tissue's been stripped, you pull it in, and you might have a little helon on the endothelial layer. This is then pulled into an injector. Good morning, Daddy. Good morning, Nicholas. And after the injector is put in the eye and it's pulled through with the anterior chamber maintainer, and then with simply tapping and keeping hold. And the key on this is to make sure you don't let go of that tissue until you have an air bubble to support it, and then simply tapping. And this was a case, I believe, with an ACI well. And then the air bubble is placed. Now, this is the endo-in technique, the video courtesy of Donald Tan, using his endo injector. And this, he's taken the
desake tissue that has also got the pre-stripped DMEC over it. And he's using the desake posterior stromal layer as a carrier for the endoglide. So he's pulling both the posterior stroma and the desmase membrane into the endoglide. And pulling it across. Notice that the fluid has been evacuated now. Now he's got an anterior chamber maintainer, as you can see, and he's going to pull both the stroma and the endothelial layer toward the anterior chamber, but then he's now going to grasp just the desmase membrane, and he's going to pull it off of the posterior stromal layer and pull that into the anterior chamber. Got the anterior chamber maintainer on. And once again, the key is do not let go at any time. And then when he pulls out the injector, a little bit of fluid, a little bit of tapping, and then he puts a gas bubble or air bubble underneath it. And now you can let go here. He's going to actually get the edges open. And then let go of it. And your tissue's in place. With the pull-through technique, you are allowed to do more complex cases. Well, which technique is better? I mean, we've got people that do pull-through, people that do tapping. There was a beautiful article by Marianne Price in Cornea 2018, where they looked at 754 cases, about half and half of the tapping technique and the pull-through technique. And the rebubble rate was the same, the endothelial cell loss was the same, and their unscrolling time was the same. So the bottom line on this is either technique works well. The surgeon's comfort level is the most important. Now, what about PDEC? I'm sure in India that there's been much more presented on PDEC than I can ever present. And you know that it's Dua's layer with desmase and endothelium of the donor tissue. The tissue is prepared using posterior layer air injection, staining, and scissors. And the insertion technique is similar to endo-in DMEC with a pull-through technique. It can also be injected as well. Now, some advantage of PDEC over DMEC. DMEC can be used in all types of cases, endothelial replacement, routine cases, and very complex cases. PDEC allows easier opening of the scroll tissue because it has that posterior layer, which gives it a much stiffer conformation. And PDEC allows even very young donors to be utilized. In our practice, we do not do DMEC with donors that are younger than 40 years old. Now, we have occasionally used a 20-year-old or a 28-year-old, but it's much more difficult with those younger tissues, whereas PDEC allows very young tissue to be used. Huge advantages. There are some advantages of DMEC over PDEC. DMEC tissue is pure anatomic replacement. And I still believe that if we have just desmase membrane replacing just desmase membrane, this will give you less higher order aberration than donors that carry any stroma, even Dua's layer. There's less risk of interface optical distortions. DMEC donors now can be completely prepared and preloaded by iBank and then sent to the operating room for use by the surgeon. We do not have that capability at all the iBanks for PDEC in the United States. Stripping of DMEC tissue is less complex than preparation of PDEC. If you look at the way PDEC is produced, it is a more complex technique of harvesting that tissue. DMEC surgery is now standardized with an early easy learning curve, and DMEC now has a large volume of peer-reviewed literature. And although the literature is growing for PDEC, there's much more peer-reviewed literature on DMEC than PDEC. Well, what about treating endothelial dysfunction? We talked about endothelial keratoplasty, the progression of that, but now we're moving even further. What about endothelial dysfunction that's treated without a transplant? Well, there's desmase stripping only, DSO of the central, excuse me. Cindy, could you turn that down, please? I'm sorry, my family. So desmase stripping only is where we strip the central 4 millimeters, and we use a ROCK inhibitor, Repositil drops, which is medical stimulation of endothelial migration and mitosis. Now, the big limitation of DSO is that it's not effective in pseudophakic bullous keratopathy. You must have that peripheral reserve. And I know that in India and many other countries outside the United States and outside of Europe, that the primary need for endothelial replacement is pseudophakic bullous keratopathy. But in the United States and much of Europe, when we're looking at Fuchs dystrophy as our primary cause of endothelial dysfunction, we can do Descemet's stripping. And it's important to recognize that it doesn't work in all cases, and probably because not all Fuchs dystrophy is equal and the endothelial reserve is not all equal. In this case that I did a phaco first, and this is my capsulotomy line right here. And the Descemet stripping line is right here. And it's very simple to fill the chamber with Helon. And after we've done the phaco through the same wound, just strip off the central 4 millimeters. It's important to mark the center of the cornea at the slit lamp before the patient is dilated. Place a mark on the center of the cornea in the center of the pupil, and then you will be able to use that mark for your Descemet stripping only. And to strip just 4 millimeters, maybe 5 millimeters, but much more than that, and you start getting failure with DSO. Well, this is that same patient you saw the slide on. This is 1 week post-op. And the vision without glasses is count fingers. And you have to really prepare the patient for that. You have to let them know that you cannot have vision until the stromal edema is gone. And the stromal edema is severe. And look at the macrocysts here. This is a function of rapazidil. Little microcystic edema of the epithelium will turn into macrocysts with rapazidil on board. This can be quite irritating the eye. But then 4 weeks post-op, look at this cornea. This is a normal cornea, and the endothelial cells have filled in all this massive area of edema. And the patient now has 20/20 vision with his own cells. The endothelial cell count at 4 weeks post-op is 625, and I just saw that patient 1 year later now, and the vision is still 20/20, and the cell count stands around 600 to 700. But these are his own cells, and he'll never have rejection, and etc. You know, all the reasons why DSO is a good idea for selected patients. Now I'd like to move on to the final section on here and just talk to you about an innovative transplantation technique for endothelial failure, and in the setting where there are multiple limbal melts. So I see some of the most fascinating complex surgery videos I've ever seen in the world coming out of India. And I'm probably bringing complex procedures to people that are already doing a lot of this. But for me, I think that a new approach to very devastating cases where it's not only endothelial failure, but there's extensive necrosis and extensive thinning of peripheral cornea. This technique that I've been working on the last couple of years has been helpful. And I think this is a hybrid transplant. And this is where, when I say it's hybrid, because we're combining DALK surgery with PK in the same operation on the same eye. But it's not the donor tissue that we're doing the DALK and the PK on, it's the recipient bed. So when do we do hybrid surgery? Well, it's for cases that require a 10 millimeter or larger graft. So I'm not advocating this hybrid surgery for standard cases of endothelial replacement or melting, but it's for when you have extensive melting and you have extensive extreme recipient corneal thinning that involves areas in the periphery where you normally would be passing your sutures for a PK or a DALK, and there just isn't enough tissue out there, or there's a big hole in the periphery. And these are the kind of cases that are just total disasters. In addition, these cases have marginal central endothelial function or even central necrosis and holes. So for instance, what do you do with a cornea that looks like this? This is a patient that had strep ulceration and was treated for a couple of days with vancomycin and fortified antibiotics. But then she perforated. And when we look at this, there's very little limbus left. And if you look at a schematic, it could be extensive thinning where you don't have anywhere you can suture, and you have to do a very large transplant. So what if you just do a full thickness transplant? Well, here's what happens. If you cut out in the sclera, after you recess the conjunctiva, if you cut a full thickness scleral trephination or near full thickness, and then you take off all that necrotic tissue and you put on a full thickness transplant with the endothelium, what happens is the iris will come up, and the iris will come up and obliterate your angle. It'll also steal all those endothelial cells from the center, will migrate onto that iris. And you'll get absolute glaucoma and absolute endothelial cell loss, forcing you to do a penetrating keratoplasty later after you've already treated the patient then with glaucoma tubes and trabs and everything else. So if you do a full thickness penetrating keratoplasty on a 10, 11, 12 millimeter bed, you're going to end up with multiple operations in the future. So what is a hybrid transplant? Well, it's not about the donor tissue. A hybrid transplant is about the recipient bed. So a better way to treat these disaster cases is to cut down to about 100 microns left of the stroma or the sclera. Carry out your dissection as you would with a dowk, creating a flange, creating a peripheral area of corneal tissue that is only 100 microns or less of tissue. It doesn't matter if this is healthy endothelium or not. Just create a stromal bed of tissue for 360 degrees. And then take a donor that is, if it's a 12 millimeter bed, a 13 millimeter donor, not the same size, not even a half a millimeter, but a full millimeter larger. And keep all of the endothelium on the donor, keep the entire thickness of the donor, and place this into the bed and suture it in the sclera. So when we're thinking about doing these large transplants, we have to evaluate what is going on with the recipient. If the recipient endothelium is healthy all the way across, and there's no central scarring and no central necrosis here going through the endothelium, then we can simply do a large lamellar graft and rely upon the endothelium of the recipient to detrigest our large graft. That's just simply a very large lamellar transplant. But if you have endothelial cell loss, or you have holes here and here and here, then what we can do is create those flanges, the DALK in the periphery and the PK in the center, and put the entire graft on top. And this will now allow the angles to remain open. So a 13 millimeter full thickness donor with endothelium onto a 12 millimeter bed, leaving these flanges to preserve the angle. And if you do this, your final result will be that the flanges will adhere, or sometimes they don't adhere to this, but they don't come down onto the iris either. They simply are sticking out into the aqueous. And we leave our angles open, and we have the endothelium of the donor now to give us a beautifully clear cornea. So the characteristics of the hybrid transplant are the endothelium is retained on the graft, the entire area of the graft. The graft is 1 millimeter larger in diameter than recipient bed, and we don't modify the edges of the graft. We simply just take the entire thickness of that. Whatever recipient limbal epithelial stem cells can be saved. So I didn't mention this, that we do want to save, if we have a graft that's not purulent all the way through, if we have a recipient bed that doesn't have necrosis everywhere, we want to save whatever epithelial cells are on the surface of the recipient and recess those back before we do our large trephination. It is necessary to use 9-0 nylon sutures to those scleral edges to approximate them, because 10-0 won't hold. Then we cover the edges with the recipient conjunctiva and the recipient stem cells. And I also put an amniotic membrane on top, and oftentimes a tarsorrhea in these very sick eyes. So let's get back to that case. Here's this horrible looking case. And we recess the conjunctiva, saving whatever stem cells there might have been up here as much as we can. A 12 millimeter diameter deep trephination and deep lamellar dissection, leaving 2 millimeters of the flange here. So this is 2 millimeters. And then the 8 millimeter penetrating trephination. And then we take off all this stuff and we put on a 13 millimeter graft, suturing the sclera down and then bring the conjunctiva over it. And what happens is you can take an eye that looks like this, and 3 months later, you've got an eye that looks like this, where the vision is now 20/60 without glasses, because these are far peripheral sutures and they have very little compression of the central cornea, very little induced astigmatism. And importantly, the angles are open. So you see that this flange here, this Dowk area of the periphery has allowed the iris to stay back. And now the pressure is 16 on no medications. Well, the advantage of the hybrid transplant over the PK is the 13-millimeter hybrid transplant will preserve the angle. A 13-millimeter PK will not preserve the angle. The hybrid transplant avoids extensive iridocorneal adhesions. You get retention of the transplant endothelium, and this allows corneal clarity. Even if the peripheral flange does not adhere and the flange is coming down, you can still have corneal clarity all the way across because you preserve the endothelium on that donor all the way across. The astigmatism is low because of those minimal compressive sutures, and you have a rapid edge healing scleral edges because it's a vascularized edge. The big question, obviously, in all large transplants is what is the rejection rate going to be of these large lamellar grafts? We can tell you that we have had 1 out of 5 had rejection, and we were able to reverse that rejection by using heavier topical steroids. We have not been using systemic steroids or systemic immunosuppression for these grafts. That certainly can be done if we find over time that our topicals do not work. Well, to conclude this large lecture on endothelial evolution, endothelial replacement evolution, I'd like to give the final comments that we truly are in the most exciting age of corneal transplantation there's ever been. The rate of innovation, think of this, just think of this. The rate of innovation surgical techniques has accelerated exponentially in the past 10 to 20 years. And I truly, as an older ophthalmologist now, I envy today's residents and cornea fellows. I mean, my God, you've got the brightest future in cornea that's ever been in the history of cornea. And it's also challenging, but it's so exciting. And what I would recommend to the residents and the fellows is you should embrace this challenge. Think of where you can make a difference and make that difference. Well, as Swesha said, I always pay tribute to my family because they're the ones that allow me to be here and talk with you and spend time away from them. So thank you, Charlie. Thank you, Nicholas. And thank you, Cindy, for allowing me to have this early morning giving the talks. And I thank them for supporting me all these years. And I thank everybody at the Congress for your kind attention to this lecture. Thank you. It's been an honor to be here with you, even if it is virtual. Thank you.
Thank you, Dr. Terry. That was a fabulous oration. It's just no words to express how amazing it was. And I think the last message you gave for the younger new cornea specialists who are coming into the fray, I think it's a very good message. And it's truly an exciting time to be a cornea specialist. Thank you for honoring us with this oration. And I'd like to let Dr. S.K. Mittal, who is part of our organizing team at HOA, give the final closing comments and vote of thanks.
Good evening, everybody. I, Dr. S.K. Mittal, Joint Secretary, HOA, feel privileged to propose vote of thanks on this occasion on behalf of HOA and HOA VISTA Organizing Committee. I extend my sincere thanks to distinguished national, international faculty for sparing their time in spite of their busy schedule and odd hours in various countries because of the difference in the clock. A special thanks to Dr. Narendra Swarup Oration Awardee, Professor Mark A. Terry. I extend my sincere thanks to all national faculty, keynote speakers, session coordinators, panelists, and all speakers for providing this academic feast by sharing their experiences in their respective field and making this event interesting and memorable. I thank all the participants, delegates for making this HOA VISTA 2020 a very successful event. My sincere thanks to our digital partner, Hallmark Events, for with their support, we could get connected with all of you. I wish from my core of heart, my thanks to our business associate sponsors. With their support, this event has reached to a new height. in the last but not the least, I expressed my deep sense of appreciation to our president, vice president, advisor, secretary, and whole organizing team. We wish and we hope to meet you all in our subsequent meet, and I wish you all a very happy New Year 2021. Thank you.
Thank you, Dr. Mittal. I think that is perfect. And
Malika is missing.
Yes, Dr. Terry, we'd just like you to hold on for a minute. We want to take a picture with you, virtually at least.
Okay. Done, doctor.
Perfect. Thank you so much.
Thank you, Rishi. This was
Thank
really
you,
a
Dr.
pleasure.
Terry.
Thank you, Professor Terry. It was great having you with us. Wonderful lecture.
Thank you
one of the
so much. It was nice to see all of you, even if it was virtual. I hope the next time that we can spend together having some coffee and some smiles.
Sure, sure.
Thank you, everyone.
All right, take care now.
Thank you, everybody.
Bye-bye, Rishi. Thank you again.
Bye-bye. Bye-bye, everyone.
Good night, all.
Good night.
Are we offline?
Thank you, doctor.
No, we are still online. I think on behalf of HOA, I think it's my duty to mention special thanks to the Hallmark team, Sheshadri, Vinay, Peshwa, and so many others, Deepthi and all who have been with us throughout. Done a wonderful, great job, and I think we encountered much less glitches than a physical conference. So I think it was a great effort overall. I think you have found us equally comfortable to work with.
Yes, doctor. Yes, doctor, very much.
Anybody wants to say something? Please add.
Yeah, I just wanted to say that the support was excellent, and thanks for prompting us and putting up with all our nakras and last minute demands and commands. And I think you guys have just helped made it so comfortable. Thanks for all the posters. I think they were very well done, and continuously following up. I think we got a lot of registrations because we had you. On our own, I think even if each of us had individually pushed it, I think it wouldn't have reached the stage. So it was seamless in that way. Yeah, thank you.
Thank you. Thank you, doctor.
Thank you, thank you, Sheshadri. Thank you, Vinay.
Thank you. Thank you. Thank you, sir.
Thank you so much.
Thank you, doctor.
Bye, everyone. Bye.
Bye.
Hi, Grover team. Hello.
Yes, sir.
Thank you so much, all of you. I think Anup, I know from Holby, and who was in Holly?
Pratap, sir.
Pratap, Naresh, and your boss, Abhishek, everyone. I mean, whoever was with you to make this HOA successful. I mean, Hallmark says thanks to you.
Thank you, sir. Thank you so much.
Wonderful, wonderful support, wonderful cooperation. You know, last minute of our giving of good support, and we continue our relationship. It goes on.
Thank you so much, sir.
Thank you, thank you. Bye.